Colleagues, the Senate Finance Committee is now in session, and the first bill that we will be hearing is Senate Bill 868, Senator Lee. If you want to come to the witness table, our sponsors have as much time as they need to lay out the parameters of their bill, and if you have witnesses are getting 2 minutes each. Let me call up the panel that we have following Senator Lee. Serena Lowe, Alicia Warpat, Alarise Vandel de Palacios.
Lisa's on her way, but she's not here yet, but she's coming.
All right. Now, those mics are movable, so if you sit near one, you can move it back and forth. All right, and you will have 2 minutes each. Senator Lee, you're on.
Okay, I'll try to get through this too, but this is a...
I have 124 people that we do to hear today, so we want people to be ready.
They're ready, Madam
Okay.
Chair. They are ready.
All right.
And this is a very important bill. SB 868, Self-Direction Act of 2022, addresses issues that we have been trying to resolve for 3 years. This bill resulted from a summer study, as you remember, completed by the House HGO Committee on DDA's self-directed option for Marylanders with developmental disabilities. The complete report has been submitted to you, the committee. You can look at it later. The bill is meant to codify elements of the program which have been threatened since 2014 when the self-direction waiver New Directions was combined with the waiver, which previously only included provider-managed services. The bill does not seek to add new elements to the SD program, which was initiated by participants and family advocates in 2005, only to restore what has been lost and to protect other provisions that have been at risk for years. But Maryland self-direct individuals are doing quite well these days, and the program continues to grow. Through the pandemic, because they employ family members, self-direct individuals dare well not facing many upheavals and having, measurably better health outcomes. However, family staff has been threatened for at least 6 years. This bill codifies hiring a family member as staff is and will remain an option for self-directed individuals. Recent changes by the DDA have allowed participants to achieve financial parity with their provider-managed peers. This change has allowed participants accustomed to sacrificing goals and services to enjoy greater access to the services. And other admirable changes include monthly meets between DDA and the representatives from SDAN, and as a result, implementing several improvements. For example, a revised agreement which is based on the supported decisions-making model that SDAN has requested for years, which protects participant autonomy. Additionally, after SDAN pleased to restore the overnight support program cut in 2018, 4 days ago, Deputy Secretary Simmons issued a memo notifying participants that the overnight supports are available under the waiver funding. So you may ask why this bill is necessary. There are really 2 reasons, and one, there is still much lost ground that must be recovered, including DDA policies that minimize the role of the support broker, the linchpin of the New Directions program. The support broker is the only team member specialized in self-direction and is critical to those who lack a strong family support network or come from very disadvantaged communities. The second reason for codification is that the DDA, like many other state agencies, full of devoted employees who are overworked and consumed with distracting tasks that reduce their interactions with the very people that they serve. And since 2016, DDA has attempted to eliminate the following: participants' right to hire family, the choice in physical management services, personal supports altogether, and independent support brokers. And DDA has tried to impose the following competency tests: the relinquishment of participant budget and employer authority to one representative, and the forcing of participants to seek supports from another state program not intended for Marylanders with intellectual and developmental disabilities. And since 2016, the small group of volunteers has countered the state and worked to restore the original version of the self-direction. We appreciate the DDA willingness to evolve, but the participants should not have to rely on a small group of volunteers or to hope for goodwill of a few DDA administrators. This bill will ensure that Maryland DDA administrators maintain the flexible person-centered program as envisioned and allowed and funded by the Federal Centers for Medicare and Medicaid Services. Regarding the, I just want to just address some points. Regarding the rebutting the physical note, DDA must complete the renewal and have CMS approval for Community Pathways waiver by July 1st, 2023. This bill only moves that deadline up by 6 months. And if DDA needs to contract with additional staff to make a few changes required by the bill, that same staff would also work on other aspects of the renewal, the waiver renewal. The actual cost of implementing these changes into the new waiver is far less than the Maryland Department of Health, OLS, estimate. And DDA already conducts regular training for coordinators of community services and support brokers. Further training could be seamlessly implemented without little cost. And SDAN already meets with the DDA regularly to supply with detailed recommendations at no cost. And finally, nothing in this bill is meant to increase funds already earmarked for the participants' needs by the state. It gives them flexibility in the use of and access to the total amount of funds allocated for their supports by the formula used for all budgets. The amendments made to the original bill attempts to clarify this intention. For these reasons, we urge a favorable vote on SB 868, and I'll turn it over now to my esteemed panelists.
Okay, and panelists, you have 2 minutes each. You may go in whatever order you think is best so we understand the bill. Okay. All right, don't touch the mic. Don't push the button or anything. It's on. You can slide them back and forth so they're near your mouth. Okay.
Thank you. Thank you, Senator Lee. Thank you, Chairwoman and the committee. My name is Serena Lowe, and I would like to offer my strong support for the Self-Direction Act of 2022. From 2015 to 2019, I served as a senior policy advisor for the Administration for Community Living at the U.S. Department of Health and Human Services. And in this capacity, I was ACL's primary liaison to the Centers for Medicare and Medicaid Services Home and Community-Based Services Waiver Program. In this capacity, I provided technical assistance to all 50 states, including the state of Maryland, and the District of Columbia in the implementation of the federal regulation governing the provision of federally funded Medicaid home and community-based services and the expansion of self-direction services. Later this rule, published in 2014, established the first time a set of criteria to assure that qualifying individuals with disabilities have access to an array of services and settings are integrated in and supports access to the greater community and optimizes individual initiative, autonomy, and independence in making life choices. Later in 2014, CMS also issued guidance on the implementation of Section 2402 of the Affordable Care Act, which outlines standards for self-direction and person-centered planning in programs like home and community-based services. In 2021, I served as a technical assistant to the Self-Direction Advocacy Network of Maryland and served on the Maryland General Assembly's work group to review and recommend policies for the Maryland Self-Direction Program. In its deliberations, we did determine that the introduction of various policy changes in recent years to the self-direction program had the effect of creating unnecessary administrative burdens on individuals and families, which this bill will seek to address. Noting in the nothing in this legislation from my analysis shows that this would impact the federal funding for the home and community-based programs and the state's existing federal match. And I'm happy to answer any questions at the end.
Okay, let me just start with one. What would you say is the main ongoing problem that the DDA community is experiencing, which this bill will cure?
Well, I think that the program, when it was first created in 2005, was actually a model for the country. But since then, there's been a number of introductions, policy changes that have limited how individuals can use the funding that's applied to them, the types of services that they actually have access to. And it really seems to be a pattern of policy changes that almost discourage, frankly, or even prevent people from adequately taking part in the program. If you don't have really strong natural supports and resources to help you guide through this process and navigate it, you're not able to be successful in this program. And the reduction of things like access to support brokers to only 4 hours a month, that makes it very difficult and creates, I think, a system of inequity for people who really need that extra technical support to succeed in directing their own services and hiring and firing their own staff.
And most people want as much autonomy as they can.
That's
handle.
correct. Yes, ma'am. And I just want to say one other thing on that, which is that all of the research across the country and in the state shows that time and time again, people who are on self-direction actually do not spend the full budget that they're typically given. It's actually a cost-effective way to help people stay in the community and out of institutionalization.
Thank you. All right. Senator Clausen.
I know you said you were through the whole United States, and at one time, this program was like the top Cadillac of the country.
That's correct. Yes, ma'am.
And are there other Cadillacs out there now that we are just a whatever, a Dodge Stratus, like I have?
Well, I think there are some really troubling policies related to, again, not being able to access support brokers who have the technical expertise to support people, not being able to have overnight supports or hire your own overnight supports, forcing you to go to a provider agency. That's the antithesis of self-direction. Those types of policy introductions has definitely declined the quality and certainly the flexibility and access of this state program compared to other states.
But originally, the parents were allowed to stay the night with their children and get reimbursed for that.
That is correct, and that is also something that is not abnormal. It's something very typical in many other states.
In other states. But now they have to go and hire somebody to take
Well,
that.
well, the state, after a lot of pressure over this past year, has decided on a case-by-case basis, sometimes they do pay for it. But what's interesting, what might be of interest to this committee financially, is that they, even after getting confirmation from CMS that they can draw down the federal match for this, they're still using state-only funds, my understanding is. So they're not even getting the federal match to support
So
this.
if we got a match, we could do that.
Yes, they're doing it now on a case-by-case basis due to pressure from the advocates, but at one point they were not, my
I hope we
understanding.
get pressure from the legislators because this has to be fixed. So.
Okay. With your reading of the bill before us, will we have a cure for this particular problem?
Yes, in my estimate, you will.
Okay, thank you. All right, who's going next? And just state your name, and you have 2 minutes.
Hi, my name's Alicia Wopat, and I want to give you my heartfelt appreciation for your attention to this bill today. I'm a member of the Summer Study Work Group. I'm on the SDAN board, and I'm a parent of a young man in self-direction. This bill, I think you've heard, seeks to return to the flexible and person-centered nature of the original program. It will provide better equity by codifying policies and allowing CMS-approved services. It's going to allow families like ours to set up a program for when they're unable to provide gratis services for their adult children. DDA tells us that an approved budget for a participant that uses the DDA's formula is earmarked for that individual for the entire fiscal year. And this bill is intended to provide access to that money, not additional funds. So we are trying to address the arbitrary caps and Maryland's choice to exclude certain services to the self-directing community. There really is nothing new in this bill, nothing that advocates and stakeholders haven't been saying for years, time and time again. This summer at the summer study, the chair expressed her desire to resolve the issues, and at the conclusion, MDH expressed appreciation for the opportunity to continue working with us. So there were no resolutions offered. You heard from MDH, probably in the letter today, that they have agreed to some of the things, and we're grateful for that. These concessions have come after years of advocacy, and over the years, many of the policies we thought we won, we had to refight again. So this bill comes to codify these important policies and services, and through not just this administration, but future administrations. In other words, we had it, we lost it, and we need it back. Thank you.
And it needs to be codified so people aren't making a lot of dumb discretionary moves.
Exactly.
Okay. All right. And Sabrina?
Alaris.
Oh, okay, okay.
Good afternoon. My name is Alarisa Vidal de Palacios. I am an independent support broker and advocate. I'm also the parent of a specially enabled individual who is a participant in the DDA self-directed waiver. My agency, Consulta, has represented and advocated for over 100 families and their stakeholders. Consulta currently provides active brokerage service for 60 participants, their family members, and their support providers. Consulta has active cases in all 4 regions where DDA has offices. Since our inception, our business niche has been to represent families whose origins were not of the U.S. Here we are years later, and the result is we are a solid organization that represents many individuals with multicultural backgrounds and varying degrees of financial status. Over the last 3 years, we have observed increasing variation in the self-directed service delivery model, specifically access of services by individuals and their families of cultural and racial groups. The lack of access, we noted, were simple barriers. 1, lack of information or inconsistencies in the information provided. Lack of qualified DDA agents who fail to thoroughly understand the programs. Straight determinants in the form of steering families away from self-directed services. And lastly, through language, the universal connector. Although DDA has translation services, many families still miss an opportunity to connect because the DDA agent does not access the translation services in order to be able to better express the services to the families. Equality and accessibility of service are further driven apart by the functionality of the DDA regional offices, which all fail to have a minimum standard of cohesive operation. Simply put, each regional office oscillates in different directions, resulting in prolonged access and denial of services to qualified individuals.
Thank you. Thank you very much. Okay, now let's go to our next panel. Robert Stone, Geneva Stone, Sonny Seferati, and Margaret Carter. You have 2 minutes each. Are all of those persons here? It was Robert Stone, Geneva, Sonny, Margaret. Are they all here? Okay. You will have 2 minutes each, and the mics, you can move them up and down along the table. Put them near your mouth and have them nice and high up so that we, yeah, okay.
Who's going from his microphone up? I guess Rob's going.
Message.
Sorry. I'm sorry. It takes a moment.
I'm Rob Stone and I'm in favor of SB 868. Self-direction gives me control of my own life and the choice to live in my community. I am an advocate, an artist, and a writer. I have my own art website. Right now, I'm doing well. But the DDA can always change the rules on me. This bill says the DDA must give me access to overnight supports when I need them, to a house manager when I need that, and that I can hire my family as staff if I want to. It also says my services won't be taken away because someone who doesn't know me can decide whether I'm competent. Please pass this so I will always have certainty and predictability with my basic self-directed services. I want to stay in control of my life. Thank you.
Thank you. We agree that you ought to be in control of your life. Okay. Now, Geneva? Okay. Are you going to testify?
Sure. Okay. All right.
Go ahead.
Okay, sorry. I am Geneva Stone, and I'm urging you to pass SB 868 out of committee with a favorable rating. I am the parent of Rob Stone, a self-directed participant in Montgomery County. Rob transitioned from high school wanting to be an advocate, an artist, and a writer, and I'm proud to say he has achieved all three of those goals. I am 57 years old, and Rob's dad is 60. Rob depends on self-direction's flexibility and commitment to choice. However, self-direction is still subject to the DDA's internal rulemaking authority, and Rob has been in 2 different DDA programs, and I have worked with the DDA on Rob's services since 2005. And my family has served through over 16 years then of rules and service changes by the DDA with little or no notice. These rule changes have affected Rob's ability to purchase equipment, hire certain types of staff, and access his community. My family then has to go through the onerous process of speaking to the DDA through Rob's case manager, providing more documentation, and making yet another argument for Rob's right to certain services. I can, for the time being, continue to fight these basic service battles with Rob, but at some point, I will not. If you pass SB 868, Rob will be able to count on basic parameters in self-direction without my having to intervene. Our community needs certainty and predictability in self-direction. Thank you.
Thank you very much. Sorry you had to go through so much, but your son is really thriving, and we're glad that you're here. All right.
Hello, can you hear me?
Yes.
Hi, I'm Sunny Sefarati, and I am a self-directed services participant. When I graduated from the Maryland School for the Blind in 2007, I was placed in a sheltered workshop where I remained for 8 years. The sheltered workshop was very negative, and I had more negative experiences than positive experiences. In 2015, my support broker helped me get out of the sheltered workshop. When I was in the sheltered workshop, self-directed services was something that nobody ever told me about until 2016 when I entered the service. I am in support of SB 868, and one part of the bill says that there needs to be competency tests, which I believe that people in self-direction that have a disability are able to self-direct with the right supports, regardless of ability. I am blossoming now because I am in self-directed services. I serve on 3 organizations: the Musical Autist, the Maryland Developmental Disabilities Council, and the Self-Directed Advocacy Network of Maryland. I would ask that the committee would consider passing this bill so that people like me will be able to self-direct and do the things that I do in the community. I think that everybody in self-direction deserves to have the right to choose who to hire and where to go in the community. We set personal goals for ourselves, and we hire our own staff to work with us in achieving these goals. So I encourage this committee to please consider passing SB 868 so that people like me can do the things that I do, whether it's serving on boards, whether it's going to the grocery store, going into the committees, going to different places in the community, and things like that. Thank you very much.
Thanks. It's really good to hear from your perspective why we ought to pass this good bill. Okay. Did we hear from Margaret Carter?
Hi, my name is Meg Carter. I'm the parent of a child in self-direction. My daughter Lucy is 36 years old. She's been self-directing since 2010. Lucy has really severe epilepsy, which I would never have imagined that she'd be able to participate in the community as much as she does without self-direction. This is a young lady who has 3, 4, 5 seizures a day. She's out almost every day, shopping, climbing walls at earth treks, swimming at brick bodies, taking boxing lessons from her personal trainer. Not only is she doing all those things, but at the time that she's socializing. She's connecting with other people. She goes into the gym and fist bumps. I don't know how many people. She knows way more people than I know. I go places and people say, "Oh, you're Lucy's mom." And I'm like, "Yes, I am." What a wonderful thing to be. Lucy, I love what it's done for her. So in 2016, I helped to found the Self-Directed Advocacy Network of Maryland. To me, it was really important that other people like Lucy have the same opportunities that she does. I'm here today to support this bill. With Hestan, it's been a roller coaster ride with DDA. DDA has a lot of wonderful people in it, and I know they're trying. But since 2016, it's been like this, up and down, gains and loss, gains and loss. And what people in self-direction need is stability. They need to be able to count that this program, that the services that this program offers are going to be there and are not just the result of the goodwill of a DDA administrator. That's why we need them codified into law.
Thank you very much. Senator
Ask you
Klossman.
a quick question. 'Cause
Sure.
the day is long, but when you said you had the peaks
Ro-
and valleys.
right.
and When you were in the valley, how did that affect your daughter?
It mostly threatened her services, I will say that. It didn't, well, at one point, for instance, DDA proposed getting rid of personal supports altogether and making them, having Lucy get all of her personal supports from Community First Choice, which is not a program that is designed for people like Lucy. So that is something Hestan opposed, and it is something that we were able to stop. But it was a proposal, it was a serious proposal. Another serious proposal was eliminating family as staff. We had to launch a petition drive to the governor to stop that. So yes, most of those things were stopped. But for instance, I'm looking at the results of the summer study in the information letter today. DDA says it's going to do all these great things. That's wonderful. But that's the first I've heard of it. There was no document that DDA issued at the end of the summer study saying, we're going to do this, this, and this. We heard you. I see it now in the letter of information. Great. But
Okay.
we need more than just promises. We need concrete results.
Thank you very much. All right, we're going next to Alexandra Hunter. And we'll call up Carol Custer, who's favorable with an amendment, and Patricia Eisenberg is testifying for information only. You may go ahead and start.
Good
You have
afternoon.
2 minutes each. And we really are going to have to time you. You'll hear a little beep from time to time because we got 124 people to listen to, and everybody wants to go home tonight.
Okay. Good afternoon. My name is Alexandra Hunter. I'm actually a family member. My sister-in-law, Rhonda, has been in self-direction since 2011 when her parents passed. She lives with me and her brother. And self-direction is, I'm going to just get straight in it so we don't waste time. Self-direction is an evolving program. It is growing and changing on the needs of the participants, not because DDA thinks so.
We are forever grateful to the state of Maryland for even offering such a great service to people with disabilities. Self-directions give the participants employer and budget authority. That means the participant is the employer of record and must follow the Maryland labor and licensing laws. Some of the rights of the employer authority is being stripped away bit by DDA, and it is why it is important for Senate Bill 868 to pass. It would help restore the flexibility and access to self-direction while retaining cost savings. The flexibility and access I'm speaking on today is for the participant to be able to change and add positions to their staff to meet their daily needs. The importance of a house manager position or shift supervisor position, like they already exist and proven to be needed in traditional waiver services like group homes with provider agencies like Bellow McRae and the ARC. Having a house manager position would take a lot of stress away from the families who should not have to take the responsibility of managing staff and staff call-outs, just to name a few, especially when those family members have full-time jobs to provide a roof over everyone's head and to cover all the living expenses. Family members could be paid as staff with minimum restrictions. That would help. I wish I had more time to go into the details of what it takes to have a family member with disabilities. The care they need and how much of a positive difference a house manager position would make in the SD participants' life and their family. Stress level would drop tremendously, especially during times with COVID, and not knowing if staff is coming in, what staff is calling out.
We're going to have to wrap up. It's
I know.
just because we got still about 118 people to hear tonight, and they want to go home too. Okay, thank you.
Thank you.
All right. You just slide that mic down so that she can get it. State your name and go ahead.
Good afternoon. I'm Patricia Eisenberg, mother of Jillian Eisenberg. My daughter's 21 and is a thriving participant in the self-direction program. We always knew that we wanted Jillian to participate in self-direction. She has a lifelong passion for cooking and baking, as well as sports, particularly swimming, and in general, setting and achieving goals for herself. We've had 3 CCSs since March of 2021. Even though we always said we wanted Jilly to be in self-direction, we began working with the CCS assigned to us in late May, who did not seem very well informed about self-direction and didn't mention to me that I should get a support broker until July. I found our support broker for Jillian in August. In the meantime, the CCS submitted, without our knowledge or approval, a shell plan that did not meet my daughter's needs. Keep in mind, my daughter should have been under the Governor's Transitioning Youth Initiative, have been receiving services starting July 1st. We had been going back and forth furiously throughout August. My husband and I are both teachers. We had been paying out of pocket, asking family members to help, taking time off ourselves to support our daughter and keep her safe until her plan became active the first week in November, so more than 3 months after it should have. We are fortunate, we had local family members. We could take time off without losing our jobs. There are a lot of parents who can't say the same. We had savings we could tap into. There are a lot of family members that can't say the same. And Jillian needs to have the discretion for more than 4 hours of support brokerage in the decades to come that I'm not there to intercede for her.
Thank you very much. Okay.
Okay. Hi, my name is Carol Custer.
Push that a little closer to you. Just pull
I
it.
took my mask off. I thought that would. My name is Carol Custer. I'm a support broker who, over the last 12 years, have worked with close to 50 individuals in directing their plan. Right now, I'm also the secretary of the Self-Directed Advocacy Network, which is a small group of volunteers that swung into action in 2016 when some of the things you've already heard about were put into place. We do concur with the proposed amendments suggested by the Disability Rights Maryland. Their language only strengthens the intent of our bill. And we also are willing to work with the other advocacy organizations who submitted letters of information. I have been testifying for over 5 years about the situation with DDA and what has been happening to the people in self-direction. This is probably the 12th time. My point has always been that DDA has chosen to make these changes. CMS allows what we started in Maryland in 2005, and we can go back to that. But we need your help. We need your help to put these principles of self-direction into law so that no one in the future has to fight to get back the supports that they need. This bill makes it clear how Maryland will treat individuals with disabilities who self-direct, and I think the state needs to tell the department what is going to happen so that right choices are made in the future.
Thank you for your testimony, everybody who's testified on this very good bill. We'll do all that we can to try to help.
Thank you.
Okay.
Thank you.
All right, we're going next, Senator Lee, to your 867. If you will come up to the mic and just lay out your bill as quickly as you can, and then, let's see, let me call up your first panel. Josh Basili, John Michaels, and Michael Delta.
You just gotta remove the chairs. What? You just gotta get the chairs out of the way.
Thank you, Madam Chair. We appreciate letting us go first. We're very grateful. There would have been more witnesses, but because of
Well, we
COVID,
just want you to go ahead.
okay, we didn't have as many, so we do have these advocates here. I bring you today SB 867, Equal Love for Employees with Disabilities Act, legislation that is a result of many years of work with the State Department of Health. This follows the lead of the state of New Jersey that recently passed legislation to accomplish essentially the same goal, ensuring that the eligibility of participants in the Employed Individuals with Disabilities waiver programs to get married without fear that they'll be removed from participation in essential services in the program. Enough money has already been set aside to pay for the increased levels in the budget requests, and we simply feel that their thresholds were too conservative and will not lead to any increased growth with broader provisions proposed in this bill. First, I must say that I'm really happy and appreciative about the dedication exhibited by the DDA and the Maryland Department, MHA, to Josh and others who fear that the EID availability will be removed should they get married and therefore their income increase. The policy of one administration is not as strong as codified law, and we're here because as the last session of this administration, we want to protect the availability of this waiver program for the future. Future administrations can, of course, build on this law. The Willing to Work Coalition has evaluated the physical note and agrees with the DLS's hesitancy to adopt the MDH analysis. The EID enrollment will not double, but could grow by approximately 27% in the first 12 months after enactment of this bill. The calculation is based on growth after a similar bill in Washington State. We have not seen projections after New Jersey's enactment. However, the New Jersey analysts noted that the numbers cannot be reliable because of the lack of information as to how many spouses are ineligible because of the marriage threshold in place. If the numbers cannot yet guide us, we propose that you use our values to guide. We encourage people to get married and do not prevent it because of needed access to resources that prohibit marriage. Should be a higher marriage income limit be met. Even if eligible under the change to the budget language, affordability of the new higher premium may be an issue. The fiscal note discusses projections of 1,200 participants up from the status quo of 850 current enrollees at just shy of 27% increase. This increase reached only 226 new enrollees for 1,076 total, below the threshold for the MHA allocated funds to pay for the projected growth, so it's well within the budget. While I very appreciate much MDH, the current and past secretaries and current deputy secretary, I would be remiss to point out that I was before you last term with a bill to create a pilot program for its population. Instead of having that in place for years, language was put in that bill to discourage participation and even block the population that they were actually trying to protect and serve. We accepted the language from the department in good faith and were beyond disappointed. Going forward, I'm going to verify any potential amendments at this point because the affected population deserves more than lip service, and they really need services. For these reasons, we respectfully ask my esteemed committee members, please vote favorably on SB 867.
So the point of this bill is to make it possible, without any interference from the state, if adults who happen to be in the DDA program wish to get married. Is that it?
Well, it also, those are that have disabilities, but they require, assistance, but they also still want to work. And so that they can at least get married, yeah, and that their spouse's income will not be factored into the whole formula. But they will explain it a little bit more. It's just a
Okay.
matter about justice.
Okay, thank you.
Thank you, Madam Chair.
All right, we're going next to Josh.
That's me. I want to make sure, can you hear me? Am I too far away from the microphone? Am I too far away from the microphone?
You might be.
Do you want me to bring this down?
No, you pull your chair up, sit next to him, and pull that microphone up a little closer to his mouth. The mics are kind of awkward. Okay, that's great.
Can I have Michael do it, because my speech is in my right side? Sorry.
Okay.
Thank you, Senator Lee. Dear Chairwoman and esteemed committee members, my name is Josh Basil, and I'm here today in support of SB 867, Equal Loving for Employees with Disabilities Act. I became paralyzed below my shoulders as a teenager when a wave picked me up and slammed me headfirst against the ocean floor. Since then, I've never stopped wheeling after my dreams of becoming employed, falling in love, and starting a family. With the support of the Maryland vocational system, I completed my undergraduate degree and ultimately graduated magna cum laude from law school. Since becoming employed, I enrolled in the Maryland's EID program called Employed Individuals with Disabilities Program. This was back in 2013, and it was upsetting to learn that my future would be guided by strict EID rules that would prevent me from earning more than 300% at the federal poverty level, save more than $10,000 in assets, and prevent me from getting married to a spouse that also had a job. The second that I violated any of these three rules, I'd be kicked out of the EID program, lose my Medicaid, lose my caregiving, and no longer be able to survive in the community outside of an institution or nursing home. EID enrollees that do fall in love are told to get happily divorced or remain as cohabitated partners for life. And enrollees that do reach the age of 65 are terminated from the program as an EID enrollee. As a proactive advocate, I turned to Governor Hogan, and for the last 4 years, I've been working with his administration. In September, they agreed to remove all income and asset limits, but would not fully remove spousal inclusion and the age 65 rule. In January 2022, the governor of New Jersey signed into law a bill that would remove all income and asset limits, would remove spousal inclusion, and would remove the age 65 rule. I'm so happy for workers with disabilities in the state of New Jersey. In order to make sure that EID rules do not change from administration to administration, Senator Lee of Maryland decided it would be important to codify the rules in SB 867 and to mirror the New Jersey law. I'm dreaming of the day to marry the love of my life. EID has prevented me from marrying my fiancée, who I love more than anything, but it did not stop us from starting a family. I'm so happy to report 12 days ago, became a daddy to a beautiful baby boy who's the love of my life. And
Congratulations. How's that baby boy doing? Fine?
so he's so perfect.
Okay.
And I cannot wait to pass SB 867, to wheel down the aisle with him in my lap, to have my beautiful 4-year-old stepdaughter to be our flower bearer, and to exchange vows and say I do. With your support today and approval of SB 867, I will be one wheel rotation closer to making dreams come true, and for the first time since 2013, to be able to work without limits just like everyone else. Thank you for your time and consideration.
Thank you very much for your testimony. Thanks for your courage and for your being a leader on this issue. Okay, let's go to Michael.
Hello, I'm Michael Dalto. I'm a small business owner and a disability advocate, and as the member of the panel with white hair, I get to talk about what it's like to be old. The bill under consideration would eliminate the upper age limit for the EID program, which is currently 65. Now, Medicaid rules describe being age 65 as being aged, and that is totally false. Aged is at least 85 or 90. Many people have to work long past age 65, and they should be eligible for EID too. It's especially unfair to cut off people, old people, because we have the most health problems. So a good number of people enrolled in the EID program have lost eligibility when they've turned 65. They have incurred far greater medical expenses. Their Medicare cost sharing has increased dramatically. That's because they've lost Medicaid, which in the state of Maryland eliminates Medicare premiums, deductibles, and coinsurance. One Frederick man enrolled in the EID program saved so much on Medicare costs that he was able to get a mortgage and buy a home. However, when he turned 65, he lost EID, his Medicare cost sharing skyrocketed, and he nearly lost his home. A Baltimore woman recently turned 65, and she lost eligibility for Medicaid through a different Medicaid eligibility group, the adult group, which also has an age limit of 65. But because she hadn't worked long enough to get enough credits, she did not qualify for premium-free Medicare Part A. It has a very high monthly premium. She cannot afford to enroll in Medicare. But she's working. If it weren't for the upper age limit for EID, she could enroll in EID and continue her insurance very affordably. So age discrimination is illegal, and there should be no place for it in the EID program. Thank you.
Thank you. Are there other states that you know of that don't have a limit, an age limit?
Yes. The two that we've looked at most closely are Washington and New Jersey, which recently eliminated their upper age limit. And there are a handful of other states that have done it as well, Senator.
Thank you. That's helpful to know. All
you.
right, and you're last. You got 2 minutes.
Hello. My name is John Michaels, and I am a C6-7 quadriplegic, and been a quadriplegic for the past 28 years. 2 weeks after graduating high school, I dove in a swimming pool and severed my neck, and have been quadriplegic since for the past 28 years. I have used the EID program since it's been offered in the state of Maryland. Before the EID program, there were not many options for someone like me to be gainfully employed and have a successful career. Currently, I'm an assistant director at the Center for Independent Living, and I've been working with the state through the Willing to Work Coalition to change regulations. But based upon the proposed recommendations, if I would get married, my spousal's income would be considered into my monthly premium. Presently, my monthly premium is $55, and if I would get married, my premium would be over $600 a month. I would spend over $7,000 extra a year. Financially, that is more than I can afford, so I would choose not to be married. This program is the only program that pays for a personal assistant to help me with my ADLs. Being a quadriplegic, I need daily help with dressing, grooming, hygiene, and bathing. Other obstacles I face with the current EID regulations is limited resources that I can save, and the current age limit of the program is 65. I have extra medical expenses that Medicaid does not cover, and the expense and upkeep of a wheelchair accessible van can be very expensive. I'm actually looking at one right now, and it's over $100,000 a year, or $100,000 just to buy the vehicle with all the modifications, and I drive. Drove here today took me 2 hours and 30 minutes just to get here to testify, and that's what it'll be to get home. So I have a lot of expenses that is not covered. I would, and then also with the age limit of 65, that would be detrimental to me financially, medically at 65. Living the life of the quadriplegic is very stressful, and the obstacles we face every day is challenging, but I do what I can to the best of my ability and live the best life I can. And just one thing I have, my fiance Lori and I have been together for almost 7 years, and when I proposed to her, I was committed to have her as my wife. We lost Lori's mother 2 years ago to multiple sclerosis. On her birthday this year in October, we would love to get married and share our wedding day in the memory of her mother. With the support of SB 867, we will be one step closer to our dream. Thank you for your time.
Thanks so very much for your testimony, and to all of you. All right, that ends the testimony on this very good bill. All right. Okay, we're going next to Senate Bill 781, Senator Hester. Is she here? Yes. Okay, Public Safety and Behavioral Health Improvement Act. Senator Hester, you'll be able to take the time you need to lay out the parameters of your bill, and let me call up your first 3 or 4 panelists. Let's see, Kevin Kennelly, Jennifer Redding, and Dan Rabbit. The mics are movable, and also the one at the podium is available if someone would like. All right, now did everybody hear their names? So we got our sponsor, Jennifer, Kevin, and Dan. Okay, go ahead, Senator Hester.
Thank you, Madam Chair, members of the committee. It's great to be back in finance again. For the record, Senator Katie Fry Hester from District 9, here to talk about Senate Bill 781, which will expand the work of the Behavioral Health and Public Safety Center of Excellence, which this committee passed last year. I first wanted to just briefly remind you about what this wonderful center is supposed to be doing. It's in the governor's office, and it's got 6 main goals. Well, the overall goal is to keep people with mental and behavioral health issues out of the criminal justice system. And then there's 6 goals beyond that. First is to act as a statewide information repository for behavioral health treatment and diversion programs. Second, to develop a strategic plan for the state of Maryland to reduce incarceration and increase treatment of justice-involved individuals. Third is to host the annual state summit on the sequential intercept model, from which the recommendations from the statewide report came, which formed this office. Fourth, to identify and inform stakeholders of grant funding that would support the missions of the center. And fifth, to continue to facilitate sequential intercept model train the trainers programs with the goal of training 50 facilitators by 2021, which is now passed. And 6, to provide technical assistance to localities for the implementation of best practices and the intersection of behavioral health and justice system. So that's like a broad overview of what the center is supposed to be doing. Now, unfortunately, it's taken a while for them to get up and running. I'm delighted that they've finally hired 1 person to work in the center, and there's 2 more positions that are currently open. But what the bill in front of you does now is it provides funding for the center. Because there hasn't been appropriate funding allocated. So Senate Bill 781 appropriates $500,000 to the annual budget for the Center of Excellence to contract services with the University System of Maryland. It also establishes and provides one-time funding of $500,000 for the Behavioral Health Screening and Grant Program to assess the severity of disorders and identify appropriate levels of care. And this would take place at various intercepts throughout the criminal justice system. Fourth, it requires the Maryland 911 Board to establish training standards for dispatchers and operators to address mental and behavioral health conditions and provide funding for that training. And fifth, it requires the Governor's Office to create a scorecard of safety indicators as recommended by the Office of Legislative Audits. Their audit report came out at the end of January. Committee, I have had a brief conversation with Senator Augustine. I understand that some of this bill overlaps with some of the work, the great work that senator is doing, and we're going to continue to work to eliminate or complement that overlap. But with that, I would ask for your favorable report to get the center finally up and going, and turn it over to my lead witness.
Okay, let me say one other thing while you're talking about the work you want to do with Senator Augustine, so you're looking at how two bills work together, or should. We have written testimony, I haven't read it yet, from the Maryland Judiciary that is unfavorable. So you want to get your hands on that and take a look at it to see what responses are needed.
I would be happy to,
Okay.
and Madam Chair, if I might, the original report this came out of was from the Mental Behavioral Health Commission and the subcommittee on public safety and criminal justice, and we do have a member of the judiciary on that work group, so I'd be more than happy to work with him and others.
I don't know what's going on there.
Okay, thank you so much.
But since I see it, I want to alert you to the fact.
Thank you, will do.
Okay, all right, and let's hear from you. You have 2 minutes.
Thank you. My name is Jennifer Redding. I'm the Executive Director of Behavioral Health Services with the University of Maryland Upper Chesapeake Health, in addition to the Klein Family Harford Crisis Center in Harford County. I'm here today in favorable response of this bill. As we talk about the importance of behavioral health and keeping as much as possible those that are impacted by behavioral health and substance use disorders out of the criminal justice system. 1 in 5 folks experience a mental health or a substance use issue at some point in their lives. Certainly, those numbers are higher, with the marathon of the pandemic that we've been living through the past 2 years. Depression and anxiety make up about 80% of all mental health issues. In Harford County specifically, our rates are about 13% higher than the state average for suicide, for those individuals who die by suicide, with specifically 11.4 individuals per 100,000 versus the state average, which is 10.1 individuals per 100,000. Suicide is the number 2 cause of death in people ages 10 years old to 34 years old. In regards to this bill, supporting additional training for 911 dispatchers on behavioral health conditions, crisis intervention, and utilizing a mobile crisis response versus law enforcement, I think, is vital. In Harford County, my organization participates in a partnership with the Bel Air Police Department on law enforcement assisted diversion, and there's absolutely a place for law enforcement and interacting with those in the community. So often they're the first points of contact in the community when someone is experiencing a mental health or substance use issue. With proper training and partnership, however, they are able to hand those folks off to the behavioral health professionals so that they can be properly assessed and linked with resources, therefore preventing a barrier of the criminal justice system. The importance of peer certification, so working within a multidisciplinary team, certifying peers gives them credibility, and they're so vital to the work that we're doing. And finally, just the behavioral health screening, whether that's in a detention center, at any point of contact, it's so vital so that we can connect the dots and get those folks linked with the resources they need. Thank you for the opportunity.
Thank you. The other witnesses appear not to be here, but we will follow up ourselves, and you want to follow up to see what it is that the judiciary is saying. Okay? Thank you.
Thank you very much, committee.
Thank you. I'm not. All right, Senator Simonaire, Senate Bill 751. I've had to turn down about 15 senators today who wanted to hear this thing. All right, and Chris Pashnach. What's that, Panasuk?
Panasuk.
Okay, got it right.
I was like,
fine.
that's about the worst pronunciation I've ever heard.
Okay, all right. Let's see, is Robert Phillips here? Okay, good. Senator, lay out the parameters of your bill, and then each of your panelists will have 2 minutes each.
Thank you. I should be able to get this done within about 60 minutes. Thank you very much. Seriously, it's good to be before you. It's the first time before your committee this year. Often in the news, we hear about gut-wrenching clips of 911 phone calls, and it's very difficult to listen to maybe 1 or 2 minutes of it. And that's what 911 specialists do for 8 hours a day, sometimes 12 hours a day. And not only do they take calls, but they also dispatch people, and they save lives as they're talking to people before the physical presence shows up. And I have the greatest respect for them and their work. As a state, we need to give them the recognition that they deserve. And I understand there's another 911 bill dealing with just the generic 911 topics. And in that bill, they deal with first responders just in the public safety article. In Maryland law, there's 2 terms that relate to that. One is first responders, another one is emergency responders, depending on the section of law. There are many references in Maryland law. There's public safety, education, criminal law, alcohol, beverages, and the list goes on. And this bill updates those. Many other states are doing this. Most recently this year, New York and New Jersey have passed similar laws. And this just updates the first responder and emergency responders in state law to include 911 specialists. This bill gives them public recognition that they deserve. These people continuously show professionalism in their life-saving work, and now we can help them in their time of need. And others can share much better than I, but I would ask for a favorable consideration as we move forward here. Thank you.
Thank you. All right, let's go then to Chris Panasuk.
Thank you very much. I wanted to speak in favor of this bill. There are roughly 1,400 dispatchers across the state of Maryland that sacrifice their mental and physical health every day for the citizens of the state. There are roughly 1,400 dispatchers across the state of Maryland that sacrifice their mental and physical health every day right here in the state of Maryland. Right here in Anne Arundel County, our dispatchers work an average of 60 to 70 hours a week. They are overworked and burnt out and often unseen by the community at large. Until an emergency happens and somebody can't get through to 911 because there's an accident on 295 tying up all the lines and somebody else in the other part of the county is having a medical emergency. Right? There's just simply not enough bodies to go around to handle the workload. Right? This is when they get noticed, and they often feel the most uncared for. Right? This bill is about giving them the recognition as true first responders to the emergencies that are happening in their community. Right? They answer the calls. Right? That when, as my wife said in her written testimony, right, when it's the worst day of your life, it's the normal day for them. Right? And they don't do this 8 hours a day. They're doing this an average of 12 hours a day, every day, 6 days a week. Right? And right, that's where I got to end. That's basically, sorry, I lost my place. Basically, these men and women deserve this respect because they are sacrificing time with their families and their community in a way that is detrimental to not only the community, but to themselves. And this is just a small, small thing that we can do to say thank you.
Thank you. Let me ask, if I were reading the whole bill right now, what specifics are there to guide the way in which this respect should be shown?
They are, right, by equivalent them with their counterparts in the field, right, their counterparts in the field get seen, they get noticed, they get cared for. Right? When their counterparts in the fields, when something happens to them, right, when you hear about PTSD for police officers and PTSD for firefighters, you're not hearing about it for the 911 dispatchers. You're not hearing about the overwork and stress conditions that are happening in those facilities. You do hear about those things in out in the field. But it's also about respect. Just simply the respect of I'm I am here, I am first. I picked up that phone and I was there all the way up until the physical help got there.
Thank you very much. Okay, now let's see. What about John Ripley? Did that person come in?
I'm here.
Okay, Mr. Ripley. Did Kasia Garcellian come in? Or you may come up. Okay. You have 2 minutes each.
Was he supposed to go first? I'm not sure.
Oh, Mr. Phillips, why don't you go ahead next?
Thank you, ma'am. My name is Robert Phillips. I'm the chairman of the Maryland State Firefighters Association Legislative Committee. Also a 43-year volunteer firefighter. The MSFA supplied, or I supplied on behalf of them, written testimony for this bill. To that, I'd like to add, the MSFA believes the 911 dispatchers are the first link in our emergency first responder chain. They're the ones that get the call for help, and they're the ones that the public rely on until others respond. They are the calming voice on the other end of the black box who give the public hope. They might just try to keep a person calm in a stressful situation, or give life-saving instructions to another person to keep them alive or someone else alive. Without their assistance, the other first responders would not know where to go or what is the emergency at hand. When in the field, they provide the communication that links us, other first responders, to the help we need. They arrange for more and different assets to respond when we need them. Without them checking on us when we're out working alone, some might not come home. I have more than once been the only person on location, and it's comforting to hear that voice. Chief 1, dispatch, are you all right? I can tell you personally, one time I was out on an investigation, and the gentleman I was investigating tried to run over me with a tractor. One call, Chief 1 dispatch, I need help. They sent every police officer in the area, 4 of them. And an engine company. They are the first responder. Sorry if I'm a little emotional.
That's all right.
As you heard earlier, there are approximately 1,400 dispatchers in the state of Maryland who will benefit from your support of this bill. I thank the committee for their time on this important issue and ask that you favorably support Senate Bill 751. Thank you.
Thank you very much. All right. What about John Ripley?
Yes, ma'am.
Okay.
Madam Chair, members of the committee, good afternoon. And I want to say I'm very pleased to be here in person to testify on behalf of Senate Bill 751. I want to first thank Senator Simoneri and Delegate Kempsky for the work on this piece of legislation. Again, my name is John Ripley. I'm the president of the Baltimore County Federation of Public Employees, representing about 1,500 county employees and 250 or so active 911 center employees. Over the years, I've witnessed their hard work, their professionalism. They're in a workforce of a highly technical job, and they perform these jobs admirably. In the county, we like to think that we have the very best police and fire departments, but without the 911 center professionals, those departments would falter. 911 center employees are the true first responders in emergencies, and because of that, we urge your support for SB 751.
Okay, I'm a fellow Baltimore County, and now, when we pass this bill, what will be different than it is right now?
Well, as nothing immediately, but as some of my colleagues have already emphasized, it's a kind of a gateway to recognizing them as the first responder professionals that they are. Imagine, I guess, being tethered, in Baltimore County, it's 12-hour shifts. Imagine being tethered to a workstation, sometimes having the luxury to stand or sit at your choice. But being tethered to a workstation like that, and as my colleague has already mentioned, dealing with one emergency after another, and that is their workday. Sometimes to the extent of advising life-saving measures of first aid, CPR, controlling bleeding, sometimes the last voice some people ever hear, comforting voice that some people ever hear.
You guys have done a great job of really helping us to see your sacrifice through your eyes. What I think we need to understand is when we pass this bill, what is going to change for you to make it better? In what ways would you like to see people give you the honor that you're due?
I think they're unsung heroes. I mean, they've been left behind with the Hometown Heroes Act. They've been left behind in other workers' comp presumptions and things like that. And they're first responders. I mean, they're dealing with emergency after emergency. No one's calling them with good news.
Okay, thank you. All right, let's go to Kasia Gatchalian.
Hi, my name is Kasia Gatchalian. I've been a Baltimore County 911 call taker and police dispatcher for 20 years. I started out as a volunteer firefighter EMT, and then I went over to 911. I'm also the union vice president for Baltimore County Federation of Public Employees, and I'm also an assistant police dispatch supervisor, and I've been in that position for the last 8 years. I believe that 911 specialists should be considered first responders. They're at the forefront of public safety, and they are the first contact for those in need of help. They are essential, and their performance is critical to the safety of the field units and the public. I personally, and I'm going to use this example, is I took a call from a lady whose 4-year-old was in cardiac arrest, and she openly admitted that she was a nurse and she had completely forgotten all of her training. And so I was there, and call takers are there. We are trained to give CPR instructions over the phone. And if you can imagine how difficult that is to tell a mother whose 4-year-old is not breathing and is not conscious, it's very difficult. But I told her that we were there to help, that I'm there, and I told her step-by-step directions to help her 4-year-old child. And that is just one example of the many things that call takers do on a daily basis, hour to hour, emergency after emergency. Other examples would be we've handled school shootings, we've handled train explosions, we've handled police officer shootings, we've handled just a number of things that people call on their worst days. These men and women take pride in their work. They handle extreme circumstances. They take call after call back to back for hours at a time. They deal with people on their worst days, and we should absolutely focus on supporting these 911 specialists, giving them the added benefit and recognition that they deserve. And to add on the question that you asked earlier, sometimes it's just that recognition that makes us proud of what we do. And for a long time, we've been considered clerical workers. Sometimes people have considered us glorified secretaries, and we were much, much more than that. And sometimes it's just this recognition that would make us happy, just happier in coming to work every day and dealing with these situations. And I thank you for listening, and I value your support. Thank you.
Thank you very much. Okay, what about Kevin Kennelly? Is Kevin here? Okay. All right, then that ends the testimony on this bill, and thank you very much. We're going next to Senate Bill 743, Senator Washington, Maryland Medical Assistance Program, Affordable Assisted Living Enhanced Care Pilot Program. And let me call up your panel. Claudia Schlossberg, Osama Suadi, and Reverend Dr. Alvin Hathaway. Okay. Madam Sponsor, you have the time that you need to lay out the parameters for your bill, and all of the other witnesses will have 2 minutes each.
Thank you. Thank you very
Okay.
much, Madam Chair. Thank you, colleagues. Senate Bill 743 would establish a pilot program that serves to address both the housing and healthcare needs of older adults and seniors who qualify for medical assistance but do not qualify for skilled nursing based upon their level of health. This bill would provide a mechanism to address the gap in the need for assisted living and the ability of facilities to pay for it, individuals to pay for it. Currently, Maryland Medicaid provides a coverage for nursing home residents under certain circumstances, and there is coverage for nursing home care, but not only do you have to be financially eligible, but you also need to have a certain kind of nursing home care that's provided. Maryland residents may be eligible for Medicaid long-term care services that are delivered outside of a nursing home facility or assisted living facility. Now, research indicates that a private pay resident in an assisted living community in Maryland will pay about $4,600 per month on average. And residents of Maryland that are in need of assisted living may also require some financial assistance in order to avoid moving into a nursing home, which would be much more expensive. So, sorry, I messed up that sentence, but it's $4,600 to provide assisted living. But it's much, much more. And in my own case, for example, with my mother, it's like $13,000 a month. Maryland Medicaid offers certain home and community-based service waiver programs that allow individuals to afford LTC services so that they can remain at home and live independently and to stay out of nursing homes. For example, the Senior Assisted Living Group Home Subsidy Program will pay a licensed registered assisted living facility up to $650 a month, while residents will give the facility all of their money on top of that. Plus, they can keep about $60 a month allowance. Now, currently, there is certainly, as I told you, it costs more to provide that service, so there's a gap there. So there is a way to finance assisted living costs. You either have to have long-term care insurance that includes assisted living, not all of them do, or there's been the practice of using reverse mortgage. And, you find that not only has an implication for the family, but in terms of it's usually the only piece of wealth that parents or grandparents have to pass on to their children, and so they'd have to use that mechanism. Now, in 2000, and this year, there's about 25,000 assisted living beds in Maryland, but only about 4,500 of them are Medicaid certified. And in 2019, only about 1,000 Medicaid certified beds were occupied by older adults. So the goal of this pilot is consistent with the home and community-based waiver program to provide seniors with assistance in daily living and housing and nutritional costs, and also to avoid the long-term impacts of needing skilled nursing. But the idea is to increase the number. How do we increase the number of available beds? How do we make these beds more affordable? So we have these two tasks. So that's what this pilot program is doing. It would both improve the ability of senior housing to give people who are interested in senior housing to leverage existing millions of dollars in capital resources to construct some modern congregate settings. Typically, the way assisted living is provided is in a much smaller setting, so 3 people in a house, or it's being provided at home. So the idea here is to allow there to be a larger setting that's not a nursing home, that's not an independent facility, but can really maximize and provide much-needed support. Now, Illinois has the largest Medicaid funding assisted living program in the country, with over 154 operating sites and 12,000 apartments. Based on that, they find that the state saves about $104 million to $150 million annually by keeping people out of nursing homes. So the key is if we can keep people in an assisted living, even though it's a congregate assisted living, we can save a lot of money. Now, why I have to make sure I preface that is that in the bill, it's asking us to spend some money. But it's asking to invest and provide incentives to allow are people who do this work, these developers, these people who have experience in creating senior living communities, invest in this particular product. The other thing I want to draw your attention to, and in the bill, it makes eligible individuals who are 60% of the state median income. Why that's important is that, and that we provide an affordable mechanism there, is that many of our constituents are in that middle space where you're not poor enough or didn't start divesting your property, because there is that opportunity to, if you look ahead, to divest everything early on, or you either have to have all the money that you need to pay, be able to pay $13,000 a month or $8,000 a month. Most Marylanders are somewhere in the middle. And so with this program, you would be eligible, say in Baltimore City, at 60%, it would be a household income of $43,000. In Montgomery County, a household of $52,000. In St. Mary's, $43,000. So getting in that where most people are, they would be able to afford this product. So again, colleagues, this is an opportunity to address an issue. The people that I have here as my panelists know much more about the specific tax credits and details of it, but I do ask for your favorable report because it does address a need that we have in our state. So I have Ms. Claudia Schlossberg. She was a former Washington, D.C. Medicaid director. They did a really interesting program in this area, and she'll talk about that. Also, Dr. Alvin Hathaway, a good colleague of mine from Baltimore City, but also is well known to people across the state and being on the right side of things. And also Mr. Usama Suadi. He's with Greg Cardona Partners. They are an affordable assisted living developer, and they're currently constructing projects in D.C. So again, thank you for your time, and I look forward to having my panelists answer most of your questions. Thank you.
Okay, thank you. All right, let's go then next to Ms. Claudia Schlossberg. You have 2 minutes.
Thank you. Good afternoon, Chairperson Kelly and members of the Finance Committee. My name is Claudia Schlossberg. I'm the founder of Castle Hill Consulting, which is based in Washington, D.C. I provide strategic advice and technical assistance to public and private entities in the Medicaid space, primarily focusing on services, developing services and programs for vulnerable populations, particularly seniors and persons with disabilities. I have over 35 years of experience in this field, including serving as a senior policy advisor to the Department of Health and Human Services in the wake of the Olmstead versus LC decision, the Supreme Court decision mandating that states provide services to people with disabilities in the most integrated setting, and 7.5 years in the Department of Healthcare Finance in Washington, D.C., 4.5 years as the Medicaid director. Maryland, like virtually every other state in the nation, is faced with the challenge of meeting the needs of a growing population of seniors. The data from your own Maryland State Plan on Aging shows a significant growth in the aging population, including amongst the oldest old, people over 85. We also know that many older adults in Maryland are poor or near poor and are low income and dependent on Medicaid. Yet today, the waiting list in Maryland for home and community-based services offered through the Medicaid waiver is estimated to be over 26,000. While there are several measures being taken, including legislation before this body, to try to manage that Medicaid waiting list, my experience is that the only way to truly reduce the number of people on the waiting list is to expand service capacity. The Affordable Assisted Living Enhanced Care Pilot Program is a bill that is designed to do just that. It leverages Medicaid funding that's available to pay for services to attract developers and investors to build Class A assisted living communities that establish a new standard of care for low-income seniors using private equity and low-income housing tax credit financing. These communities are larger. They're 80 to 150 units, but they offer private studio apartments and one-bedroom apartments. Each individual resident has their own key and their own lease, so these are their own apartments. They also offer enhanced services, medication management, care coordination, and other services to help avoid, to help reduce avoidable hospital admissions and the inappropriate use of emergency rooms.
I wish we could go on. You're very informative. We just have a lot of additional people. We got about 90 more people to hear tonight before we get done. Are there questions? Okay, let's go to the Reverend Dr. Alvin Hathaway. He's my pastor, well, my former pastor. He's the pastor emeritus of my church, and he's on a lot of community boards and commissions and working to make life better for all kinds of people. And is kind of an expert at different modalities for doing that. So Reverend Hathaway, you've got 2 minutes.
Thank you, Madam Chair. It is good to see you, good to be here. Dear colleagues, many of you I know very well. I want to commend my dear beloved brother, Senator Hayes, on his new addition to our world. Bless you. I've been young, and now I'm old. Yet I've not seen the righteous forsaken, nor his seed begging bread. I believe that we, within the state of Maryland, have been innovative in terms of addressing the needs of seniors. We've done it in the past. I think we have this opportunity through the support of this Senate Bill 743 to do it in the future. One of the things that our seniors do desire is to be able to age in place in the neighborhoods in which they've lived and grown up. This will attract developers to come into those neighborhoods to invest, to create these kinds of housing communities that we desire to see, where we can still have access to our seniors, where their seniors can have access to their houses of worship and places that they are familiar with. And I think that this is an innovative way to create within a pilot within the state of Maryland, something that has been done in Washington, D.C., and I think it could be done in a very efficient and effective way. I would ask for the support of this body, this distinguished committee, to report this out favorably. I commend my dear colleague, Senator Murray Washington, for advancing this legislation. I believe its time has come. Thank you.
Are there any questions? Okay, thank you. All right, we'll go next to Osama Suadi.
Good afternoon. Chair Kelly, members of the Finance Committee, I thank you for the opportunity to testify. My name is Usama Swati. I'm one of the partners at Greco Partners, a purpose-driven real estate and community investment organization based out of D.C., and I am here in support of Bill 743. For 2 decades, my partners and I have historically worked in communities in the District of Columbia and the greater metropolitan area with a sense of purpose, energy, and transparency, and a collaborative character that underlies the creation of over 1,100 apartments, 400 of which are affordable, over 71,000 square feet of retail, and additional commercial space. Our work has won over the years the support of institutional investors and national and local lenders, and we are very comfortable partnering with local governments, negotiating win-win outcomes with community stakeholders, and then layering financial resources to develop high-quality places for people to live, work, and play. We do this with respect to the communities that we're part of. We are positively and innovatively engaged in shaping, preserving the physical and social and economic context in which people live. And by doing so, contributing our values and knowledge in a fashion that merits respect and considers community's interest. One of the great examples of this approach is our recent work in the District of Columbia, as Senator Washington has mentioned. We have managed to attract well over $350 million to date to deliver our first set of affordable assisted communities, of which are 100% affordable to seniors earning the area median income of 30% or lower. We plan to deliver a total of 600 units, 600 apartments in the District of Columbia over the next 3 years, and I would urge your committee to pass this bill, as it would very much help leverage capacity building, as Claudia mentioned earlier. Thank you for the opportunity.
Thank you. Before we let the panel go, which aspects of the pilot do you think are the most important, anybody? Or if you can't get everything you want, what should we really fight for the most?
Sure. Yeah. Chair Kelly, I think the fundamental piece here is that, is the Medicaid reimbursement rate which would enable leverage. As I mentioned, an average community of 157 apartments will take about $90 million to bring out of the ground. That's land costs, construction costs, startup costs, of which in the District of Columbia, we've asked for zero subsidy in terms of that development. We leverage zero public funds for the delivery of those physical assets. So the Medicaid reimbursement enables us to be able to attract those investors and lenders and provides the backbone of the finance structure. So I would say that it's the reimbursement rate.
Okay. Thank you very much.
Sure.
Okay. All right, we're going next to,
Oh, sorry, Senator, if I could say.
Sure.
For me, why I was attracted to the bill is that it's both of those things together actually do provide that. So if we just raise the rate without also creating the structure for creating the housing, it just looks like an end way to get rates up, and that's not
That's
not the
correct.
goal.
okay.
I definitely agree with that. Thank you.
Okay, thank you.
Senator.
I just wanted to be on the record about that.
Okay, thank you. All right, we're going next to Senate Bill 863. The senator is Senator McGray. He's staffing a hearing right now, so his staff person, Tamika Winkler, is going to testify on behalf of the sponsor. And let me call up the initial persons who are signed up. David Rodwin from the Public Justice Center, Lal Tesfaye from New America, Eric Cachamero from the Alzheimer's Association. If those persons would come up. And let's see, we have room for Ann Seacott, if she's here.
Oh, she should be coming over.
Okay. The mics are movable, and so, Ms. Winkler, if you would start us off, and then you have the time you need to lay out the senator's bill. The rest of us will have 2 minutes each.
Good afternoon, Chair, Vice Chair, members of the committee. My name is Tamika Winkler for the record, and I'm here to introduce SB 863 on behalf of Senator McCray. This bill will do two things. It will increase the hourly reimbursement rate to the employers of the home care workers and provide an increase in pay to the home care workers, which will allow them to compete for more, which will allow the employers to compete for more workers. I would defer to David if you guys have any questions or to elaborate on the bill more. If that's okay.
All right. Okay, then we'll, let's see, who do we have next? All right, we'll take, David Rodwin, go ahead. So, David, in light of that, let's give you a couple of extra minutes so you got time to lay out the bill.
Thank you, and good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is David Rodwin. I'm an attorney at the Public Justice Center. First, I just want to thank the chair for her leadership on this issue over the years, and thank this committee for passing out the reporting bill just recently on this workforce issue. This bill is about taking a hugely important step, or a leap really, to solve this really terrible workforce crisis of the shortage of home care workers in the state of Maryland. It does two things. First, it increases by 15% the Medicaid reimbursement rate that home care agencies receive for each hour of home care that they provide. It's currently $20.54 an hour, so it increased by about $3.06 an hour, so it would be $23.60 is what it would increase it to. So it increases money for the providers, the businesses that provide home care. At the same time, it increases the minimum hourly wage rate that home care workers need to be paid, which right now is just, Maryland's baseline minimum wage, would increase it to $16 an hour. So it will immediately improve when it takes effect in July 2023, when that rate increase takes effect. The wage circumstances and the quality of these jobs attract more workers, decrease turnover, improve quality of care, and just really take a big leap, as I said a moment ago, to improve home care in the state of Maryland and address this workforce crisis. I did want to sort of just note the two things about the fiscal note. We don't think it's as high as the estimate is for two reasons. First, The cost of nursing homes, everyone agrees, is always higher than the cost of home care. The minimum annual cost for someone to be in a nursing home is north of $80,000 a year. Home care is just about always less than that. When people aren't able to find home care workers in their communities, they have no choice but to go to a nursing home, very often understaffed. I'm not going to disparage nursing homes in any way, but often health outcomes aren't as good in nursing homes as they are when people are in their homes and communities. As it relates to the fiscal note, the cost to Maryland is much more when workers go into individuals go into nursing homes. Second, there's this likely federal funding coming down. It hasn't passed yet, but those who know more about it than I do say that it's expected. An additional $150 billion in money for home care. If and when that passes, that will fund a very good portion of this rate increase already by the time this bill takes effect. So I just did want to note that about the fiscal note. Finally, a point about terms we hear a lot about recently, racial equity and the gender pay gap. What is racial equity? And what is racial inequity? Racial inequity is when you have a workforce that is 90% women, 70% black in the state of Maryland, where the state funds that workforce but doesn't provide enough funding and doesn't set enough wage guidelines to make sure that these are livable wages that allow people to support themselves and their families. What is the gender wage gap? We often think about people working the same jobs and women getting paid less for those jobs, and that absolutely does happen. What happens just as much, if not more, is certain jobs that are predominantly women-dominated just getting paid less. Here we have state policy just paying less to home care agencies, that paying too little so that to allow women to sort of narrow the gender pay gap. And as a result, we have a really awful gender pay gap in Maryland. I think women make 86 cents to the dollar, and black women make something like 69 cents to the dollar as compared to white men. And it's policies like the reimbursement rates that drive that. So with that, I'll defer to the rest of the panel and just ask for a favorable report on SB 863. Thank you so much.
Thank you. All right, let's go next to Lua Tesfaye.
Thank you, Chair Kelly, and to the members of the Senate's Finance Committee. My name is Lul Tesfaye. I'm a senior advisor with the Center on Education and Labor at New America, which has done research on effective federal and state policies to support improved compensation for care workers. Given Maryland's aging population, home health and personal care aides are among the fastest growing occupations, with the number of expected jobs to increase by 41.5% by 2028. Despite the critical role of and demand for care workers, their pay is incredibly low, at about $13.50 an hour. And many workers struggle to make a living. For context, the living wage for a single working adult in Maryland is $17.25 an hour. A sole earner in a two-person household must make $26.66 an hour. And for each working adult in a two-adult household, they must earn $13.33. When you have dependents, the cost of living goes up pretty significantly. Without policy interventions, economic conditions for these workers will continue to reinforce gender, racial, and ethnic inequalities, considering that 88% of this workforce is women, 88% are people of color, and 32% are immigrants. Medicaid is the primary source of long-term care funding for the elderly and individuals with disabilities, and as such, it sets the industry standard for care worker wages based on the reimbursement rates, which must cover overhead, administrative costs, as well as worker wages and benefits. Last year, Maryland implemented 2 provider rate increases, but there was no requirement that the compensation of workers be increased along with the provider rates, which is problematic given this is a public source of funding and there are significant costs, especially with inflation. For those reasons, I am requesting your support of SB 826 since it will improve the compensation of direct care workers.
Okay, so you're saying the recent wage increases just went to the owners of the companies?
So yes, there were two provider rate increases. There was one for home and community-based services, and this was in response to an increase in federal dollars made available for home and community-based services. And there was also an increase for behavioral health and long-term care provider rates, but there was
But
no
there was
requirement.
nothing to mandate that any of it even trickle down to the actual workers who
That
do
is-
the work.
That is correct.
Okay, all right, thank you. Okay, Eric Colchimaro.
Chair Kelly and Vice Chair Feldman, Eric Colchimaro, Director of Government Affairs for the Alzheimer's Association in Maryland. Thank you for the opportunity to be here today on Senate Bill 863. The Maryland National Capital Home Care Association, or MNCA, has been a longtime ally of Marylanders with Alzheimer's and other dementia. MNCA serves on the Virginia I. Jones Alzheimer's Disease and Related Disorders Council. We are also grateful that this committee passed what is now Chapter 488 of 2021 with MNCA's support, which requires annual and continuing education on dementia for all of the home care providers who work with individuals who have this cruel disease. The bill under consideration today is a rate increase. It is a 15% rate increase for these invaluable providers who organize staff to go into our homes and help our seniors age in place. Amidst the pandemic, where nursing homes and to a lesser extent the assisted living facility industry received millions in state government aid, these long-term care providers also deserve our added support. This is also a bill that helps our direct care workforce. And my goodness, that's important. This workforce aids individuals with dementia, 95% of whom have at least one other chronic condition and whose care is complicated. There is a shortage of them overall. By 2030, 3.4 million more direct care workers will be needed. And yet the median wage for all of the state's home health care and personal aides is just $13.51, and it is even less for some of those workers. I will close with this. The fiscal note outlines a high cost. We may even hear from the industry that they want the cost to be higher in order to pay their workers $16 an hour. Yet what about the workforce? 90% of whom are women, 70% of whom are black, and many of whom who did not have a college education. These are healthcare heroes, and we need to value them, not just by acknowledging the shortage, not just by talking about the staffing costs, but by realizing we can do right by them by paying them a living wage.
Thank you. Is there anything in the bill that would require auditing periodically once the bill is passed to make sure that the pass-throughs get down to the personal care aides?
Yes, Chair Kelly, there's annual cost reports that would be submitted, I think it's by September 1st annually. And there's also a method by which workers can report to the Department of Health if they're not getting $16 an hour. So we sort of built that into the bill with exactly that concern in mind.
Okay. You might want to suggest that when the workers sign a contract to work, that $16 minimum is somewhere there, because if they don't know they'll do it, they might never call anybody to report or to ask a question.
I agree completely, and actually there is a notice required, I had forgotten it, but there is a notice provision that provides that the residential service agencies do need to provide notice when it takes effect on, I think it's July 1st, 2023, that at that moment, the workers have a right to be paid $16 an hour. And the home care agencies need to provide, as part of that cost report, proof that they have provided that notice to the workers.
Okay, thank you. Are there any other questions? Okay.
Madam Chair, if I may, just to your prior question, actually, about the American Rescue Plan Act, which a colleague mentioned, that was a one-time, what's called, the technical term was FMAP increase. And through some budget language that was inserted, 75% was required to go to the providers. But as you correctly noted, there was no requirement for even a penny of it to go to the workers.
Okay. All right, so we all got to work on that. Okay, very good. Ann Seacott, did she come in? Brennan Lester, Christopher Mayer, and Claudia Belog. And guys, you have 2 minutes each. We'll kid him about that later.
Well, let's kid him about it now.
Okay. All right, and you guys have 2 minutes each.
Thank you, Madam Chair, members of the committee. I'm Ann Seacott. I'm speaking to you today on behalf of the Maryland chapter of the National Association of Social Workers in strong support of Senate Bill 863. We thank Senator McCray for introducing the bill, and as I will echo the thanks again to the chair and her longtime leadership on this issue. This committee passed a bill a couple weeks ago that required some reporting. One of the pieces of that bill also directs the department to look at the costs so that more appropriate rates can be created. So I think this is a very complementary bill, the two bills that you've been working on. Social workers support this bill because it does three so important things. The first is it helps people. When we have a well-paid, well-trained workforce, they're providing services, better services. When they've got a job that pays a decent wage, they're going to stick with that job longer. And that helps the people they're serving. The turnover rates in these positions are astronomical. And it is so important to make sure that we're providing, that as a state, the policies that we pass are encouraging of the best quality services for our loved ones. The bill helps the workers, obviously, creating that mandatory minimum wage, and it helps the employers by increasing those rates. It's what we will call a win-win-win. The fiscal note, as has been noted, doesn't take into account the likely federal dollars coming, nor the offset for the very expensive alternatives to home care. So we think that this is just very smart policy that is going to help a workforce that's in need, as well as our community members who are so dependent on these services. So with that, we ask for your favorable report.
Thank you very much. Okay, Lester Brennan.
Hi, this is Audrey Sellers. I'm here to deliver testimony on behalf of Brennan Lester.
I can't do that.
Okay.
Oh, I'm sorry. Okay. What about Christopher Mayer?
Thank you, Madam Chair, members of the committee. My name is Christopher Meyer. I'm a research analyst at the Maryland Center on Economic Policy. We're a nonpartisan, nonprofit organization that works to build equitable prosperity in Maryland through research-backed policy, and I'm here in strong support of Senate Bill 863. Home care workers provide enormously important services to aging Marylanders and Marylanders with disabilities, but the fact is the system we have now is dysfunctional because of a severe workforce crisis. And that dysfunction is it's guaranteed to get more severe in coming years. As of 2015, 18% of Maryland's adult population was 65 years old or older. By 2025, that's going to increase to 24%. By 2030, it's going to increase to 27%. That's based on data from the Maryland Department of Planning. So as the need for these workers is increasing, we need to increase wages to ensure that it's actually an attractive occupation. As of 2020, personal care aides in Maryland took home typically only $13.51 an hour. This bill is a matter of justice, as you've heard from other witnesses. The home care workforce is overwhelmingly women and predominantly workers of color. It's also a matter of justice for Marylanders with disabilities who need to have access to care. It's also the right choice for Maryland's economy. Putting more money into low-wage workers' pockets means stronger sales at local businesses. Increasing access to care will strengthen our workforce generally because they won't have to deal with that themselves. And something that this body has been very concerned with this year is making Maryland an attractive place to retire. I'll tell you, access to long-term care is an essential part of that. Thank you. I ask for a favorable report.
Thank you. And Claudia Bailog.
Thank you, Chair Kelly, Vice Chair Feldman. For the record, my name is Claudia Bailog. I'm with 1199 SEIU, representing 10,000 workers in hospitals, nursing homes, clinics across the region. I'm also here in support of SB 863. I want to frame my remarks around the staffing crisis. Our members are working under dire conditions right now with short staffing in all of our facilities. And we know that their counterparts in home and community-based services are no exception to this. Clients who can't find caregivers will inevitably end up in short-staffed nursing homes and short-staffed hospitals. And I would take this a step further. I would argue that our unique Maryland hospital rate reimbursement system is put under tremendous pressure when long-term care settings are struggling to keep their patients out of the hospital. So with that, I want to pivot to what is possible. There are states responding to the staffing crisis because it's a national crisis with massive investments in PCA wages and personal care attendant wages. New Jersey is investing over $600 million into raising the PCA rate to $23 an hour. Tennessee is investing $140 million to fund wages of these workers. Wisconsin, over $200 million. I want to put those numbers out there to put our fiscal note into context. These states are using ARPA, American Rescue Plan dollars, to jumpstart these wage increases, but they're committing to finding the revenue streams to continue those rates when the ARPA dollars eventually dry out in 2024. So with all of these things, I urge this committee for a favorable report. Thank you.
Thank you. All right, we're going to call on Dana Kaufman, who is favorable with the amendment. Oh, you have a question?
Yes, I wanted to ask a question. I'm looking here at the fiscal summary. Did you all look at that to see the increase of an increase about $65.9 million? You all agree with that?
I think the increase wasn't to the workers, though, it was to the owners.
I'm sorry?
The increase wasn't for the workers. That's why they are here. The increases went to the companies.
And just.
The Medicaid expenditure?
Right. The Medicaid expenditures of 35.7 million. And, again, this doesn't include the offset when people are able to receive services in their homes and not go to much more expensive nursing homes. And it doesn't take into account the potential federal dollars. I'm sorry, I think all of us are sorry that a lot of that money hasn't been approved yet. But it's one of the areas of some of the recent discussions about additional federal aid that actually has very little opposition.
Well, quite frankly, that doesn't negate the fact that we have to give these personal care workers deserve the money that we're requesting.
Absolutely.
So we can't, okay, I've got it. I understand.
Okay.
Thank you.
Thank you, and thanks to all of you. All right, we're now going to hear from Dana Kaufman, who's favorable with an amendment.
Good afternoon, Chair Kelly, members of the committee. For the record, I'm Dana Kaufman. I'm here on behalf of the Maryland National Capital Home Care Association. We are support with amendments, but before I explain the amendments, I do want to put a couple issues on the table. So first, we agree that the personal care aides need to have higher wages. At this point, with the market trends, it is very difficult to even hire because they can go to Amazon warehouse, they can go to big box stores, they can go to fast food restaurants and get a higher wage. But that issue also falls squarely on the Medicaid budget. And the Medicaid budget, and I sound like a broken record because I say it all the time in front of this committee, inadequately funds our programs. And that's not just me saying it. You can go back to the 2018 study that was done by Hilltop Institute, and it basically says that in 2018, and my figure is actually wrong, I lowballed it on here, I typo, but in 2018, they said that the cost to cover services should have been $25.54. Right now, 4 years later, it's only
$20.54, and that's 4 years later, and we're not anywhere near what they said it should have been 4 years ago. And while the state has asked for detailed plans to decrease that cost differential, that has not happened. So until we actually increase the Medicaid program overall, it's almost impossible for the providers to be increasing wages. Now, to that extent, though, the bill does do two things. It does increase the Medicaid allocation by 15%, which then will trigger the ability to pay a higher wage of $16. But right now, we had estimated that the average, now again, this is the average, is $13.25, the hourly wage, but that didn't take into account cost associated with hiring employees, and that's your payroll tax, your workers' compensation, your unemployment. These are all mandated, they're all unavoidable. So after we looked at what the wage is being paid now, on average, and those additional costs, to get to 16, we would need an increase of 20.8%. So again, it would increase, but that would allow us to then increase to $16. But I will also point out that still doesn't address the underfunding situation that we have. So we're still behind the 8 ball. So my time is up, so I will stop talking. But in my written testimony, there are some other amendments, because the one thing I'm going to add is this is not my first rodeo with this, and we need language that says this money should supplement and not supplant, because I have seen that happen too many times. Thank you.
Since you're the only person that had the amendments, do you want to quickly just go over the basic parameters of your amendments?
Sure. So the first amendment, and the most important, is the fact of increasing the 15% to 20.8%, which then we feel will be able to give the residential service agencies, the provider agencies, the ability to pay $16. But at the same time, we need to have language that this money would supplement and not supplant the current reimbursement rates. What we don't want happening is that right now the mandate is 4%. We don't want the 20.8 or 15, however you want to say it, to encompass the 4%, because that 4% is to offset the increases in minimum wage, which are still going up. So that's what our one of our main concerns. But we have to be careful, because like I said, I've been down this path before. Back in '98, $60 million went into increase wages in the nursing homes for direct care workers. The Great Recession hit, the monies got cut, but the wages stayed the same, and the providers were left holding how to pay for higher wages when they had the baseline cut. I've also seen it with what you call their quality assessment, but we've always referred to as the provider tax as well. And then the other amendments that we had really just put more of the processes that are in the bill in the scope of the department to figure out.
Okay. Thank you very much. No other lights. Thanks so very much. Okay, and that ends the testimony on 863. We're going now to Senate Bill 633, Senator Kagan, Public Safety 911 Emergency Telephone System Alterations. And let me call up your first few panelists. Let's see. Okay, Russell Strickland, William Ferretti, Steve Sauter, and John Ripley. Okay. Madam Sponsor, you have the time that you need to lay out the parameters of your bill, and everybody else gets 2 minutes each. All of these bills are worthy of more, but we just can't do it unless we're going to stay here to midnight.
I understand that. Thank you so much, Madam Chair, Mr. Vice Chair. For the record, Cheryl Kagan, proud to be the Senator for Gaithersburg and Rockville, and for the last 4 years, Chair of the Next Generation 911 Commission. Before I start, I really just want to thank Nathan McCurdy and Tammy Kraft. Your staff is so kind and helpful and smart, and we just appreciate them for people who don't get to work with them every day. So thank you all. I also want to give a shout out to Senator Riley, as well as now Senator Jackson, and delegates Sue Krebs and Terry Hill for their participation and commitment to upgrading our 911 services around the state. My journey on 911 started right here in the Finance Committee 7 years ago with your predecessor, Madam Chair. And I think most of you have heard me say that 3 people have died in my district when 911 has failed. And so Maryland is now, thanks to your leadership and passing 11 laws, Maryland is at the forefront nationally in updating our 911 systems. You all have worked to change the funding, the cybersecurity, the training, the staffing, recruitment, oversight, accountability, and so many other aspects. And so this is the 4th and final omnibus bill, and there are 9 aspects of it. And I have the 4 annual reports. You all have seen these. This is the big one. This is the last year, and I think you all got copies, but happy to share them, and they're on my website if you want an actual copy. I'm going to run through the 9 pieces, and then I'm so honored to have Secretary Strickland, the Vice Chair of the Commission, Steve Souter, 54 years in 911, and the fabulous Bill Ferretti, who, even though he retired, moved out of state, was kind enough to come back and testify. I'm going to start the 9. First off, cybersecurity. We have already taken a bunch of measures. We have a cleanup, just making sure that all 24 counties are keeping their 911 centers updated with cybersecurity best practices. If they are not compliant, the 911 board will be meeting with staff, negotiating a plan, an implementation plan, and a timetable. There could be fiscal consequences if they do not keep their cybersecurity plans updated. When we passed the Carl Henn Law in 2017, one of the things that we did was modify the funding structure in 3 ways. We took the 25-cent state portion of the fee and made that 50 cents. So everyone, rather than paying $1 for their phone service, their 911 fee, they were paying $1.25. No one complained. That was fine. We closed the loophole, so if you had one phone, you were paying $1.25. But if you had a family plan and it was, 2 parents and 2 kids, rather than paying $1 or $1.25, you would pay a service for each of the 4 phones, so you'd pay $5 a month. But again, if you're in a car crash or grandma's dying of a heart attack, nobody begrudged making that call. The third thing we did was authorize the counties to raise their local 75-cent portion of their fee up to another 75 cents. And that was just, we thought it might be a dime or a quarter. Well, it turns out there is such a funding shortfall, and almost every county is still needing to pull funds from their general fund budget, from the money that would pay for our schools, our roads, our health care, our arts. And they were taking that money, taking it out of that fund to pay for their 911 centers. So a bunch of counties have already increased the local portion of the funds and have already increased it to the maximum, including pretty conservative red districts, because they want to make sure that they are saving lives. So this would, so what we said is, rather than having counties come back every couple of years and beg the General Assembly for permission to raise it by another dime or a quarter, we're just going to say, you guys are our duly local elected officials. You can't spend the money on anything other than 911. So if you want to raise it, this would authorize the local jurisdictions to raise it, and they would be accountable to the voters and to their local county councils, county commissioners, county executives. The comptroller, we have not been able to get good information about the collection of the 911 fees from over 100 telecommunications company providers. So are they assessing the right amount of fee, and are they remitting it correctly and with accurate information, because that then gets distributed to the 911 board and to the 24 counties. We got one report that was astonishing and actually revealed a multi-million-dollar shortfall that, that the comptroller and his team is working on. We want regular audits, and we want the 911 board to have access to that information. Number 4, the current law has the governor appointing the chair of the 911 board, which is pretty unusual. Secretary Cavey told me, I think it was like 15% or something. It's a pretty small percent where the governor not just appoints the people, but then picks who the chair is. Well, God forbid if the chair needs to leave or has a health problem or something, there was no vice chair. There was no succession policy. And when we're talking 911, we can't have a glitch in that. So we said, you know what, let the 911 board members select the chair, and let's create a position of vice chair for a smooth transition. And everybody seemed to think that that was a good idea. Next is reclassification, and Senator Simonaire and Delegate Kipke have a bill that just does this, and that is just making our 911 specialists, the courageous women and men under the headset, reclassifying them as first responders, as has been done in 9 other states, red and blue: California, Georgia, Idaho, Iowa, Indiana, Kansas, Texas, New York, and Oregon have already reclassified them. There's no cost, but it's respect and appropriate to do. Implicit bias training was something that you all amended in last year's 911 omnibus bill. We took that seriously, and the commission, the 911 commission that I have chaired, spent time on implicit bias. We collected data from our 911 specialists that is filed in that's in your folder, and we have collected by gender, by race, and maybe something else, but you have that data. And so we are also recommending regular implicit bias training for our 911 specialists on a regular basis when they start, and then regularly after that. Occupational wellness. You're going to hear more in the next bill about the truly unbelievable strains that our 911 specialists are under in their jobs. We are proposing in this to offer them direct access to mental health care. Don't have to go to their supervisor, don't have to get permission. Let's keep it confidential between the 911 specialist and a mental health care provider. We think that's common sense. And again, mostly all of these were approved unanimously by the commission, which has just every interest group representing. Addressing 911 specialist compensation, I was astonished to learn that there may be some counties that are paying the 911 specialists minimum wage. And these are the folks who are the first responders. And without their presence and training and skill set and calmness in the face of crisis, literally we will not have police, fire, and paramedic appropriately trained to respond to a crisis. We don't say how much they should be paid, but it should not be minimum wage. And the last thing is the 911 operations, the 911 board. We just are creating a protocol as to how to fill vacancies. We had, I think, 5 vacancies that had been sitting for many, many months, and it was just, that was a problem. We want the diversity of expertise and geography that board needs. I will just say also the 911 board has now been moved based on the law that we passed last year to create a new cabinet-level department, the Maryland Department of Emergency Management, and we have now approved the cabinet secretary. Secretary Strickland is with me today endorsing this legislation. It used to be the Maryland Department of Emergency Management, and we moved the 911 board from the Department of Public Safety and Corrections, where it never belonged, into under the Department of Emergency Management. And so we want to continue that partnership and make sure that those vacancies are filled. Just for those who are live streaming and don't have access to the file, in addition to the folks up here and who are going to follow, we do have a lot of written testimony, including from the Anne Arundel County Executive, Stuart Pittman, the Baltimore City 911 Center, the Baltimore County Federation of Public Employees, Maryland State Police, Secular, which does cybersecurity, and the 911 Training Institute, a national institute, so, and a bunch more. With that, Madam Chair, I'd be happy to take questions or turn it over to my panelists.
There is no opposition to your bill, so we want to quickly hear from the rest of your folks. We'll be here about another 6 or 7 hours with the number of bills. So you got a good bill, and people agree with you already, and so do we. All right.
Well, Chairman Kelly, Vice Chairman Feldman, members of the committee, thank you for having me here today. My name is Russell Strickland. I am the Secretary of the Maryland Department of Emergency Management, and I am here in support of Senate Bill 633. I've submitted written requirements outlining why this bill is important to the state's 911 system. And today I simply want to reiterate that the Maryland Department of Emergency Management appreciates the leadership of Senator Kagan and Senator Riley on the 911 improvement in Maryland. As a new home of the 911 board, we stand ready to assist the board with the resources they need to implement the changes in this bill. I appreciate the opportunity to share the department's position regarding this bill and respectfully request a favorable report on Senate Bill 633. Thank you.
Thank you. All right. And now we're going to William Ferretti. Good
afternoon, Madam Chair. Madam Chair, Mr. Vice Chair, members of the committee, my name is Bill Ferretti. I am a retired director from Montgomery County 911. I had the honor to serve on the commission while still working in Maryland, and since then I've been advising the commission, and I've been proud to do it. This bill really comes down to a culmination of 4 years' worth of work from the commission. Excellent leadership by by Senator Kagan, by Senator Riley, by now Senator Jackson, Delegate Hill, and Delegate Krebs, and all the work that this legislative body has done for us over the past 3 years to recognize our asks. And really, this comes down to two areas where we've found additional opportunities for improvement: people and accountability. Accountability in terms of remittance of fees, accountability to make sure that our PSAPs in the areas of cybersecurity and training are living up to the standards that we ask them to. As members of Maryland, and then from people, making sure that the counties have the resources through the fee in order to pay the people that they need to do the job, they have the resources they need, and then also that the board that's overseeing this work is operated efficiently and is fully staffed with all of their members. So with that, I would ask for a favorable report on Senate Bill 633.
Thank you. Now we go to Kevin Kennelly.
Madam Chair, Committee, good afternoon. Steve Souter, Vice Chair of the 911 Commission. Thank you for your service to Maryland, and we appreciate our opportunity to serve as well. Of all of the various topics spoken about here at the table, the one that's dearest to my heart are people. People that run 911, people that answer the 911 call. We can buy all the technology in the world, but behind it all is a human being that works under incredibly stressful circumstances, a human being that we have to be very careful about how we recruit, how we train, how we retain, and yet what we find time after time after time is that those people either drop out, they wear out, or they burn out. And our investment in human capital goes out the door. We have a duty and we have a responsibility to ensure that those people that are on the front line of every emergency that's reported in the state of Maryland are properly compensated, properly trained, properly retrained, properly benefited, and you can go on and on and on. It is absolutely asinine for us to invest that kind of money and have that investment go bye-bye. So thank you very much for your support. I appreciate it very much, and thank you.
Thank you. Okay. We should hear next from John Ripley, Kirsten Newman, Tiffany Harvey, and Susan Greentree.
Good afternoon, Madam Chairman, members of the committee. Kevin Canale here on behalf of the Maryland Association of Counties. It's a great bill. This is a culmination of a lot of great work that this commission has done. Me too on everything you heard, and we'd ask for a favorable report.
Thank you.
Good afternoon, members of the committee, Chairwoman Kelly, Vice Chair Feldman, and members of the committee. Tiffany Harvey on behalf of Comcast. My colleague, my predecessor, Sean Looney, was a very active participant in this work group and all the work that was done. I believe he submitted testimony, and he's watching from afar because he loves this issue so much. And we would say us too, and we ask for a favorable committee report on this bill.
Thank you.
Good afternoon, Madam Chair, members of the committee. Again, my name is John Ripley, and we're asking for a favorable report on Senate Bill 633. I want to first start by thanking Senator Kagan, Senator Riley, Delegate Hill, and other members of the Next Gen Commission. This is invaluable work, and I appreciate everything that they've done. I represent about 250 active Baltimore County 911 Center operators and dispatchers. They are the true first responders in any emergency, and we believe firmly that they ought to be correctly reclassified as such. Simply put, they are the true first responders, and I hope you support Senate Bill 633.
Thank you very much. Did we hear from everybody? Thanks so very much. Okay.
Okay, thank you, Madam Chair, Vice Chair, and the committee. I worked for Anne Arundel County. My name is Susan Greentree, and I worked for Anne Arundel County 911 Center for a little over 35 years. I'm going to share a couple of stories with you. Okay. Well, the reclassification, the tremendous complexity and advancements in 911 since I started in 1984, but what has not changed is that when you have an emergency, the first person that you speak to, the one that you explain your emergency to, who helps you while units are en route, is the 911 specialist. Calls vary moment to moment. The victims of crimes, home invasions, drugs, accidents, domestics, all of these types of incidents. When you've called, these are likely maybe one time you called in your life. They're very infrequent, I would certainly hope. To a 911 specialist, this is what we hear, what we triage, and what we go home with every single day. So I would urge you to have a favorable report for Senate Bill 633. Is that right?
Thank you.
On the reclassification. Thank you.
Thanks so very much. Okay. Now, Senator Kagan, you can stay right there. We're going to your Senate Bill 374, Workers' Comp, Occupational Disease Presumption 911 Specialist. And let me call up your panel. Susan Greentree, Robert Phillips, Matt Pavola, and Steve Sauter. And if somebody doesn't want to have to sit down and get up again, you can even use that standing mic. Okay. All right.
Madam Chair, Mr. Vice Chair, colleagues, for the record, Cheryl Kagan, very proud to be the senator for Gaithersburg and Rockville, and again, for 4 years, the chair of the Next Generation 911 Commission. Colleagues, this is not going to be the kumbaya, and it's not going to be an easy bill to hear about today. The case that I want to make is that the courageous women and men under the headsets are 911 specialists who are our first responders, deserve a very narrow presumption just for PTSD, post-traumatic stress disorder, for the unbelievable careers that we are blessed that they have chosen. It takes between 8 and 12 months to recruit and train a 911 specialist and have them be working under the headset independently. On your worst day, when you call 911, you want someone who is calm, who is focused, who is trained, and who is competent to respond with police, fire, or paramedics. But even more than that, you need someone who is steady and who isn't going to necessarily be burdened from yesterday's call or the call that they just got an hour ago. These, and this is the way I talk about them, these first responders, the courageous women and men under the headsets, listen to suicides in their ear. They listen to mass murder. They listen to someone in a wheelchair whose house is on fire and they're not sure where they're going to live or whether they're going to be able to get out in time. A baby who isn't breathing. I mean, the stories are awful. I sent to each of you on this committee a link to about 2.5 minutes of just audio. And Madam Chair, I understand why you didn't want to live stream it. It's brutal. And it gives an idea of the stuff that they have to listen to every shift. And the problem is that when they answer the phone, they don't know what they're getting. So it could be a 10-year-old boy whose kitty cat is up a tree, and he wants a firefighter to come and help get their kitty down. Or it could be someone who was just raped, or someone having another sort of crisis. And you're going to hear some stories. One of the most unbelievably impressive national experts on 911 trauma is Jim Marshall. He wrote a book, and I have read the entire book, called The Resilient 911 Professional. I'm going to read you just a couple of sentences. 911 professionals experience rates of PTSD at a rate 4 to 5 times greater than the general population, multiple times higher than the general public, and on par or greater than other emergency responders. This rate, estimated at 24.6%, utilizing civilian cutoff scores on screening instruments used in the study, 24.6% may be inaccurately low. There's really a culture of we're tough and we can hang on and it's fine. A more recent study suggests that PTSD rate among the 911 workforce may exceed 30%. So part of it is what they hear. Part of it is also what they have to imagine. Because unlike our first responders, these first responders, our 911 specialists, don't get to be the heroes and sheroes. They don't get to come in and put out the fire or catch the bad guy or give CPR to grandma so that she lives. They wonder what happens, and they don't know. And while ideally they should leave that trauma and that stress with them at the office, too often they bring it home. And you're going to hear stories about some of the challenges with bringing home and the long-term impacts. I have to give a special shout out to Senator Riley, who wanted to testify as a father-in-law, not just as my partner on all things 911, not just as a senator, but his son-in-law took the job as a 911 specialist, and he tells the stories that even in a brief space of 1 year working in Anne Arundel County, that he saw the change in his son-in-law, that he saw the stress and the toll that that took on his son-in-law, therefore on his daughter, and on their family. It is brutal. We need our 911 specialists to be healthy, able to show up literally, physically, and psychologically. They've got to be effective at responding to traumas. Between 18 and 24% of 911 specialists experience PTSD compared to 3.6%. That was a different study. There was a Fairfax County study that showed that 14.5% in Fairfax County of public safety communications personnel who had responded to the survey had had suicidal thoughts within the past year. And this is not hypothetical. On June 4th of last year, Hartford County 911 specialist Eric Ishak died by suicide. A 911 specialist in Hartford County. This is not hypothetical. It happens. He was a husband, he was a new father, and he's dead because of his job. That shouldn't happen. We need to provide the mental health care. We need to provide the support. Now, there are...
So what do we need from workers' comp that we don't have now in order to?
Thank you for asking. So some of the opponents are going to say, oh, it's a slippery slope, and everybody should be covered. A lot of people have hard jobs. These folks are invisible unless they screw up. If somebody dies on their watch and they live with that every day, I will tell you that there's a 911 specialist who couldn't get someone to cover her shift in Frederick County. She's a supervisor. And as you all may remember, a few months ago, there was a Frederick County fire chief who died in a fire. And the woman under the headset during that call not only had to go home that day because of the guilt and the tears and all that, she couldn't come in the next day. And then when they live streamed the funeral, and kind of everyone, the governor was there and firefighters came from around the country to honor his passing, she was on shift. And she found it hard to continue on. These cases, and you will hear from some of these folks, these cases stay with them. So, Madam Chair, to answer your question directly, we need to have a PTSD presumption, very narrowly. They must get evaluated by a psychologist or psychiatrist who is licensed in the state, in the jurisdiction. It's not, the example that I give, and I don't mean to sound flip, but they don't come in for workers' comp for diabetes because they're obese because they eat Twinkies on their shift all day. It's not that. It is super narrow, and MACO, Maryland Association of Counties, was on the commission. We worked really hard, and my commitment was to keep this super narrow. Our data is, and Chesapeake and workers' comp folks are going to come in, and they're going to say that there were 339 cases. 339. Abby, I'm looking for the chart. 339 cases over the last 5 years, if memory serves. 5 years, and that is not just worker for 911 specialists. That's for all folks. 339 cases. We are not talking about an avalanche of thousands of new cases. You're going to hear about a case that has taken more than 3 years and is not yet resolved, and the 911 specialist has to relive every trauma and every case, every nightmare that she brings home.
So if we just had the presumption, they don't have to go through trying to prove one by one, case
Exactly.
by case.
Just level put a small thumb on the balance so that we can give them the scale of some support and some treatment and some support. So with that,
Senator Feldman has a question for you.
Yeah, just because, you don't get rebuttal, so anticipating the
Yeah.
opposition. So in looking at their testimony, that, I think what you're going to hear, and this will give you an opportunity to respond, is that PTSD is a compensable occupational disease under our case law, but that no claim for 911 folks has ever been denied. So the presumption is, there's merit to presumption, but in this case, they're going to, I think, say nobody's ever been denied a workers' comp claim alleging that, so therefore, do we need the presumption? So I'm just going to put that in front of you, and I don't know that's what they're going to say, but I'm sensing that from the testimony.
I think it's pretty likely they will say that.
If I could just follow up, if it takes them 2 or 3 years, however, to not be denied.
Correct.
While they suffer without compensation, is that good enough?
No, and let me speak to both of those. And first off, what if they're then not under the headset and it takes longer and longer to get the phone answered when there's a crisis? So if no one is being denied, and I'm not sure whether that's the case, but then there's no harm. And if they're saying, If they're saying that they're already being compensated, they're already being recognized, then again, there's no change. They can't have it both ways. They can't say, well, we're already approving everyone, but we don't want to make it official. They're dragging these folks through such a traumatic, awful process when they already live through trauma every day under the headset. Again, we have a shortage in our workforce, in our 911 centers. And I will say again, I don't know if I said it on this bill hearing, when 911 fails, people die. And if your house is on fire and you call 911 and you get voicemail or you get put on hold because someone had a nervous breakdown or, God forbid, died by suicide, and it takes a year to replace them, to train a replacement, and we don't pay them enough, that's a problem. We've got to take care of these courageous women and men. So I'd love you to hear from some of these witnesses. We know that there's opposition. I'm so passionate about this. This is the right thing to do, colleagues. It's the right thing to do. Super narrow. The world will not end. Please give this bill a favorable report. And now I want you to hear some stories from some of my colleagues here. And I'm leading off. Because we didn't get to play the tape, I am going to ask the chair's indulgence just for this witness. If she needs a little bit more time, she has some stories that I think the committee should hear.
Okay.
Thank you for your consideration.
All right.
Hi. Thank you, Madam Chair, Vice Chair, and the whole committee for your time. I'm just going to tell you some of the calls that I've experienced over the years. My name is Susan Greentree, and I worked with Anne Arundel County for a little over 35 years. So there was a call that I took where the teenage girl living in Severna Park, her mother came home from work and found her daughter hanging. The mother was hysterical. I'm trying to calm her down, trying to get some information, got the unit started, and I'm trying to talk her into how she can cut the rope down, get her daughter down. She's unable to reach. She's by herself. She cannot reach her. And she's not sure. She thinks maybe she's still alive, but she doesn't know. She can't tell. So I tell her to just grab her by her legs, hold her up. She's doing that. Time is passing. It takes time. It seems forever to her, but the units are on the way. And she starts saying, I can't hold her anymore. She's slipping. I can't hold her. I'm like, you can. You're a mom. We are moms, and we can do this. Her daughter, my daughter, at the time were the same age. Anyhow, she held her up till they got there. The medics got there. The girl was in cardiac arrest. They were able to get her some treatment, took her straight uptown Baltimore to a hospital. I found out from my own daughter that the girl did live couple of months in the hospital, several months in rehab, and she survived. I know if I had not been on that phone with her, coaching her through, her daughter would not be alive today. That terrible story, but it had a good ending at least. A call from a person a resident who they were having tree work done in their yard. This was in Crownsville, just a couple 2 years ago maybe, and a tree trimmer fell from the very height. Co-workers were hysterical, could not do anything. The homeowner trying to give him instructions on CPR. He's not sure. He thinks he might see the chest moving, but he's not sure. We're doing CPR. The mouth's filling up with blood. Tilt him up. Drain his mouth. Get it back down. Okay, let's continue. And I'm helping him pace the CPR the way it should be. And then all of a sudden, he's something coming out of his mouth. And fortunately, units arrived. In any event, there were brains. There were brains coming out of the patient's mouth. That patient obviously did not live.
I wish we could go on, but we can't because we've got about 50 more people to listen to, and I don't want some of them to call 911 before the day is over.
Okay. All right.
But
thank you.
You really make us think, and you help us to envision what the job is like.
I'm glad. It's just years of that sort of thing that I know how it changes me.
Sure.
So thank you. I wish for a favorable report on this Senate Bill 374.
Robert Phillips.
Yes, ma'am.
Good afternoon. My name is Robert Phillips. I am the chairman of the Maryland State Firefighters Association Legislative Committee. I supplied written testimony I'm sure you've read, but to that I want to relate a personal side to this bill. I know firsthand the issues of being a 911 dispatcher. I am not one, but my wife was one for 17 years, and I know the toll it has taken on her. The dispatchers, or as they're now properly being called, specialists, they take every type of call. Easy. Senator Kagan said it very well. Young boy goes out and his cat's up in the tree and he calls for the fire department to get it. I've been on that call. Up to things that are very, very much worse. For them, they're the calming voice on the other end of the black box. They take the information and they dispatch the first responders. And while the others are responding, the dispatcher is the one who has to try to keep the caller alert, often giving life-saving information until the rest of the cavalry arrives. Then many times, sadly, they don't know what the final outcome is. They don't get their closure. I know the call she took because I was there at home at night when she would wake up out of sleep screaming. She was taking the calls again. I remember vividly the first one. All she could say was, "It's just a baby." That was it. It got her. It eventually got her. She came home after a shift one night and sat in the middle of the living room floor and just cried. She couldn't do it anymore. But that was just the beginning. It wasn't the beginning of the end. It was another beginning. She started getting professional help on her own. She used her own vacation time, what sick time she could. And it came out of, since it wasn't a filed claim, it came out of our insurance. So, you know, that's what it was. But then it got to the point that it couldn't continue like that, and she had to file a claim. And that's what this bill was all about. She had to convince the hearing officer that it was her job. And that's where the problem was. It was her job. And she sat there before that hearing officer, and I don't want anybody to think I'm being unkind about it, because the hearing officers and the lawyers have their job to do, and I agree with that. But she had to convince them that it was her job. It wasn't, she didn't have a good relationship with her father, she had trouble with her son. You know, they came up with all kinds of really good ideas. But she had to convince them she was guilty until she proved herself innocent. The hearing officer asked her, "Can you name 3 calls? Can you just name 3 calls that bothered you?" She named 27. Right off her head. She had to relive every call. That's rough. They don't need to do that. They need help. That's what this bill was all about. Sorry if I'm a little upset. I personally hope there is neither other dispatcher that ever has to go through this. If they need help, they need help. If it was me in the fire service, 43 years, that's fine. You need help. She is not considered the same as a first responder, does not get the same respect. The MSFA and myself personally ask for a favorable report. Thank you.
Thank you very much. Okay, you're next.
Chief, first, it's an honor to follow you. Thank you. Committee, again, good afternoon. Many of you know I've been in the 911 field all of my life. 54 years to be exact, 61 years in dispatch. And oftentimes people will ask me, what was the most interesting call? What was the most dramatic call? What was the most memorable call that you ever took? And it is without a question easy to answer. It was in the late 1970s. I was working for the District of Columbia Fire Department. We got a 911 call from a pay telephone at the west end of the Calvert Street Bridge in Washington, D.C. That's the bridge that crosses Rock Creek Park, just a little bit north of the zoo. And the reason there was a phone booth there is because it was a bridge that was famous for people jumping off it to commit suicide. And as I picked up that phone, there was somebody on the phone that was threatening to commit suicide. And for the next 2 hours, I talked with him. Gary was his name, and he ended up calling me Steve. And during that 2-hour period of time, there were peaks and there were valleys to our conversation. And sometimes I think I had talked him out of it, and other times I was doubting myself. And at the end of 2 hours, he said, "Steve, thank you, buddy. It was nice talking to you, but I'm jumping." And I heard the phone drop and bang against the side wall of the phone booth, and it went silent. So it's very, very easy for me to remember that. And at that time, I had absolutely no training in how to deal with a threatening suicide, and absolutely no support for having to do with the aftermath of that. Because post-traumatic stress disorder was not even part of our jargon back then. But over these many, many years, I've answered many more calls, and many of them were suicides, and I have never, ever forgotten that call or the one that followed. I do not want our 911 specialists of today to experience what I have experienced. If they need help, they deserve to get help. You've heard the numbers, small as they are. You've heard the impact, as large as they are. And I ask for you, please, to vote favorably for this bill.
Thank you very much.
Thank you.
All right, now let's go to your next panel. If these people could come forward. John Ripley, Kirsten Newman, James Lanier, Kashir Kachelian. You have 2 minutes each. And let me just say this. Previous panels have really made the point in terms of how much stress people are under and how much psychological nerve-wrackedness is going on in their daily lives as they take these calls. If you feel that that point has been made well, and you want to just say, "I'm here because I agree," that's fine. If there's a big point that we're missing, if there's something else that you know is happening in the back and forth between the departments and the government of Maryland and the attempt to get what you're asking for, make sure we understand that. Okay? Thank you.
Madam Chair, members of the committee, again, my name is John Ripley, and I'm here asking for a favorable report on Senate Bill 374. I'm the president of the Baltimore County Federation of Public Employees, representing about 250 Baltimore County 911 Center specialists. They are the true first responders. Eliminating or adding this presumption will simply eliminate hurdles, added and unnecessary hurdles, and prevent a delay in thorough treatment. These are emergency responders. They deal with emergency after emergency. They don't just deal with it, they live through these emergencies. And I ask for your support of Senate Bill 734.
Thank you so very much. All right, Kirsten?
Thank you. Matt Pavola, and I'm with the Maryland Association of Justice, asking for a favorable decision for SB 374.
Okay. All right.
It's an honor to have testify after all of this compelling testimony. Now I'm going to take you from these extraordinary experiences you just heard about and take you into the mundane world of the trial court. We just can't roll, just because there's a presumption doesn't mean we don't have to prove our case. We still have to prove the elements of the case. To your point, Senator Feldman, presumptions are helpful, no question. But there has not been, we've contained presumptions over the years in this legislation, and adding this one will not drastically change anything. What it means is simply that we still have to produce a report from a psychologist or a psychiatrist. We still have to put our client on the stand. They have to testify. They have to prove that there was subjective exposure that led to the disease, and they have to prove objective through proving that they were exposed to a hazard. So we still have to prove our case. Then the defense produces its witness, its expert, perhaps some witnesses from employment, and the defense then has this opportunity to disprove the presumption, to rebut it, in other words. Finally, so the point is that there's still a full-fledged trial. It just gives us a slight advantage to these specialists, these 911 specialists. Finally, as I see my seconds ticking away, the fiscal impact will be minimal. It's occupational disease; those are very rare. It's the presumption. It's also the permanent partial disability at the end is a very small award on a psychological damage case. Thank you for that opportunity to testify.
That's very helpful testimony. All right, now, did we hear from Steve Sauter?
Oh. Yes.
Okay, all right.
Thank you.
Okay, and you are Susan.
Hello. Yes. Again, my name is Keisha Gachalian. I've been a 911 call taker and a police dispatcher for the last 20 years. I'm not going to say any more stories. You guys have heard it. We have a stressful job. What I will say is that 911 specialists need more than what we're getting for our mental health. I will say at Baltimore County, we have a table in our mailroom with brochures. We have an email maybe once a month asking about our mental health. That's it. We also have a brochure given to us about EAP and say, go see a therapist. And a lot of times what we have is each other to depend on and to talk to, and I will say that a dispatcher that handled a police officer death, it affected him very deeply to the point where he looked towards substance abuse. And as his colleague, he turned to me a lot, and at 7 o'clock in the morning when he's calling me drunk, talking about this, I am not a therapist. I will be there for him, but he needs much more than that. And so for that, I want you to vote favorably for this.
That's very helpful. Okay, did we? Yeah, Senator Klossman.
Yeah, when you said you need more mental health, that's what's been going through my mind. Is there a program that the county offers for these folks? I mean, when you get burned out that bad, is there something that they do with their employees to try to reverse that, to try to get them over those humps of burned out?
They have EAP, which is the Employee Assistance Program, which you can go through Cigna. And they give brochures, but a lot of the employees there, they need more assistance and they need more guidance to go seek that help. But as far as I know, there's no certain program for 911 specialists. Police department, fire department have their peer-to-peer meetings, and they also have people that they can go to. We also work closely with our mobile crisis response team, and every time a bad 911 call happens, they come into the center and they talk to us. But there's no specific program.
Has that ever been considered through your department with the union?
Not that I know of, no.
I think maybe
They're really
that might
trying
be
to
helpful.
get the,
I
workers'
understand that,
comp.
but I think that's part of the crux of the whole problem. They get burned out and have really, really heavy duty mental health issues, and they need to get over that. So I just think the county needs to look at that, or the state needs to look at that.
Yeah, but that's what they're trying to get is workers' comp as a presumption that they need it.
That's aside from the workers' comp.
But this bill is about, okay. All righty. All right, we heard from everybody on this panel, I believe. Okay. Who didn't we hear from? You may come and take the motion. All right, just state your name and you have 2 minutes each, and the mics are movable.
Okay. Chair Kelly and Vice Chair Feldman, thank you for allowing me to share my story today. Sorry. My name is Kirsten Newman, and I have a daughter, Vivian Newman. She is 4 years old. I'm here today because of my recent negative, almost deadly experience with 911 emergency services. My daughter is a cancer survivor. This past year, she's been participating in a clinical trial for maintenance treatment. The clinical trial includes a series of shots that create flu-like symptoms, including fever. Vivian received her final shot on February 15th. The following day, she developed a low-grade fever. Around 3 p.m., she suddenly stopped breathing. Her face began turning blue, and she started to seize. I grabbed my phone and dialed 911. I was greeted with the following message: "I'm sorry, we are experiencing high call volume, please hold." I was then put on hold while my daughter was seizing in my hands, and then it disconnected. This happened twice. From the time of my first phone call, 5 minutes passed before 911 called me back. By this time, our babysitter had reached a dispatcher. Unfortunately, it still took 15 minutes for an ambulance to reach our house. My daughter was barely breathing and seizing for 20 minutes. Vivian is okay, and her oncologist believes she had a complex febrile seizure. However, we are very lucky she does not have any lasting neurological damage, considering the amount of time it took to reach 911 and for the ambulance to arrive. I subsequently have learned that our county, with a population of almost 600,000, only has 6 dispatchers when fully staffed, and fire and ambulance has less. These people are working 12-hour shifts with no mental health support, are underpaid, and burn out quickly. Even Vivian's nurses at Johns Hopkins have easy access to mental health support. I am asking you to please support this Bill 374. This is literally a life or death situation for every resident of my county. Thank you.
Thank you very much. All right. Now we need to, let's see, did we hear from, let me make sure from the last group, we heard from Ripley, Newman, Lanier, and
I'm
Ketchum.
Lanier.
Okay, all right.
Good afternoon, Chairwoman Kelly and the members of the Senate Finance Committee. My name is James Lanier, and on behalf of the Maryland Association for Justice, we are obviously here favorable support for the Senate bill. Instead of hashing everything that's been said, I'll try to be brief and hit 3 things very quickly. The most important part of the presumption, and the most important part of workers' compensation generally, is medical care. Allowing the injured worker to get the medical care that they need, the presumption would make it a little bit that much easier, since we still, even though we have to still prove our case, then it makes it that much easier because then it's presumed that it's going to be part of the claim under the requirements of the job. Now, the employers and the insurers still have the right to come in and show that there was a pre-existing condition and that's what's really the cause of it. So it's not a rubber stamp. In addition to that, the purpose of the presumption is also a matter of public policy. It's a highlight. We have these presumptions for specific employments, for firefighters, for police officers, and for park police for Lyme disease. This highlights that these things are important to this state, and we acknowledge that we care about these specific types of employment, that we're going to allow these very narrow presumptions because we want these people to know that we care about their jobs and we want them to get the help, especially the medical help, that they deserve. Finally, we would not be the first state to do this. Senator Kagan's commission report highlights from the University of Maryland Law School that Colorado and Oregon also have very similar laws on the books for 911 specialists that Maryland is being asked to do. So we ask for a favorable report for this bill for all of the reasons that much more important than what I've had said here today.
That was very helpful testimony to remind us of really the limits of the importance of the presumption.
Thank you, Senator.
All right, thank you to all of you.
Madam
All
Chair,
right,
I'm
now,
just one sentence.
You know what, I really do need to go
Okay.
to the other.
Okay.
Okay.
Thank you all.
Okay. Let me call up Michael Daly, Carmine D'Alessandro, Ashley Smith, and Kevin Kennelly. All right. Let's see.
Let me start.
And as soon as someone is done, if you will move, we can let Julie Murray, who's also a part of your panel, come up.
Madam Chair, I think I'll start. So, good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is Carmine D'Alessandro. I'm Chief Legal Officer for Chesapeake Employers Insurance Company. We insure about 20% of the private market and workers' compensation in Maryland. We also insure 9 counties, approximately 130 municipalities. I also serve as the president of the Injured Workers Insurance Fund, which oversees the workers' compensation program for the state of Maryland. We are here to respectfully oppose Senate Bill 374. Senator Kagan and Senator Feldman have covered some of my testimony, so I should be able to be a little briefer than I intended. First, I think it's important to note that no other class of employees in Maryland has this presumption, not police officers, firefighters, correctional officers, EMTs. So right now, 9/11 operators, specialists are situated with all the other first responders when it comes to this condition in Maryland. As Senator Feldman alluded to, unlike those two other states that put this in legislation, Maryland post-traumatic stress is governed by two appellate courts in Maryland, Means versus Baltimore County, which found that post-traumatic stress was a viable occupational disease in Maryland. Mrs. Means was a paramedic. And Belcher versus T. Rowe Price found that post-traumatic stress was compensable as an accidental injury. As you know, in comp, it's either an OD disease or an injury. You've heard that we have 339 cases on our books right now open where we are accepting this, paying benefits, paying medicals. Those include 911 operators. And the reason presumptions are given when we don't want to burden the claimant with evidentiary proof. A firefighter who has lung cancer has to show, was it 20 years of fighting fires or was it 20 years of smoking cigarettes? We don't have him or her prove that case. The employer has to disprove it because that's a difficult evidentiary position. You've heard some of the testimony today. That's not a difficult evidentiary position. In fact, no one who's testified in ECM or here has actually lost their case based on that testimony. I'd lastly just quickly say I appreciate the concern for the narrowness of this presumption. Those of you who have been doing presumptions for the last 10, 15 years knows that there's no such thing as a narrow presumption. We're now up to about 14 cancers, heart disease, lung disease for a vast number of employees. These proliferate and become very costly. Thank you, Madam Chair.
Okay.
Good afternoon, Madam Chair and members of the committee. Kevin Canale here on behalf of the Maryland Association of Counties, respectfully in opposition to Senate Bill 374. You know, it's tough because I've been a part of this commission for 4 years. I think I've supported every bill. Mako has supported every bill that's come forward. And as Senator Kagan alluded to, we worked hard to get to a place where we could find a middle ground on this one, but we just couldn't get there. And I think a lot of what you've heard from Carmine is what we would say as well. You know, this is tough, and unfortunately, like Carmine said, they're situated, the specialists are situated with every other first responder out there. And while this is a narrowly crafted presumption just for 911 specialists, it's pretty obvious that any other first responder would expect to get the same presumption here. It just is what it is. So you understand from a county perspective when we have Chesapeake telling our counties that this is unreasonable and that, you know, their insurance rates would skyrocket. Counties just don't have the resources to absorb those costs. So again, while we very much appreciate the testimony and I understand it, I've been a part of this commission for 4 years, this is just somewhere we couldn't find a middle ground on, and so for that reason we'd ask for an unfavorable report.
Senator Feldman has a question.
Well, just Kevin, just on that point though, if what Carmine says is true is all these cases are being paid out, and so how would that have any impact on what you just said? Like that doesn't kind of make a lot of intuitive sense to me.
So I don't know if Carmine, if you're referring just to the 911 specialist or if you're referring to everyone generally.
Well, I mean, this bill's about specifically
Sure.
the 911 folks, so if they're winning their cases anyway, why would that have an impact on fiscal to the counties at all, since they're already winning the case?
Because I think, Senator Feldman, once you have a presumption, and Maryland and Arizona have the strictest workers' comp presumption in the land. The other 48 states have a more moderate presumption. These cases become somewhat irrebuttable. So the concern is that once there's a presumption, it's next to impossible to defeat it, even with evidence. So, for example, in a lung cancer case, a smoker with a family history is going to win 99.9 times out of 10 because of the nature of our presumption. So what we're saying is with the presumption, the cost then will skyrocket because there will be more and more claims that will be very difficult to disprove.
With this particular presumption, however, you're not dealing with cancer or heart disease. Basically, you're dealing with something that's more psychological or brain responses to what the person is going through, aren't you?
Yeah, and I think that's one of the reasons that we would oppose is what you heard, if someone files a claim and lists some of those concerns, with post-traumatic stress, there's a trauma. Either that trauma is work-related and you win, or that trauma is work-related and you lose. So these are terrible stories, I deplete, but in terms of evidence, those, as they testify at ECM, they've never lost based on those stories because it's clearly work-related. What we're concerned about is we want to see that event, and then we'll proceed from there. So you're right that we're talking about different conditions, but these conditions are easier for the injured worker to prove was work-related than, say, the cancer, the heart disease, or the prostate cancer, those other presumptions.
You do lose some, however, don't you?
The presumptions? I've won 2 presumptions in 28 years. It's not the best record. So it's very difficult to win a presumption case, very difficult.
Okay. All right, who's going next?
Thank you, Madam Chair, Mr. Vice Chair. My name is Ashley Smith. I'm speaking on behalf of the Maryland Defense Council in opposition, and we would request an unfavorable report. I'm actually glad for the questions that just came up because that touches exactly on what I was going to point out. This bill, as drafted, is grossly overbroad, and it's problematic as it was written. First of all, there is no causation requirement within this bill. If you develop PTSD as the result of childhood physical and sexual abuse, military service, the death of a loved one, all of those things would be compensable if you are a 911 operator under the law. There is no requirement in this bill that your trauma be in any way work-related. All that is required is a diagnosis of PTSD. That means the state, municipalities, local governments will be picking up the bill for all therapy and out-of-work time for their employees for trauma that is completely unrelated to the workplace. I would also emphasize that this bill does not contain any time limit or length of service requirement, which is included in many of the firefighter presumption bills. Under this bill, as written, an individual could work as a 911 operator for 3 months, develop PTSD 20 years later, and that would be presumed related to their employment as a 911 operator, and the employer would be obligated to pay all benefits related to that. I would also emphasize that in this particular case, what we heard from earlier testimony was that the purpose of the presumption is to take away the necessity of a hearing. And Mr. Pavela pointed out that a hearing still happens on almost all presumption cases, including hypertension and heart disease. And I would respectfully submit to Your Honor that a presumption will not eliminate the necessity for a hearing. Hearings will still take place. The only way for a 911 specialist to receive the mental health treatment that they want and need without the requirement of a hearing would be to go through their own personal health insurance. And for those reasons, we would request an unfavorable report. Thank you, Madam Chair.
Okay. Did we hear yet from Michael Daly?
No,
Okay.
Madam Chair.
Okay.
Thank you. Madam Chair, Mr. Vice Chair, members of the committee, Michael Daly from the Maryland Defense Council. On behalf of the MDC, we're asking for an unfavorable report. I adopt the testimony of my colleagues. I'd also like to point out one other thing that seemed pretty apparent to me from those that were testifying, very compelling testimony in favor of this bill. It seems to me it's an access to mental health care that's the problem. This bill does not solve that. This is the same as any other workers' compensation bill, whether it be a presumption or otherwise. If someone claims they developed an occupational disease or they were injured on the job due to a work accident, then they have the ability to file a claim form, still required under this. They must then prove that they have the condition that they claim is work-related. They then, by choice and by law, as this committee knows, they have the right to choose their health care provider. The employer and insurer do not have a pool of mental health care providers, physical therapists, orthopedic surgeons, whatever the specialty may be, to say, here you go, injured worker, we're going to open the doors for you to go find them. This bill doesn't do any of the things that I think the people that are asking that it be passed do. What this bill does, however, is I think unintentionally create problems that my colleagues have just pointed out. There's a system that already does exactly what these folks want it to do. They can file a claim, they can come in, and they can get the help that they need, proving their case. However, to make it an irrebuttable presumption, as Mr. D'Alessandro pointed out, does not solve the problem. And for those reasons, and again, as the same as my colleagues have already presented, we'd ask for an unfavorable report. Thank you for your consideration.
Thank you. And let's see, we had one more witness listed. Is Julie Murray here? Yes, okay. I'm up to testify now.
Thank you. Thank you, Madam Chair and Mr. Vice Chair. Julie Murray. I am also appearing on behalf of the Maryland Defense Council today. I would like to adopt the arguments of my colleagues, which I think were very well made, and just expand briefly on where Mr. Daly ended, which I think is an important point to note. The testimony here today was certainly, from my standpoint sitting there, very compelling. And it does show that 911 specialists need mental health service. However, the testimony that was given does not show that the placing a presumption for a compensable occupational disease in the Workers' Compensation Act will do anything to alleviate that issue. It does not increase the access to people to have mental health services. It does not change how they can get them, when they can get them. It does not impact their ability to seek counseling, which was a lot of what you heard here today. If there is a problem among 911 specialists in not having the appropriate access to health care, that is an issue that should be dealt with outside of the workers' compensation realm. It's not an issue that's fixed by this bill. All this bill does is create a presumption for a PTSD as either PTSD, which is already compensable either as an accidental injury or as an occupational disease under the two cases that Mr. D'Alessandro cited. And in light of that, we do ask for an unfavorable report on Senate Bill 374. Thank you.
Okay. Thank you very much. And that ends the testimony on this bill. Thank you. We're going next to Senator Jackson, Senate Bill 10, Workers' Comp, COVID-19 Occupational Disease Presumption. Senator Jackson here? Yes, okay. And let me call up your people. We've got Lance Kilpatrick favorable with an amendment. We've got some others that I assume are favorable without. So let's call up Robert Phillips, Matt Palvola, and James Lanier. Okay. As soon as somebody's done, the other person can come up and take the seat. Okay, Senator, you have the time you need to lay out your case, and then your witnesses will have 2 minutes each.
Yes, ma'am. Thank you, Madam Chair, Mr. Vice Chair, members of the Finance Committee. For the record, Senator Michael Jackson representing District 27 on behalf of Senate Bill 10. Senate Bill 10 is a very straightforward bill that simply creates occupational disease presumption. Having sat through the last two testimonies, I'm not sure I can say simple anymore. Right? Related to COVID-19 for first responders, public safety employees, and healthcare workers. In the public safety realm, those eligible to receive the presumption would be firefighters, emergency medical technicians, law enforcement officers, correctional officers, members of the National Guard, State Marshal's Office. In the healthcare sphere, those eligible would include the individuals employed in healthcare, home care, and long-term care settings, whose duties include direct patient care or other work in areas where patients diagnosed with COVID are treated. The legislation would apply retroactively and be interpreted to affect worker compensation claims filed on or after March 1st, 2020, and would sunset on July 31st, 2023. As you all know, workers' compensation occupational disease presumptions are put in place because the risk associated with certain occupations can often lead to the development of healthcare conditions. These presumptions are an important safeguard for those who work in certain fields because of the unusual hazards encountered by their employment. These presumptions streamline the workers' compensation claim process and require no additional evidence from the claimant as long as an individual's condition arose in the course of the duties they were involved in during their employment. Currently, such presumptions are in place in a few other cases. Presumptions exist for fire and EMS personnel relating to heart disease, lung disease, leukemia, and multiple types of cancers, for heart disease and deputy sheriff's police officers and certain correctional officers, and for Lyme disease for natural resources and park police officers. And if I might, Madam Chair, I'd like to just mention that as a member of the Fraternal Order of Police, during the 90s, I had the opportunity to walk the halls and work on the 2 pieces of legislation which brought about the heart disease for deputy sheriff's police officers, correctional officers, as well as Lyme disease. So we're very familiar with the challenges, but it is a work that's necessary as we move forward to make sure we take care of our employees. As you all know, as you all probably know, my professional background leads me to a keen interest in these sorts of issues. First responders, public safety, and health professionals face unique challenges in the work that they do, and those challenges have truly been magnified by COVID-19. These are the folks, as you all know, who, despite the realm of the unknown that we have lived through, and we're not finished yet because some of us are still donning our mask and we're still in an uncertain realm, got up and went to work every day. Not knowing exactly what we were dealing with, not knowing what they were going to bring home to their families, and not knowing if the PPEs were going to hold up. Allowing this presumption will be a valuable solace for these public servants who sacrifice so much for the benefit of their communities. I'm hopeful that the committee can move this legislation forward. And with that, Madam Chair and committee members, I move for a favorable report of this bill, and I'll stand for questions.
Okay.
Thank you.
All right. I don't see any lights on, so we'll go to your witnesses. Okay. Is Lance Kilpatrick at the table now? I'm going to ask you to wait for a minute. Let's hear the other 3, and then we'll hear yours since you have an amendment. Okay, so if you'll state your name and go ahead.
Thank you, Madam Chair. My name is Robert Phillips. I am the chairman of the Maryland State Firefighters Association Legislative Committee. Just as a point, I do represent 34,000 volunteer first responders, and I write this for them. I supplied written testimony for this bill, but I'd like to add to that. The MSFA fully supports this bill. The first responders listed in this bill are on the front lines each and every day and come in contact with the public like no other profession. They could be called out to assist an ambulance crew with a sick person or be sent to the scene of a motor vehicle collision. They might be dispatched to help a person who has fallen down or, yes, stuck in a tub. They call us to help them, to rescue them. It's the public. They call 911, we respond. The public they serve, our first responders, relies on them to respond anytime, anywhere, in all circumstances to provide relief to the emergency at hand. Today, fully 1/3 or more of our calls are medical in nature. This is in addition to about 25% of our calls being motor vehicle collisions and associated rescues. This puts the first responder in a constant environment that exposes them to a greater degree of risk when it comes to this highly contagious virus. Based on the working conditions which they face every day, we feel that this bill should be passed to take care of our first responders. I thank the committee for their time on this important issue and ask that you favorably support Senate Bill 10. Thank you.
Thank you. All right.
Here we go. Good afternoon, Chairwoman Kelly again, and members of the Senate Finance Committee. Again, my name is James Lanier on behalf of the Maryland Association for Justice. We are again
Pull your
here.
mic a little closer to you.
Yes, ma'am. We are here to ask for favorable support in Senate Bill 10. So with regard to the first responder aspect of it, that testimony was much better than mine ever would be. But what I wanted to focus on was the fact that a year later, obviously we were all here on the very similar bills last year, but now that this has become more of a disease of life, and we all have to deal with it forever. This is why the presumption actually becomes a little more important now, because just like we all have to deal with COVID, we all have to deal with concerns of cancer. with heart disease, with stress, with hypertension. And again, this is why we want to favor first responders and note that they have a special duty, they have a special job, as the senator has indicated just a minute ago. So the fact that it is more of a disease of life means that we have to have the presumption more so to highlight the fact that we need to make it easier for these people who have to go and involve themselves with the general public that they have no history with, and then they develop the disease within the 14 days of which they were working. Then that makes it that much easier, not to be perfect, but it makes it easier for them to help prove their claim if they can otherwise meet the prima facie elements of the claim in the first place. You have to have medical proof. You have to be able to show that you were exposed on the job. In addition, hopefully, the fact that there is a sunset provision is also helpful, because then hopefully in 18 months, we won't need this presumption anymore, and then it'll go away, and it'll be sunsetted out. So there's also a safeguard for the employers, the insurers, the self-insureds, and, well, I guess the UEF really wasn't being involved, but, if it turns out that we don't ultimately need this for any longer period of time, the senator was very wise at putting in a sunset provision. Thank you very much.
Okay, let me just ask you a question.
Yes, ma'am.
Although these people were in jobs where obviously there were great probabilities of exposure during the time when the disease was most prevalent, they also took modes of transportation, as did all of the general public, where maybe they got it on the bus or the subway. We went into stores where some people refused to be masked while we were buying something for our personal consumption, and we were around people who might not have done what they should. So the sources of the problem are so diffuse, I guess I would say, during the 2 or 3 years when this pandemic was most rampant, that wouldn't that give you a harder time trying to prove what the source was likely to have been?
Well, that is exactly why the presumption is necessary. So I'll give you an example. One of the COVID cases that I took, I will admit that it was accepted, but one of the individuals I represented was a correctional officer who worked in the infirmary. He developed COVID. Why? Because all he was around was COVID. But that claim was filed and was originally challenged. It was only a couple of days before the hearing that it was eventually accepted. But that would be a perfect example. If the employer can show that the person was not exposed during the time period that the senator put in the bill, or there were other exposures. You went on a vacation, you went to Ocean City, you did something else in which we can pinpoint that exposure to, then it would not be work-related, and that's part of the rebuttable nature of it. Also, by the fact that we limit it to the first responders, says that we're not just putting it out there for every source of employment. Like you said, we could all go to the gas station and be exposed to somebody when we're paying for our gas. But we have to look at the work history of the individual as well, that they had a known exposure. Like, for example, with a health care worker, the Department of Health has those statistics. So in another case I handled, we went to the Department of Health to show that that facility had multiple, both staff and patient exposures positive, and that's one of the ways we were able to show that that person's claim was related to their work. But this becomes that much easier with the presumption. We don't necessarily have to rely on statistics from the state to show that, to help prove our case. It just makes it that much easier to help the injured worker get the medical care and benefits they deserve.
Ordinarily, if the person was exposed when we weren't in a pandemic situation, it seems maybe your argument would be stronger in terms of the value. When it was all around us, so that everybody needed to be masked and everybody needed to stay away from normal activities that they regularly would have otherwise have engaged in, it means that it could have been possible from almost anywhere at any time. I mean, when it was really at its worst, it was as if we were all encapsulated in the pandemic.
Right, but that's what we see now with just general communicable diseases. For example, if someone calls me and says, oh, I've developed hepatitis, or I have SARS, or not SARS, MRSA, excuse me. or I've got tuberculosis. Those are extremely hard to trace, and ultimately, those are not compensable claims because they don't have the presumption, and I can't necessarily show, well, you know, did you get that MRSA because you slipped and fell and opened your knee, or because you're in the hospital, or because you were exposed to another patient who had MRSA? So those claims are extremely difficult and usually are not compensable for the same reason, Madam Senator, you've
I
mentioned.
guess I was just thinking if the person in their off-duty time was violating, and maybe they weren't paying attention, all of the medical advice as to what you should do and not do, you still could have come up with it, you know, and nobody could tell.
And that's why it's rebuttable. Because if that's the evidence that we have, if the evidence the employer insurer can show is exactly what Your Honor, excuse me, Madam Senator has indicated, then the claim would ultimately be found to be not compensable because it would not be linked to the occupational source.
Okay. All right, let's move on.
Thank you. Matt Pavola, also with the Maryland Association of Justice, asking for the favorable rendering of Bill number 10. I want to thank the Senator for his service and for introducing this bill. To your point, Madam Chairperson, I appreciate those questions that you just generated there, and I just want to point out that what makes this this is so tightly tailored just for those persons during the height of this pandemic couldn't walk away. I could walk away, most everyone else, but not these folks, the first responders and the healthcare persons. And they're the only ones that are going to enjoy this presumption. They had to run into the face of danger while the rest of us could avoid it. And that's why it's so appropriate, I think, for this limited category of persons to get it. And contrary to some of that testimony, going back to the courtroom, I've been a litigator now for 40 years. I'm not sure what was being described there, but I've tried presumption cases. You still have to prove the elements of your case. It's a full-fledged trial in every sense of the word, and you do have to have expert testimony. I couldn't come into court with this, to the commission with this, without a physician saying that my client has COVID-19 and presumably caused by their exposure as a first responder, et cetera. So the case, you still have to prove your case entirely. Finally, I just want to say this. The urgency you've described, Madam Chairperson, has died down some because metrics are improving. We're now getting more pushback claimant attorneys than we did early on when everyone was really upset about this. And now employers, insurers, and even to some extent the commission, we're finding it's tougher and tougher now that the urgency is gone. We ask for a favorable vote on this so that these deserving persons can enjoy that presumption. Thanks so much.
Okay. All right, let's see, I think I got all right, now we'll go back to Lance Kilpatrick, who was the favorable with the amendment.
Yes, and if I might, Madam Chair, the NCSL, thanks, gentlemen, has been calculating, keeping information on other state legislatures, and to date, there are 7 state legislative bodies that have enacted like legislation, and there are actually 4 states to date who have instituted executive orders dealing with public safety and healthcare folks.
And this was done through executive orders and not through legislation?
No, ma'am. That's, but most of the agency, most of the legislatures across the state have pending legislation.
I see.
Currently. So.
Thank you.
Thank you.
All right, Mr. Kilpatrick.
Thank you, Madam Chair and members of the Finance Committee. For the record, my name is Lance Kilpatrick. I'm the Legislative and Political Director for AFSCME Council 3, representing approximately 30,000 state and higher education employees across Maryland, including, regarding this bill, correctional officers. And I'm pretty sure I don't have to remind anyone on this committee that correctional officers are often mandated to work 16-hour shifts in an enclosed facility that is a 24/7 facility going forward. And this legislation is retroactive to March 1st of 2020, 2 years ago. 2 years ago, None of my members had what I'm wearing now. None of my members had what I'm wearing now. The idea of having gowns for working in the medical facilities in the correctional areas didn't exist. Didn't exist at all. To this day, even though I look around, most of us are not wearing masks, within the correctional facilities, masking is still required. That's how serious COVID-19 is in that environment going forward. That's why this legislation is so important. The reason I am asking favorable with an amendment, and I really appreciate all the senators' work on this, is because I don't see how we can legitimately have an expiration date on something like this. As my mom used to say, when we make plans of such nature, God tends to laugh at us in response. Right? And I don't want to see that to happen. Madam Chair,
And
you
to
have a
be
question?
really clear, so we all understand, your amendment exactly is what?
Is to do away with the expiration date of the bill.
Okay.
Yes. So I appreciate the time and hearing of this. I wish Senator Klossmeyer's bill was still around from last year because she was spot on in what she was doing, but
Okay.
we'll take this. Thank you so much.
Thank you. All right, now we're going to the unfavorables.
Thank you, Madam Chair, members of the committee.
Got 6 persons that we'll call up: Angelica Bailey, Michael Daly, Carmine D'Alessandro, and Robert Enton. Let's take those 4 first. All right, everybody has 2 minutes each.
Thank you again, Madam Chair, Mr. Vice Chair, members of the committee. Again, for the record, Carmine D'Alessandro, representing Chesapeake Employers Insurance Company and IWIF. I know there's some written testimony on the retroactivity provision, so I'll leave that to the written. And I believe one of my panelists here will be talking about the vaccine impact, so I'll leave that to someone else. I would just like to reiterate, as we discussed last year, the vast majority of these claims have already been accepted. I believe in Chesapeake's IWIF book of business, only 6% have been denied. We're still investigating 12 to 20 more, but in the occupations that you've heard, many of these cases are already accepted, and I believe as of last year, our data tracked the Commission's data, where the vast majority of these cases were accepted without a presumption. I think what's important to note here is every single case has been accepted as an accidental injury. And that's very important because presumptions only attach to occupational diseases. They don't attach to injuries. And the reason is what Chair Kelly I was just talking about. If something becomes a hazard of life, is no longer an occupational hazard, it cannot be an occupational disease. And I'm not sure it was intentional, but you pretty much paraphrased the Supreme Court of the United States just 2 months ago in Biden versus Missouri, where the court found, and one of the reasons they didn't allow OSHA to go as far as they wanted is because, especially with Omicron, COVID was no longer an occupational hazard. It was a hazard of life. You could get it anywhere. And basically, that's the definition of what an occupational disease is not. So we've never been challenged. All these cases have been determined to be accidents. There's not been one legal challenge to those findings, and we would submit that based on that, given that these are not diseases in the workers' compensation law, no presumption could attach. And for the other comments, I'll pass the mic. Thank you.
Okay. All right, Bob.
Thank you, Madam Chairman, members of the committee. Robert Netton on behalf of the American Property Casualty Insurers Association. With all due respect to the sponsor in opposition, I think if you look at the fiscal note on page 4 for the bill, the proof is in the pudding here. For Carmine's company, Chesapeake, which is, a fairly significant insurer, they had 111 claims were accepted by, 152 claims total. 111 were accepted by the Workers' Compensation Commission. 12 were contested and are awaiting judicial review. 12 were withdrawn. 7 are still being investigated. And here's the key, 10 out of 152 were denied. I mean, there's just no need. It's, it's rare. We have if you look at the fiscal note, it outlines the current presumptions that you have. So for the lawyers in the room, and I'm looking around, I think it's Senator Feldman, and he was in the joint committee briefing the other day, as was Senator Klausmeier. The presumption changes the burden of proof in a case. That's what it does. So typically a plaintiff or a claimant, they've got the burden of proof. This shifts that and puts the burden of proof onto the employer. We almost never, ever, ever do that. But regardless, I really believe that this is a solution in search of a problem. The commission is doing its job. The lawyers for the claimants are doing their job. And once again, you have a total of 10 out of 152 that after the commission heard the full story that were denied. The rest of them are either pending or have been approved. So for those reasons, we think it sets a dangerous precedent to do this. We don't think it's necessary, and we'd urge the committee to give the bill an unfavorable report. Thank you.
Okay.
Good afternoon, Madam Chair, committee members. I'm Angelica Bailey. I'm the Director of Government Relations for the Maryland Municipal League. I know it's been a long afternoon and it's getting longer, so I will try to be brief, but this is a rather complex area of law. As others have said, this is redundant, bordering on unnecessary, and that presumption is especially problematic. When we say that an employee doesn't have to provide any additional evidence and the burden is shifted to the employer, Madam Chair, as you alluded to earlier, COVID is distinct. It's incredibly contagious. It could have been anywhere. How can we, as an employer, prove that an employee didn't go out to dinner or didn't host their family for Thanksgiving or didn't forget to bring their mask into a grocery store? It's almost ubiquitous. And with how easily spread COVID can be, evidence should actually be necessary to show that it was contracted in the workplace. So this new presumption impedes that and will be nearly impossible to rebut. And then there's also the matter of the retroactivity aspect of this. There have been hundreds and thousands of COVID infections in the last 2 years. This bill could result in a floodgate of claims, some which could be meritorious, many will not be, and that's going to be difficult for local governments to absorb. It's already hard to rebut that presumption, but time has a way of erasing helpful details too, right? It's going to be even harder to rebut when time has passed and people no longer remember the dates and circumstances under which they may have been exposed, whether they went out to eat at a certain restaurant on a certain day or when their symptoms may or may not have started. This is just too broad and burdensome. So with respect, we do request an unfavorable report. Thank you.
Okay, all right.
Madam Chair, Mr. Vice Chair, members of the committee, Michael Daly from the Maryland Defense Council. Very briefly, one of the things to pick up on what Mr. D'Alessandro was talking about in terms of the statute procedurally being defective in that it's in an occupational disease state when in fact the commission has across the board, the few times this has been litigated, has found COVID-19 exposure to be an accidental injury. And that's consistent with what the law is. It's consistent with what this committee and the legislature has historically done so well, is create an interweaving of statutory workings that works so well and smoothly, in contrast to many other states, quite honestly. Our state is great with that. It works really well. But when you start introducing bills that confuse what really should be one category into another, it creates unintended problems. In addition to that, unlike other jurisdictions at what we call pre-hearing discovery, to go along the lines of whether or not it's actually rebuttable, Maryland does not have that, and for good reasons. We want quick hearings for the injured workers to be able to get into hearings and get their cases heard quickly, and that's a good thing. However, there is no procedure in place to find out what the other things that the person may have been exposed to, as some of the other speakers have said. There's just simply no way to do it within our system. So to introduce this bill and say that this somehow corrects a problem that's out there is inconsistent with what the facts show. Those other reasons that I just said, too, create other unnecessary difficulties, which, again, I'm hoping would lead to the finding that this should get an unfavorable report. Thank you for your consideration.
Thank you to this panel. Okay, we're going next to Kevin Kennelly and to Julie Murray.
Good afternoon, Madam Chairman, members of the committee. Kevin Canale here on behalf of the Maryland Association of Counties in opposition to this bill. I won't repeat everything you've just heard. I will add that the bill does not include an exclusion for someone who isn't vaccinated. And going back, the retroactivity of this bill would make it extremely difficult to remember exactly where you were when you may have had symptoms or not had symptoms. So we think it's too expansive, and for those reasons and what you heard before, we'd ask for an unfavorable report.
Thank you. Good afternoon again, Julie Murray on behalf of the Maryland Defense Council. Picking up with one of the first things that was mentioned by my co-panelist, the vaccine issue is a large problem with the bill. There is nothing in here that addresses a person who has chosen not to get the vaccine. At the point when a person does not get the COVID vaccine, you have an issue as to whether or not their contraction of COVID actually arose out of the course of their employment or whether it arose out of their personal choice not to get the vaccine. Because that's not addressed, that's obviously a huge stumbling block that we see with this bill. Another important thing to note that Mr. Pavel, I think, represented to the committee that it's become tougher to win cases before the commission. And that is not a reason why we should have a presumption for this disease. As we saw from last session to this session, what we've known about COVID has evolved dramatically. We have seen that each case is very fact-specific, depends in large part not only on what a person does at their job, but what their home life is like, who they live with, who they interact with, who they see. We've seen the research evolve. Studies from Brown, Harvard, University of Chicago, to name a few, have noted that the correlation for community spread is far more significant than any correlation between occupational spread. So what we've seen at the commission is not necessarily that we need a presumption because cases are harder to win, but that the cases are being handled on a fact-by-fact, case-by-case basis with what we know about the disease, what we know about that person's particular interactions, and what we know about the science at that point in time. I would defer to our written testimony on the retroactivity because I think that's a very important aspect to look at. And for all of those reasons, I would just ask you to issue an unfavorable report on Senate Bill 10. Thank you.
Thank you very much. All right, that ends the testimony on that bill. We're going next to Senate Bill 433. Senator Klossmeyer, Labor and Employment, Workers' Comp Claims, Fees for Legal Services. And let me call up your two panelists, James Lanier and Matt Palvola. All right, now, Senator, you take the time you need to lay out the parameters of your bill, and the witnesses have 2 minutes each.
Okay, thank you very much, Madam Chair. Good afternoon. Wake up, everybody here in your committee. You want to stand up and stretch a little bit, whatever. Maryland Workers' Compensation, Labor and Unemployment Workers' Compensation Claims, Fees for Legal Services. Maryland Workers' Compensation Law promises injured workers or those who with occupational diseases that their medical bills would be covered. Unlike with health insurance, claimants generally must ask permission prior to getting medical care. If the workers' compensation insurance company denies that request, the only way the claimant can get medical care approved is by going to a hearing and convincing a commissioner of the merits of their case. Claimants can hire a lawyer to represent them at their hearing, but a lawyer can only be paid if the claimant is awarded monetary compensation. If the claimant is only given approval for medical care, the lawyer handling the case may not be able to be paid or have expenses reimbursed. As a result, a claimant may not be able to hire a lawyer and will either be left without representation or give up their case altogether. Senate Bill 433 would try to address this issue by authorizing the Workers' Compensation Commission to order a fee of up to $2,000 to be paid for legal services in cases where no compensation other than medical benefits is provided. Under the bill, the Commission may require that the insurance company who denied the medical care pay for the legal services that the claimant needed to get the care approved. The goal of this legislation is to ensure that those whose workers' compensation claims have been wrongly denied can get legal counsel, and the legal counsel is able to be paid for for their services. And I would just like to say, we have brought this up to the Workers' Comp Oversight Committee and had a very, very lengthy discussion about this whole issue. And you will hear the testimony on both sides of this issue. But right now, I am joined today by the members of the Maryland Association for Justice who can explain from their perspective why this reform is needed. I want to thank the committee for their consideration of Senate Bill 433, and I'm requesting a favorable report.
Thank you. All right.
Good afternoon, Chairwoman Kelly. Once again, James Lanier on behalf. Oh, I'm sorry. No, you're fine. James Lanier on behalf of the Maryland Association for Justice. We're asking for a favorable support of the Senate bill. So the focus of this bill is on the unrepresented claimants who have medical-only claims. That's the problem that we're attempting to solve. Those who have, there's two piles of money. There's indemnity money that goes directly to the claimant, and that's where the pile of money that goes to pay the claimant's attorney comes from. But when that money doesn't exist anymore, either because they settled that portion of their claim or there's limitations because there's a 5-year limitations on coming back for additional benefits, then they're medical-only claims. Because medical benefits to the injured worker are for life, for anything that they can show is necessary, reasonable, and related. So on those circumstances, those individuals have a harder time finding a lawyer if their prior lawyer, for whatever reason, is no longer representing them because they retired, they've passed away, or they had a difference of opinion, or for whatever reason they're unrepresented. That now medical-only claimant cannot hire anyone else because from a business standpoint, we can't get paid and we actually go into debt because we have to pay for their medical records and we even can't get reimbursed on that. So the purpose of this bill is to allow the commission to have the discretion to award us a fee that can be paid directly by the claimant, not that dissimilar to what we do in other types of personal injury cases where we can have a legal services agreement with our client directly, but in workers' comp we're not permitted to do that for fees specifically because all fees are done through the Workers' Comp Commission. So the commission has the discretion to award either $0 or up to $2,000 that can be payable by the claimant, or if that claimant is destitute, by the employer insurer when we win. Because they can, or obviously we can look, we've talked about an amendment that would make it clarify it. It's not just because we have a hearing, but we're able to get a benefit for the injured worker. I see my time is up, but we're asking for a favorable response to the bill. Thank you very much.
Thank you. All right.
Thank you. Matt Pavola again with the Maryland Association of Justice. I want to thank Senator Klausmeier, my senator, for offering up this bill and urging its favorable reception. This is a very big problem. This is a very big problem, this situation of unrepresented injured workers, and it really does need a remedy because there are many situations where they do not have an attorney. When the life of, just as Mr. Lanier explained, the life of the case goes on because medicals are for life, but the compensation has all dried up. What results now is you see injured workers coming into court very frequently without a lawyer, and it's a David and Goliath situation. They are overwhelmed. They can't possibly meet, an unrepresented claimant, meet the burden of proof up against a defense attorney hired by an insurance company to oppose that medical treatment plan. Among other things, they have to get a report. They don't even know that. They need a report from a physician saying they need that medical treatment. And it is a very big problem. So what's happening as a practical matter is these commissioners, they sympathize with David, and they bend over backwards to try to help out the little guy, the little person in this unfair situation. And as a result, they come out of the role that they want to play. They want to be neutral and detached arbiters. They want to be a judge that oversees the adversarial process and not advocating, and they're dragged into an advocacy role to some degree, and that will stop if there's a lawyer there. And I dare say they would all rather have a claimant represented by a lawyer than not represented. Finally, you're going to hear some testimony from Chesapeake offered on the House side, that they said they had like 5 of these cases or something like that. That's because they don't, my office, Mr. Lanier's office, we get repeated calls of such individuals who no longer have an attorney. Chesapeake wouldn't get those calls. We get them all the time. Similarly, when I'm at hearings, I see unrepresented persons all the time coming in. Sometimes I'm able to even help them out in the hallway. Sometimes help them pro bono. Sometimes it ends up, I can help out, and it ends up in an agreement of final compromise and settlement. But many times I see unrepresented persons. This is a big problem, and we urge, please, a favorable vote.
Vice Chair Feldman has a question.
Yeah, I mean, this could be to folks from the Maryland Association of Justice, but so it looks like from our fiscal note I'm reading, there's a reference to some recent changes in the regulations dealing in this space, and I'm looking at just plain language of the, it says the bill generally codifies a practice authorized by these new regs. So I'm a little bit, I mean, I understand the problem, but then this statement, I guess the question on the table is, what's different in the bill language than the practice that's been now authorized for the Workers' Comp Commission under these new regs? It seems like there's not a lot of space here, and so maybe you could clarify.
Thank you for that question, Senator Feldman. Under current practice, we can only proceed to receive a payment if we can show it's a frivolous proceeding. That's the current practice. I've never won a frivolous proceeding in my 40 years as a practitioner. That's how rare those are. Well, maybe one, but it wasn't in this situation. They're very, very rare animals, and this bill now brings it up in front that the attorney, if the attorney prevails at the hearing, can get a fee, and even that's discretionary. The commissioner could say no, or could just award $200 or whatever. But at least there is a bite to the possibility that the unrepresented injured worker who needs medical treatment has a fair chance. Did I answer your question?
Yeah, I mean, I'll let the other side, I mean, I'm looking at these new regs, and it doesn't seem to sort of square entirely with that you have to prove what you just said, so I'll let the other side. I'm just, again, looking directly from the fiscal note about the recent regs in terms of what it authorizes, and it doesn't exactly say this, but okay.
I just want to
Sure.
reiterate that we had a very, very lively and
Sure.
long discussion yesterday morning about this, and I think maybe we'll have to have the two sides come together and try to work some things out.
I was on that call. No, it's,
but
okay, thank you.
Okay.
That's good.
Okay,
Thank you.
all right.
Thank you.
Thank you. Okay, we're going now to the unfavorables. Michael Daly, Carmine D'Alessandro, Ashley Smith, and Julie Murray. You have 2 minutes each.
Good afternoon yet again, Madam Chair, Mr. Vice Chair. Carmine D'Alessandro here for Chesapeake Employers Insurance Company and the Injured Workers Insurance Fund, respectfully opposing Senate Bill 433. I'd first like to state, as I stated in Oversight and in the conversations during the interim, Chesapeake does not oppose an increase in the statutory cap that's in COMAR for claimants to receive a higher fee. We obviously would like that in COMAR, where the rest of this structure is, and we indicated that we would work with the claimants bar on the commission's timetable to see if we could increase that fee. So we're not opposed to increasing the fee as long as it stays in COMAR. To Senator Feldman's point, there have been 3 changes that benefit the claimants bar since we last talked about this last year. One, the commission increased the fee by 5% in cases that are settled. So there is an opportunity for claimants' attorneys to get more money as a fee in cases that were settled since the last time we were here last year. As Senator Feldman pointed out, it's not frivolous issues. It's in special circumstances the commission can award a fee if they feel that there are special circumstances that, and they can actually go over $2,000. And yes, it's discretionary, but so is the bill. So what Senator Feldman was alluding to, the bill's sort of already encapsulated in the COMAR changes that have occurred since we last met. And lastly, as we talked about oversight, which is very important, in the last year, the state's average weekly wage has increased by 30%. And that's important because all workers' compensation benefits stem from that wage. So as that wage goes up, benefits go up. And as benefits go up, the opportunity for additional fees goes up. So there have actually been 3 things that have happened since last year that have aided the trial bar on this issue. And as for the last, raising the cap, we would work with them and the commission, but we want this contained in COMAR. The commission has always been the jurisdiction for the fee guide, for the attorney fees and COMAR, and we would not want one little piece of that structure codified while the rest of it remains in COMAR. Thank you.
Thank you. All right.
Thank you. Good afternoon again. Julie Murray on behalf of Maryland Defense Counsel. In addition to what Mr. D'Alessandro just indicated, the other problem that we have with Senate Bill 433 is that what you heard testimony on here today is not exactly what this bill is drafted to remedy. The bill does not just address a situation where it's an unrepresented claimant who has no more indemnity left on the case, and the claimant's attorney wants the claimant to pay a fee of up to $2,000. The bill is overly broad. It encompasses situations where there is still compensation due. It encompasses situations where the employers and carriers would pay a fee, and it encompasses situations where the uninsured employers fund potentially would pay a fee. And all of those go outside the bounds of what they are indicating the true problem is that exists. We do think that if there is that problem that needs to be addressed, that we would be willing to work with the trial bar as indicated within the bounds of COMAR to try and come up with a solution that helps alleviate the concerns that they have about unrepresented individuals who have cases that are closed on indemnity and can now not seek representation on medical issues moving forward. I would defer to the written testimony as well as adopt the other arguments and just ask for an unfavorable report on Senate Bill 433. Thank you.
Okay, thank you. All right, do we want to go to Ashley or to Michael? Who wants to be next? Okay.
Thank you, Madam Chair. My name is Ashley Smith, and I'm speaking on behalf of the Maryland Defense Counsel. I would reiterate Ms. Murray's points that this is a grossly overbroad bill, and I would emphasize Senator Feldman's point that the COMAR regulations actually have already addressed this issue. Injured workers' attorneys are entitled to recover fees in the event of extraordinary circumstances, so long as they submit an itemized bill in support of that request. I would add and I would emphasize that the reason that the commission so closely regulates attorneys' fees is to protect injured workers from excessive fees and to make sure that the compensation that goes into their pockets is not being taken up too much by the fees of injured workers' attorneys. This requirement for extraordinary circumstances and an itemized bill is what is necessary to protect injured workers, and I believe the commission, in doing so, is looking out for both their best interests and the interests of claimants' attorneys who are looking to recover in these so-called special circumstances that they claim the bill addresses. And for that reason, we would request an unfavorable report. Thank you.
Thank you. All right, and finally, Mr. Daly.
Thank you, Madam Chair. Mr. Vice Chair, member of the committees, Michael Daly on behalf of the Maryland Defense Counsel. Me too, emphasizing, as Mr. D'Alessandro said, the Maryland Defense Counsel does not oppose and in fact supports any efforts by the Maryland Association of Justice to work in adjusting whatever increase they believe is fair and reasonable under the COMAR provisions, because the commission historically, that's how they've dealt with attorney fees for the claimants' attorneys. They've done a great job with it. They've just amended it recently, as Mr. Vice Chair Feldman said, and I think that that really emphasizes exactly what's being done to address these problems, and I think it can be addressed as well by the commission if there are additional changes to COBAR needed. Thank you, and we're asking for an unfavorable report.
So COMAR can do it, and we don't need to go to the, okay. All right. Thank you very much. Okay, we're going next to Senator Lamb. All right, he's on his way. Let's get his panel up. Dr. Michelle LaRue, Dr. Monica Guerrero Vasquez, and Brian Sims. Okay. We understand that Senator Lamb is on his way, but if we can get the panel up, that will be helpful. I'll see, at least you guys are in place. We'll give the sponsor a minute or two more to get here. All right, here he is. Okay, this is your panel, Senator. If you want to maybe stand at the podium, okay. All right, and Senator, you'll have the time you need to lay out the parameters for your bill, and panelists will have 2 minutes each.
Okay, great. Well, thank you, Madam Chair, members of the committee. For the record, Clarence Lamb, Senator in District 12. Pleased to be here to be able to present Senate Bill 778. This bill will require the Maryland Medical Assistance Program, also known as Medicaid, to provide medical care to undocumented pregnant women in the state. Currently, the state requires Medicaid coverage for eligible pregnant women with family incomes up to $250,000 of the federal poverty level for 1 year immediately following delivery. Senate Bill 778 would provide the same services to undocumented mothers who would otherwise be pregnancy eligible for Medicaid had it not been for their immigration status, and to their children up to age 1 year old. Today, undocumented mothers in Maryland are not receiving the necessary prenatal and postnatal care they need. There are approximately 275,000 undocumented residents in the state, and currently most of the undocumented women are only eligible for emergency services. That means that for many mothers-to-be, the first time they're seeing a doctor is on the day that they give birth. This contributes to a higher risk pregnancy. It also puts both the mother and the child at risk for serious health complications. The lack of access to prenatal care increases the risk of premature birth, low birth weight, and contributes to other pregnancy-related issues, including precipitous labor, breech presentation, where the baby's upside down, cord prolapse, where the cord can get caught, fetal distress, or excessive bleeding. And as a doctor, I want to tell you that it's no worse of a feeling than to see a young mother who's there delivering, and on the day of delivery, realizing that they had not had any prenatal care beforehand. It's really tragic in this day and age to experience mothers in those situations. While the state of Maryland leads on many healthcare issues, 17 other jurisdictions, including our neighbors in Virginia and the District of Columbia, provide coverage to pregnant individuals regardless of their immigration status, either through Medicaid or other established state-sponsored programs. And I believe that it is time for our state to also step up to help guarantee prenatal and postpartum care to income-eligible undocumented pregnant women. Through the bill, the state would be able to maximize the amount of federal funding that's available, and there's strong precedent for this in other states as well who have established similar programs. The Department of Health already covers labor and delivery costs for pregnant undocumented mothers, but this is coming at a higher cost to the state as it is through emergency Medicaid. Expenditures on prenatal and postpartum care can be offset by a reduction in current Medicaid expenditures for emergency medical services due to the higher federal match for the CHIP program. To the extent that prenatal care reduces pregnancy complications, preterm labor, low birth weight babies, and neonatal care unit stays, Medicaid expenditures would be further offset and reduced. This bill provides critical and life-saving care to pregnant mothers and their newborns at an extremely vulnerable point in their lives. Maternal mortality rates are 5 times higher amongst women without access to prenatal care as compared to those mothers fortunate enough to seek out and obtain routine health care throughout their pregnancies and in the postpartum period. The postpartum period in particular is a precarious time for mothers because, in fact, 52% of all maternal deaths in the United States occur during that postpartum period. There is, however, reason to be optimistic, as the CDC has identified that 60% of these cases are preventable with routine postpartum care for the mother. This bill, SB 778, offers postpartum care to undocumented pregnant women in our state, seeks to raise and by doing so seeks to raise the occasion to mitigate undue maternal mortality. The bill also mirrors recently passed Maryland Medicaid expansion legislation by automatically enrolling the newborn children of these pregnant women into the state's Medicaid program for their first year of life. Many of the supporters of this bill feel that it's inhumane to deny mothers and their children potentially life-saving coverage, regardless of what their status is currently. However, there is also strong financial incentive for this as well, and overall, the fiscal note is generally favorable. While the initial summary states that Medicaid costs would increase by an indeterminate amount, albeit significant, on the first page of that fiscal note, the note correctly points out that the majority of the expense will be covered by federal dollars. Based on a report by the Maryland Health Benefit Exchange, it estimates that around 30% of the undocumented population would sign up for this care, and the state would thus see an increase in $27.4 million of federal funds to cover this population. There would be an expected $14.8 million increase in general fund expenditures, so the state would have to outlay another $14.8 million in general fund expenditures. Almost all of it, though, would be offset by a reduced expenditure of $13.4 million due to the higher match that the federal government compensates for labor and delivery. So therefore, any additional state outlay would almost all be offset by reduced expenditures because the feds would pay more for labor and delivery as a result of enrollment in the CHIP program. So this is fiscally a sound policy that we have seen success in both rural and more urban states, red and blue states. It's estimated that undocumented residents in Maryland pay over $308 million in state and local taxes each year. These are Marylanders that are paying their share to the state coffers and yet not receiving benefits. Undocumented mothers and their babies face many unnecessary health risks during the newborn's first year and mom's postpartum period. We have a responsibility to provide them with comprehensive and affordable health coverage to help them better navigate the experience of having a child and produce better health outcomes for both. And in my opinion, immigration status should not be a barrier to anyone receiving life-saving health care. Also, as the proud father of a new 6-month-old, and I know our colleague here on the committee has a 6-day-old maybe, I think it is, we've seen the importance of having good prenatal care, and this bill will help expand that for women that need it as well. And with that, I'd like to thank my sponsor panelists who are here to testify today. We have Dr. Michelle LaRue from CASA, Dr. Monica Guerrero-Vasquez from Central Seoul, and Brian Sims from the Maryland Hospital Association. I'd also like to thank the committee for your consideration of this and urge for a favorable report on SB 778. Thank you.
Okay, thank you. I don't see any lights on, so you probably did a good job. All right, let's go to Dr. Michelle LaRue. It's on. You just pull it in front of you.
I thought the color changed. Madam Chair, members of the committee, my name is Michelle LaRue. I'm the Director of Health and Human Services at CASA. I'm here in support of SB 778. As you know, CASA is Maryland's largest immigrant advocacy and services organization, and I'm here today representing our over 120,000 Black and Brown community members, the majority of which are immigrants, undocumented, and uninsured. Unfortunately, our offices see pregnant members who are in need of care all the time. Annually, my department, the Health and Human Services Department, helps thousands of families and pregnant people navigate the Health and Human Services system. Again, most being undocumented, uninsured, and lacking access to care. Undocumented immigrants are excluded from Medicaid despite paying millions of dollars each year into federal, state, and local taxes. They suffer tremendously because of this. Often, undocumented expectant women see a doctor for the first time at the time of delivery, which leads to grave negative health outcomes. While community clinics and other programs are open to individuals regardless of their immigration status, they are often limited in scope and geography. Emergency Medicaid has long existed and is available to anyone regardless of immigration status. While it does currently cover labor and delivery for uninsured pregnant women, it does not cover prenatal care, which we know is vital to the health of both the baby and the mother. Not having access to prenatal care increases both infant mortality and maternal mortality. Unfortunately, thousands of mothers across the state who otherwise meet the income requirements for Medicaid are forced to risk their lives and the lives of their babies simply because they do not have immigration status and therefore lack access to prenatal care. Extending care to cover prenatal and postpartum periods dramatically increases the survival and prevents long-term complications for both the baby and the mother. Maryland is lagging behind other states that have already expanded Medicaid to pregnant residents across the country, including our neighbor Virginia. 17 states, 2 cities have already provided this coverage. CASA urges a favorable report for SB 778. Thank you.
Thank you. All right, let's go next to Dr. Monica Guerrero Vasquez.
Good afternoon, Madam Chair, members of the committee. My name is Monica Guerrero Vasquez, and I am here to represent Centro Sol, the Center for Health and Opportunities for Latinos at Johns Hopkins, where I serve as the executive director. Centro Sol is committed to promote equity in health and opportunities for our Latino community by developing community-centered programs and focus on physical health and mental health, as well as clinical innovations. Thank you for the opportunity to express our support to Bill 778. For the record, this testimony does not necessarily represent the views of Johns Hopkins University. Centro Sol serves thousands of children and their families. Just last week, I met 25 women, healthy, young, smiling, and very happy for their new children. Though none of them have received prenatal care until they had to deliver the baby. And they all shared that they had postpartum depression. They've never talked about it. Nobody knew what the postpartum depression was. They didn't understand what they were feeling other than the stigma and the shame of not being able to share that. They love their children, but they were asking, I didn't know why I feel that way. I didn't know why I feel this sad to not being able to enjoy my baby. Those with more than one child share that they only see the doctor every time they deliver a baby. As we already heard, lack of access to prenatal care is a risk factor for poor health outcomes by undocumented pregnant women and their babies, including higher rates of labor and delivery complications, and including, as I mentioned, postpartum depression for many who can be prevented and anticipated. This bill will require the Maryland Medical Assistance Program to provide comprehensive medical care for children and their mothers who may qualify for this program except for their immigration status. There is evidence that expanding access to prenatal care services will not only improve the health of the women, but also of their babies. To protect the present and the future of our communities, Centro Sol supports this bill and urges a favorable report on Bill 778. Thank you.
Thank you very much. Okay, we'll go next to Brian Sims.
Good afternoon, Madam Chair, Mr. Vice Chair, and committee members, and I want to thank you all for having me here today. My name is Brian Sims, Director of Quality and Health Improvement at the Maryland Hospital Association. And on behalf of our 60-member hospitals and health systems, we appreciate the opportunity to comment in support of Senate Bill 778. So this bill closes a long-existing gap for women who, based on their immigration status, are not able to access necessary prenatal and postpartum care. Maryland's statewide health integrated improvement strategy, which is a fundamental component of our total cost of care model, includes total population health goals, specifically addressing maternal and child health. Severe maternal morbidity includes complications such as heart attack, eclampsia, and sepsis, which are often unintended and often preventable outcomes of the process of labor and delivery. And these result in short-term and long-term consequences to a woman's health. The risk of these events can often be detected and reduced with comprehensive prenatal care, improving the chances of a healthy pregnancy. The extension of insurance coverage for postpartum care is in alignment with what is considered a fourth trimester approach to care. This individualized and woman-centered approach to follow-up care is critical for all women, but especially for those with pre-existing health conditions and social challenges, often evident in low-income and immigrant populations. Maryland's total cost of care model, which you all know is one of a kind here in the nation, relies on all folks who receive care in Maryland to have a healthy start to their lives. And so, excuse me, by expanding Medicaid coverage to include pregnant women regardless of immigration status, this bill will help ensure coverage for vital non-emergency services, thus increasing avoidance of severe maternal morbidity and promote a continuity of care. And so for these reasons, we urge a favorable report on Senate Bill 778. Thank you.
Thank you. All right, now we're going to the second panel. Dr. Folsky, you stated in the part of the second panel. Pam Kismeyer, then Martha, Shannon Wiley.
Madam Chair, Mr. Vice Chair, members of the committee, thank you very much. My name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in support of SB 778. You've already heard some of the reasons that why this bill was so important. I'll add just a few additional. This is a major benefit not only to the women and their babies who will obtain coverage, but also to the obstetricians, nurse midwives, and pediatricians who will be able to provide consistent preventive care. For instance, the patient population that will become eligible for insurance coverage under this bill has higher rates of gestational diabetes. Failure to diagnose and treat diabetes during pregnancy leads to higher cesarean section rates, which are more expensive and have higher complication rates for women than vaginal deliveries. In addition, babies born to moms with uncontrolled diabetes often have unstable blood sugars, requiring invasive treatment and more frequent admissions to neonatal intensive care units. Preterm birth rates are also higher for women who don't obtain prenatal care. A single preterm birth can cost the healthcare system hundreds of thousands of dollars. Children born prematurely are also more apt to have long-term health problems leading to, and also learning problems, cognitive problems that can lead to significant ongoing costs to Medicaid and to local school systems. SB 778 should decrease preterm births and associated costs. And I will point out that the fiscal note does not take these savings into account. When preventable high utilization costs are factored in, along with, as Senator Lamb mentioned, higher CMS reimbursements initiated under SB 778, it's likely this bill will actually reduce healthcare costs for Maryland taxpayers. And I will note that the House cross-file received a favorable vote in HGO subcommittee yesterday. In conclusion, SB 778 benefits pregnant women, their children, healthcare providers, and the overall healthcare system. For these reasons and more, the Maryland Association of County Health Officers requests a favorable report. Thank you very much.
Good afternoon, Madam Chairwoman and members of the committee, and thank you, Senator Lamb, for sponsoring this very important legislation. My name is Shannon Riley, and I am the population health nurse at Healthcare for the Homeless in Baltimore, where we strongly support SB 778, the Healthy Babies Equity Act. In addition to my current role, I am a nationally certified inpatient obstetrical nurse and worked in the hospital labor and delivery setting for the greater part of my 20-year nursing career. I also come with the support of our Maryland Sections Association of Women's Health, Obstetrical, and Neonatal Nursing. Reasons to ensure all those residing in our state have access to routine prenatal care services through insurance can be simplified to a few points. It saves money, it increases efficiency across the healthcare industry, and it saves lives, both in the short and long term, through routine preventive services, education, and support. In my current role, I follow our pregnant clients from the time we diagnose pregnancy and refer them to prenatal care services until the time it takes them to actually enter their first prenatal appointment. It frequently takes at least 2 months and up to 4 months to access those services, if they are accessed at all, after hurdling barriers such as complicated paperwork, proof of address, fear of stigma related to legal status in this country. That is a long time for missed health care in the dynamic and time-limited state of health that is pregnancy and the postpartum period. When prenatal care cannot be accessed or is accessed late, there are many missed opportunities to address health problems that can affect mothers and babies before the baby is born. I'm going to be short on time here, so because I don't want to repeat a lot of what's already been said, I do want to say that having spent a lot of time in labor and delivery, when women show up with no prenatal care services, it is an absolute scramble. It decreases patient safety across the board for everybody. We have to leave other patients' rooms in order to quickly try to assess and render life-saving care to people for whom we do not know their pregnancy history or the history of previous pregnancies and possible surgeries in other countries. Please support SB 778. Thank you.
All right, Pam, you want to go next?
Sure. Madam Chair, members of the committee, Pam Case-Mary here on behalf of the State Medical Society, the College of Obstetricians and Gynecologists, and the Maryland Academy of Pediatrics. You've heard a lot of testimony, and I'll even try to give you back a little bit of your time, but just a few things to reiterate. These women already have coverage for labor and delivery. You're wrapping around services that make those outcomes better. You all, in the past few years, unrelated to this bill and immigration status, have passed a number of initiatives from Maryland women that recognize that prenatal care services and postnatal care services to 1 year postpartum are critically important to the health of the women and their babies. And so the long-term effects that you have heard from the others before, long-term benefits from this, because they're going to have their labor and delivery covered. Well, if their labor and delivery is more successful, the costs are less, the outcomes are better, long-term, short-term to the system. And so this really is an expansion that benefits these women and their babies, but does really dramatically impact the benefit to the system and the long-term healthcare outcomes, which has long-term economic impact on the role of these individuals within our state.
Okay, thank you. All right, and we'll go finally to Vinnie.
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. First, again, as always, I thank you for the leadership you've given Maryland to become the 5th best state in the nation in healthcare, and we made so much progress, including last year's youth subsidies bill by Senator Feldman, 11,000 new young people enrolled. This is very exciting, but as you heard from Senator Lamb, who we thank so much for putting in this bill, other states are going ahead of us in helping undocumented immigrants get the health care that they need. We need to move into this area quickly. You heard so much about how important prenatal care is. 6% of births in Maryland are with kids where there was none or very little prenatal care. That's a lot of people, and it's almost surely going to be all people who are uninsured, many of them undocumented immigrants. We need to address that problem, and you could take a big step in going forward, again in Maryland, as you have in the past, by passing Senate Bill 778 and dealing with this problem. It helps the kids, it helps the parents, it helps all of us. We urge you to support Senate Bill 778. Our Full Health Care for All Coalition strongly supports this measure.
Thank you. All right, we've got the next panel consists of Andrea Agaloko. I might be screwing up your names, I hope not. Anna Rosas, Felix Hernandez, and Kaylee Schmitz. You have 2 minutes each, and the microphones are movable, so you can move them about. All right. You state your name and then give your testimony.
Madam Chair, Vice Chair, members of the committee, my name is Andrea Agalico. I'm a licensed clinical social worker at Mary Center. We have locations in Prince George's County and Montgomery County. We serve primarily an underinsured or uninsured population. I oversee the perinatal mental health program, so we focus on the prevention and treatment of perinatal mood and anxiety disorders, and I'm in strong support for SB 778. It's well documented that perinatal mood and anxiety disorders are the #1 complication of pregnancy and postpartum, affecting 1 in every 5 people. For people of color, that goes up to 2 in 5. And children born to mothers with untreated perinatal mental health concerns are at higher risk for low birth weight, preterm birth, longer NICU stays, impaired parent-child interactions, and behavioral, cognitive, and emotional delays. There's been longitudinal studies done that in adolescence, these children are at 50% risk of mental health concerns themselves. And we know that maternal stress has an impact on fetal brain development. We also know that perinatal mood and anxiety disorders are temporary and treatable, but we need to be screening for them. So we need to see people during pregnancy and during postpartum throughout that first year, so we can know what they're experiencing and get them the treatment that they need. I think it's wonderful that Maryland now has coverage for doula services and home visiting, because under Medicaid, these programs are now first-line supports in the prevention of PMADs. But the next step to support the perinatal population is to offer full medical coverage to undocumented pregnant people. Thank you.
Thank you. All right, we'll hear next from Ana Rosas.
Madam Chair and members of the committee, thank you for the
Pull
opportunity.
your mic a little closer to you, yes.
Sure. Thank you for the opportunity to speak today and for your attention to this important legislation. So my name is Ana Rosas. I am the Director of Operations at Mary Center, Adelphi, which is a federally qualified health center in Prince George's County and a constituent of District 19. Mary Center strongly supports Senate Bill 778. SB 778 will give thousands of women and children access to health care at critically important times in life during the prenatal and postpartum periods and during the early development period of a baby's first year. This will support our work at Mary Center, particularly at the clinic that I oversee in Prince George's County. Like many FQHCs, Mary Center connects participants to a wide range of healthcare and social services. We often care for the whole family. At Adelphi, we see approximately 8,600 participants annually, and pediatrics is our most utilized service line, followed by maternal health. A large portion of our participants are uninsured, and many are unable to access Medicaid because of federal and state policies related to immigration status. In 2020, nearly 40% of all of our participants seen at Adelphi were uninsured. This was largely driven by our maternal health population. A staggering 73% of these participants were uninsured. SB 778 will connect my participants to care that they desperately need and make it easier for our clinic to address our community's health and social needs. Maryland should join the 17 states that already provide coverage for pregnant women regardless of immigration status, including Virginia and the District of Columbia. I hope you will support this critical investment to address our community's health and social needs. Thank you for your commitment to improving healthcare access in Maryland and your efforts to improve maternal health outcomes for all residents.
Thank you. Senator Augustine.
Thank you, Madam Chair. This is a wonderful piece of legislation that we need to support, but I have to just really say thank you to Anna, because she's just an amazing person who cares for the folks in the district that I represent, my neighbors, and you just care so much for them, and you don't pay attention to whether or not they can pay or not. You just take care of our people. And so I'm really, really so grateful for the work of Mary Center and look forward to supporting the legislation. Thank you.
Thank you, Senator.
Okay, thank you. We'll go next to Felix Hernandez.
Good afternoon, members of the Finance Committee. Thank you for the opportunity to testify today. My name is Felix Hernandez, and I am a resident of Baltimore City and have lived in Maryland for about the last 20 years. In my current role, I strategize with teams to design and provide systems of support tailored to the needs of families navigating parenthood of children under 5. As you know, our undocumented neighbors, despite paying into federal and state taxes, contributing deeply to every facet of society, are ineligible for health care through Medicaid. Ineligibility for this program has left hundreds of thousands of families in Maryland uninsured, often facing extraordinary challenges to survive and thrive in this pandemic. I am here to express my support for Senate Bill 778 as the Healthy Children Equity Act as a first step to address this inequity. I have collaborated with expectant and parents to young children to plan, create, and access available resources to meet their life goals. We know that it is not easy for families to parent, all while trying to live and grieve through the death in the wake of COVID-19. The home visiting strategy works to support families through the challenges they face on the journey of parenthood and I'll share that in the time I've worked between DC and Maryland, most, if not all, of the families I've supported in Maryland have had to overcome more barriers to locate and access resources that increase the protective factors of their family, the same protective factors that help prevent child abuse and neglect. Further, I've worked with families who, after realizing the number of resources available in DC, decided to relocate there because there were truly no other options. Maryland's lack of material resource and support to the vulnerable communities that reside here forces families to make difficult decisions. Providing these communities with excellent access to prenatal, delivery, and postpartum care will help us preserve and protect the lives of parents and their children. Please support SB 778. Thank you.
Thank you. And now we'll hear from Kaylee Schmitz.
Thank you, Madam Chair, Mr. Vice Chair, members of the committee, and thank you to Senator Lamb for introducing this legislation. My name is Callie Schmitz. I'm with the Maryland Center on Economic Policy, and we're here in support of Senate Bill 778 because it is better for all Maryland families and communities if every pregnant person in the state can get the health care that they and their baby needs. Lack of access to care has significant costs in dollars as well as lives. Research shows that racial and other kinds of disparities in healthcare lead to approximately $93 billion a year in excess medical care costs nationwide, plus billions in additional costs related to lost productivity and premature death. Expanding access to care for pregnant people and babies would be a huge step forward in addressing racial and ethnic disparities in health outcomes. Undocumented immigrants are the largest group still locked out of affordable health coverage in Maryland. Evidence links Medicaid access during pregnancy to, as others have stated, lower maternal mortality, healthier birth weight, and fewer pregnancy and birth complications. In the short term, this means less uncompensated care costs at hospitals that ultimately affects healthcare costs for all of us. And looking at the longer term, the big picture, healthier Marylanders have lower medical costs, lose fewer work days to illness, while research shows that children who face health problems early on in life have a harder time succeeding in school and later on in the workforce. Senate Bill 778 will help move us towards a healthier Maryland. So we would ask for a favorable report. Thank you.
And thank you very much. All right, thanks to this entire panel. You're making us a little smarter. Okay, we next will hear from Robin Elliott, Laura Atwood, and Abdi Abdullahi. You have 2 minutes each, and the microphones are movable.
Good afternoon, or almost good evening. I will be very brief. I appreciate everyone's time. Robin Elliott, and I am here today on behalf of a number of clients, and I think that speaks for itself. The Maryland Nurses Association, the American College of Nurse Midwives, the Maryland Occupational Therapy Association, and I'll just note it's really important for prenatal care for the health of the newborn and the babies, and that's why occupational therapists are so committed. The Maryland Dental Action Coalition, thanks to you all, Maryland Medicaid covers dental for pregnant individuals and postpartum. The Maryland Community Health System, which is a network of FQHCs, Movable Feast, and then the Licensed Clinical Professional Counselors of Maryland. We heard the prior panelists talk about the importance of coverage to ensure the behavioral health well-being of new moms and their babies. So thank you very much. Would appreciate a favorable report.
Thank you. Okay.
Hello, Chair Kelly and members of the Senate Finance Committee. My name is Laura Atwood. I've lived in Maryland since 1999, and I'm representing Tacoma Park Mobilization, which has over 2,500 people. We are in support of the Healthy Babies Equity Act. I'm also testifying as an individual who does volunteer work in immigrant communities and as a healthcare employee who's so often struck by how many devastating health problems could be prevented. I'd like to share a personal story with a happy ending, an ending we have the power to give to more people, and an ending that should be the norm. A while back, I accompanied a young woman, I'll call Maria, to a 5-month ultrasound appointment at a clinic. It was her first prenatal test, and a volunteer organization, an offshoot of Tacoma Park Mobilization, covered the cost through donations. This is very rare. She had entered the country pregnant and with a toddler, and she didn't ever talk about her past. In chatting while I was driving there, she asked if I have kids, and I mentioned my then 18-year-old daughter and told a bit about what she was doing. Maria said softly, "I'm also 18," and we were quiet. Fast forward, she went for continued prenatal appointments, and the baby was found to be low weight with concerns of maternal malnutrition. People rallied around Maria. She gained weight and started just looking better, and she gave birth with her landlady by her side. I was honored to be invited to the baby's first birthday barbecue. Maria and her sons now have a supportive community. The 2 kids are healthy and very cute. She has a steady restaurant job and loving babysitter. Through coincidence, to get this time-sensitive support, plus her own pretty remarkable survival skills, she and her sons are now doing really well. Too many of her counterparts don't stumble upon the scarce but needed support in healthcare. The support needs to be at a systems level. With this bill, we can make it happen. Tacoma Park Mobilization therefore urges a favorable report on SB 778. Thank you for your time.
Thank you.
Hello, Madam Chair and members of the Senate Finance Committee. My name is Abdi Abdullahi. I'm a Baltimore City resident, a medical student, and a public health scholar at Johns Hopkins. I'm here in strong support of Senate Bill 778. I'd like to start with a short story that encapsulates why Maryland needs to follow in the footsteps of the 17 other states that have enacted similar policies to expand prenatal and postpartum care. During my time on the obstetric service, we received a notification that a woman was being emergently transported to our service. Now, the birth process should be a celebratory and joyful occasion. It's a moment where a new light is brought into this world. However, without access to prenatal care, that light might be snuffed out before it ever has the opportunity to shine. Now, this family was not celebrating. They were greeted with excess bleeding after birth, a condition known as postpartum hemorrhage. There are several risk factors associated with postpartum hemorrhage, risk factors that can be identified and appropriately managed with prenatal care. But in Maryland, we're currently denying that critical care to thousands of undocumented pregnant Marylanders. That needs to change. I'd like to reiterate something that you've heard several times tonight. This is a fiscally sound policy. For every one state dollar we spend, we get $2 from the federal government. And for that $1 we do spend, we get the majority of it back because of the higher federal match rate for the CHIP program in comparison to emergency Medicaid. There's a reason why states from California to Texas and Tennessee have passed similar legislation, and it's time Maryland follows suit. I'd like to close with this. The legacy of this bill, the Healthy Babies Equity Act, is a legacy that represents Maryland's commitment to the health and well-being of all pregnant Marylanders and their babies. I therefore urge a favorable report. Thank you.
Thank you very much. Okay, we have a final panel on this bill. Reagan Vaughn, Yanaldis Bolan, Juliana Valencia Banks, and Nellie Campos. If you would all come up, you have 2 minutes each, and the microphones are movable. Okay, who'd like to go first?
Good afternoon, Madam Chair and members of the committee. My name is Regan Vaughn. I'm the Director of Advocacy for Catholic Charities of Baltimore, here today in strong support of SB 778. I don't have much more to add on the benefits of this bill. You've heard it from everyone who's gone before me. I just want to add to the chorus asking for your support for this bill. We operate the Esperanza Center Health Clinic in Baltimore City in the Fells Point neighborhood. And often it's our clinicians who are sharing the hopefully good news that a woman is pregnant. But then we have our case coordinator work with them to try to find coverage and services because we can't offer prenatal care. And even for someone who it is her job to find services, it is a difficult process, especially financially. Even with sliding scales, a lot of our clients cannot afford it. And so echoing the comments before me, I just want to stress on this International Women's Day, it is a good bill for women, it is a good bill for babies, it is good fiscal policy, and we would urge this committee to support SB 778. Thank you.
Okay, thank you very much. Who's going next?
Good afternoon. My name is Juliana Valencia Banks. I have the privilege of serving as Baltimore County's first Immigration Affairs Outreach Coordinator. Thank you, Chair Kelly, Vice Chair Feldman, and members of the Finance Committee for allowing me to testify in favor of SB 778 on behalf of County Executive John Olszewski Jr. During the 4 months that I have had the honor to serve Baltimore County's immigrant community, their most frequently raised concern is access to affordable health care, particularly prenatal care. The COVID-19 pandemic disproportionately affected immigrant communities, highlighting the health inequities many continue to face. Undocumented Americans are less likely to have access to health insurance than native-born people. While slightly more than half of U.S. families obtain health insurance via their employer, many new Americans are segregated into jobs and industries less likely to afford employer-sponsored coverage. Moreover, immigrant workers are also more likely to have lower incomes. As a result, they are often priced out of insurance. Expanding eligibility for prenatal care through Medicaid to all pregnant people, regardless of their immigration status, would protect mothers and their children through Maryland. Baltimore County is home to more than 105,000 new Americans that contribute every day to the richness of our county. All children, regardless of their parents' immigration status, deserve to grow up to be healthy, productive members of society. Prenatal and postpartum care are transformative, especially in communities of color. Children deserve parents whose only concern is their child's welfare, not their ability to access critical health care that will ensure long, healthy lives for their children. It is therefore that I urge a favorable report for SB 778, promoting equity in health care for children and their mothers. Thank you.
Thank you. All right, who wants to be next?
Buenas tardes, legisladores. Mi nombre es Nelly Campos. Hoy estoy aquí porque creo que todas las madres embarazadas deberían tener atención médica. Soy miembro de casa, residente del condado de Howard y una inmigrante indocumentada de El Salvador. También soy trabajadora esencial, pero lo más importante es que soy madre y abuela. Estoy muy bendecida de tener hijas preciosas. Yo me fui de El Salvador y vine a los Estados Unidos por ellas. Una de mis hijas recientemente estuvo embarazada. Yo la cuidé y le ayudé durante su embarazo, ya que vivió su embarazo sin seguro médico. Madres como yo y mi hija, que somos indocumentadas y no elegibles para Medicaid, luchamos mucho por no tener el cuidado médico que necesitamos. Yo vi a mi hija durante su embarazo ir de clínica en clínica para poder recibir un poco de cuidado. Ella pudo ver a un doctor solo un par de veces antes de dar a luz y eso a mí me daba miedo. Me preocupaba su salud y la salud de mi nieto. Es un milagro que su embarazo haya resultado bien. Gracias a Dios que mi embarazo, el de mi hija, están bien. Pero no todas tenemos la misma fortuna. Los dos están saludables, pero mujeres indocumentadas como yo están perdiendo a sus hijos, se están muriendo ellas, están sufriendo de complicaciones severas. Esto está pasando todos los días en mi comunidad. está sufriendo. Legisladores, les pido que piensen en mí y en las miles de madres y familias como la mía. Mis hijos y mis nietos, nuestros estatus migratorios no significa que no tengamos derecho a un doctor. Por favor, apoyen estas leyes para proteger a las madres y a los bebés. Gracias.
Thank you.
I'm going to translate. My name is Viviana Lozano, and I'm a community organizer from Casa. Good afternoon, ladies. My name is Nelly Campos. I am here today because I believe that all pregnant mothers should have health care. I am a Casa member. I am a resident of Howard County. I am an undocumented immigrant from El Salvador. I am a social worker, but most important, I am a mother and a grandmother. I am blessed to have many beautiful daughters. I fled El Salvador to come to the U.S. for them. One of my daughters recently got pregnant. I watched her and helped her through her pregnancy. She went through with no health care because undocumented mothers like me and my daughter are not eligible to Medicaid. We struggle a lot with getting the care we need. I watched my daughter during her pregnancy go from clinic to get care. She only got to see a doctor a few times before her delivery. I was scared. I was worried about her health and the health of my grandchild. It's a miracle that the pregnancy went smoothly. Thanks to God, my pregnancy and my daughter's pregnancy were good, but not all had the same fortune. Both of them are okay, but the undocumented women like me are losing their children, dying themselves, and suffering from several complications. It happens every day. My community is suffering. Legislators, I ask that you please think of me and think of the thousands of mothers and families like me, my kids and my grandkids. Our immigration status doesn't mean that we don't deserve a right to a doctor. Please support this bill to keep mothers and babies safe. Thank you.
Thank you. All right. That's the end of this panel, I believe. Everybody got to testify. Okay. Thank you very much. Okay. All right. Now we're coming up on our last bill, but we got a lot of persons waiting to be heard. Senator Hoff. Okay, so he has a family emergency, so his staff person is testifying on his behalf.
Yes. Thank you, Madam Chair. Senator Huff apologizes. He had a family emergency and had to leave. But for the record, my name is Stephen Clark, Chief of Staff to Senator Huff. I am here today to introduce Senate Bill 807, which would establish an assistant outpatient treatment pilot program in Frederick County. Unfortunately, Senator Huff found out about this issue firsthand when he had a family member who experienced serious mental health issues and his family was unable to get them help. What you will find out when you try to get someone help is that it is very difficult to have someone involuntarily committed. We lack mental health beds, and the best you often get is a hospital to hold them for a day or two until they are stabilized and released right back onto the streets. In the mid-1960s, the deinstitutionalization movement gained support and many mental hospitals were closed. A number of past practices and institutions did abuse patients and violate civil liberties. Unfortunately, in my opinion, we overcorrected, and now we are left with a system where we lack adequate mental health care. And those who are seriously ill are left to be treated at jails, emergency rooms, or simply die in the streets. This is not a resource issue. It is an issue of our laws. Maryland is one of only 3 states in the nation without an assistant outpatient treatment law. An assistant outpatient treatment is less severe than involuntary commitment, which is difficult to obtain in Maryland. AOT is the delivery of outpatient treatment under a civil court order to a small, vulnerable subset of individuals with severe mental illness, such as schizophrenia or bipolar disorder, with a history of inconsistent or no engagement with treatment. This is often due to diminished awareness of the need for treatment, which may result from the illness itself. Participants must be likely to deteriorate and become a danger to their life or the safety of themselves or others. They have been often caught in a cycle of repeat ER and hospital stays, homelessness, and incarcerations. This legislation has clear safeguards to protect due process, which is very important to Senator Huff. Senate Bill 807 is required to find, by clear and convincing evidence, a very high evidentiary standard, that the respondent has a mental disorder and without treatment presents a danger to themselves or others. Once admitted into assisted outpatient treatment, the respondent will enter court-ordered treatment that will help them get better without forcing them to be institutionalized against their will. The respondent would also have an attorney present, and with the amendments, will be afforded a public defender if they cannot afford an attorney. The pilot program is not reinventing the wheel. AOT has existed for decades in most states, and there is significant data demonstrating its effectiveness. It has reduced hospitalizations, arrest, incarceration, homelessness, violence, and victimization between 74% and 87% for individuals in the program. Programs repeatedly report net savings per person from 40 to 50%, savings that can be reinvested to improve mental health services for all. It is past time we join the 47 other states that have an assisted outpatient treatment program. This is a pilot program that will be a small step legislatively, but hopefully begin to address the mental health crisis in our state. I have asked the advocates for this bill to work with the judiciary on amendments to address their concerns. I ask for a favorable report for Senate Bill 807. Thank you.
Thank you very much. Okay, we're going next to the following panel. It's Brian Staton, Evelyn Burton, and Mariah Cyphers. You have 2 minutes each, so you can all come up to the table. The microphones are movable. All right, you may go in whatever order. Just state your name and you have 2 minutes. Do you need a mic?
Good afternoon. I'm Evelyn Burton, the Volunteer Advocacy Chair for Schizophrenia and Psychosis Action Alliance, a family organization. I am here to plead for the lives of our sons, daughters, fathers, and mothers who are in hospitals, jails, and under bridges because they were too ill with serious mental illness to accept voluntary outpatient services, which is all Maryland offers. Unlike 47 other states, Maryland instead offers only jail or the streets, not treatment with AOT. We should call it what it is, discrimination. It is neither civil nor right. No one in this room is seeking to deny civil rights, but there is much misunderstanding about severe mental illness. When I say to my loved one, "How are you?" and she replies, "What is it like to be pink lemonade?" is that exercising freedom of speech? Consistent treatment with AOT can restore the ability to exercise your rights. She refused outpatient voluntary treatment, including ACT teams. Without medication, as an outpatient, she ended up having 12 hospitalizations last year and 18 ER visits, spending more time in restrictive hospitalization than in the community. You may hear stories from the opponents about forced treatment, and please remember that forced medication and forced treatment in Maryland only can occur inside a hospital. It has never and cannot be done as an outpatient or an AOT. So I want to just conclude by asking you, please ask yourself if it's your son or daughter and you have a choice of letting them live on the street, eating out of garbage cans, being raped in jail, in and out of hospitals, or offering them life-saving treatment under AOT, what would you choose? Thank you.
Thank you very much. All right, who'd like to go next?
I'll go
and
next.
The mics are movable.
Good afternoon, Madam Chair and members of the committee. I'm Maura Cyphers. With Compass Government Relations, I'm here on behalf of the National Alliance on Mental Illness, NAMI Maryland, in support of Senate Bill 807. This legislation, as you've heard, would establish a pilot program for assisted outpatient treatment in Frederick County, Maryland. NAMI's here in support today because we know when AOT is done right, it works. If carefully implemented, as in New York State, AOT improves mental health outcomes. It reduces costly and harmful consequences, lack of treatment, like hospitalizations, homelessness, and arrests. Careful implementation looks a lot like what we're already trying to expand on in terms of community-based services, assertive community treatment, supported housing, mental health and substance use treatment. These are services that many with mental health issues need. They're also what recipients of AOT need. This overlap in community-based mental health supports stimulates the development of a more comprehensive system of care, where others, not subject to AOT, but needing comparable levels of services, see the benefit and are not displaced. This pilot should be implemented with the goal of helping people take more active roles in their own care. It should include peer supports, supported decision-making, and other methods to engage people actively and participate in their own care. You're going to hear from opponents that AOT does not work, that it unfairly puts people at the front of the line. They may see things like coercive. It is not forced treatment. This pilot would help Frederick County engage the most vulnerable among us by committing the system to our people and not the other way around. Systemic indifference of the mental health system would not be tolerated with the treatment of other conditions. People with other serious illnesses like cancer or heart disease are treated with respect and care. They and their families are supported in their care and recovery. As you've heard today, we're asking for your help and your support on this bill. Thank you.
Thank you. Do you know how Senator Hoff plans to fund the bill? Have you looked at the fiscal note? Is it the county government or who is doing it?
It's my understanding.
From what I understand from the head of the Core Service Agency there, she basically feels she has enough money in her budget to cover it. The fiscal note was very low, and she didn't see a problem with it.
Okay, thank you. All right, and then we're going next to Brian Stetton.
Yes. Good afternoon, Madam Chair. Thank you, members of the committee. My name is Brian Stetton. I'm the policy director for a national organization called the Treatment Advocacy Center. We work to remove barriers to the treatment of severe mental illness, and I'd like to take my time today to put some of the opposition to this bill that you're going to hear momentarily into some context. You know, opponents seem to start with the assumption that AOT is a form of coercion, that it's forced treatment, as they call it. They seem to envision a judge wagging a finger at a person and trying to get them to adhere to treatment through negative reinforcement, that person's fear of some bad consequence that's going to occur if they don't do what the judge has directed. And I want to tell you, I travel all over the United States to set these programs up and work with judges and treatment systems to collaborate and stand this model up. And if I believed for a minute that that's what this was about, I would be on their side. Not only would that be unconstitutional, it wouldn't work. The whole reason this remains controversial is because of this mistaken assumption as to what we're trying to accomplish. And I get it. We are, after all, talking about a court order, which people normally associate with scariness, right? There's this fear of contempt of court if you don't do what the court has said, and you could be in trouble. This bill takes that off the table, just like all our great AOT laws around the country. You can't be held in contempt of court. So you may wonder, what is the point of a court order if it doesn't have those quote-unquote teeth attached to it? The points are as follows. First of all, we are trying to get a person's attention through the solemnity, the seriousness of a court process, the sense that when a judge is in your life, it has more impact on you than just being told by your mom or your doctor for the millionth time what you need to do. It's also about impressing upon the person that it's a mutual commitment, that they have a right to expect great treatment, and that the court is going to hold the treatment system to its end of the bargain too, through these repeated check-ins that take place during the period of the order. So this is really a feel-good program. When I sit in courtrooms and watch this in action, you get a lump in your throat. This is not about hurting anybody or scaring anybody, and I hope that I'll have more opportunity to give you a sense of what AOT is in reality, rather than some of the myths that have been perpetrated. Thank you.
All right, thank you. Senator Feldman has a question.
Yeah, just very briefly, because we went right to AOT, and I have to be honest with you, I have no idea how that, how that process works. So just to finish off, you wanted to add a little, can you just give me sort of some basics about the AOT process or how it even works?
Sure, absolutely, and I appreciate the opportunity to do that. So the criteria in this bill are different than the criteria for what it takes to put someone in a hospital, right? The criteria there are about a person being in a crisis at that moment. That's why they need hospital care. Here we are not looking at a person's condition at this moment, so much as we're looking at what their history tells us is likely to happen to them if they're left to their own devices. So it's about a person's history of becoming dangerous as a result of non-adherence to treatment. The point at which we typically apply this is when a person is actually stable, doing well, coming out of the hospital. This is a petition that's usually filed upon a person's discharge from an inpatient stay, where there's been a recognition this is a person who's kind of trapped in the revolving door, and the treatment system itself brings this petition to the court and says this outpatient treatment plan that we would have developed for this person anyway, hopefully and ideally, where we're attaching all these community-based services, we'd also like to layer a court order and the court's monitoring and supervision on top of that, based on the fact that this person meets these criteria in that they've been trapped in this revolving door.
Thank you.
So that's when we have the hearing.
Gotcha, okay,
Yeah.
thank you, sir.
Thank you. All right, we're going to go to a new panel at this time. Marilyn Martin, Christina Rolfes, and Cornelius Kutesa. All right, you each have 2 minutes, and the mics are movable. State your name and go ahead.
Good afternoon. My name's Marilyn Martin. I have a 39-year-old son who was diagnosed with schizophrenia in 2008. He's been hospitalized at least 18 times since he was 15. That's a lot of hospitalizations. One of the worst periods was the 2 years preceding his psychosis-induced assault upon my then 71-year-old spouse. AOT would have been enormously helpful in preventing his decline. My son had never been violent prior to this. This episode was precipitated by a provider change at his clinic. When he showed up one day to get his monthly medication injection, he refused it because it was somebody different. So I learned later that the only medication he would agree to take was one that he'd previously taken that had stopped working, which led to his hospitalization, where he was put on Invega and then had monthly shots. Instead, my son deteriorated so much that he assaulted my husband, who ended up on the floor, bloodied from head wounds and traumatized. My son now has a criminal conviction. Only after committing a crime could my son get court-ordered outpatient service. Statistics from other states show that the program works well and that there is a black robe effect that influences the patients. Tristan received 3 years of probation and is now stuck with a criminal record. The state of Maryland compounded this unfair situation by passing legislation that requires a 15-year waiting period before any expungement can be attempted. I highly doubt that I'll still be around in 2034 to try to get his record expunged. So he has stayed medicated since then, but I sincerely feel that assisted outpatient treatment, that a program like that would have achieved the same outcome much more compassionately than the criminal justice system.
Thank you very much.
Can I just wrap up by pointing out?
We really have a number of other people. and
Okay,
we
I just
have
wanted to point out that it
keep
saves
everybody-
money,
Yeah,
because
okay.
this is the Finance Committee.
Yeah, other witnesses tell
It
us.
saves on police, incarceration, judicial
Okay.
systems, and hospitalizations.
Okay. Christina Rolfes.
Good afternoon. My name is Christina Rolfes. If assisted outpatient treatment had been available for my brother, it could have averted tragedy for my family. And if AOT were implemented today in Frederick County, it could save my ill nephew. My brother, who had schizophrenia, was once a promising student and ambitious young man. Then he suddenly dropped out of college, could not hold a job, and began experiencing bizarre delusions and auditory hallucinations, My parents took him to a psychiatrist, but he refused any medication or further visits. Untreated, he deteriorated, and during a delusional episode, he violently attacked my father, leaving him with a severe brain injury. My brother was charged with attempted murder and spent 3 years in a locked psychiatric hospital where he finally received treatment and realized the horror of what had happened. Once released, he was connected to community services, maintained medication compliance, and lived a productive life, including working and volunteering to help others with mental illness. But he lived with guilt the rest of his life, and my father was left permanently disabled and could no longer work. Now, my nephew, who is 20 and lives in Frederick with my 74-year-old mother, is showing signs of psychosis. He's unable to hold a job, has delusions, has been suicidal, and has shown signs of violence. He's been hospitalized several times. He's in the hospital right now, as a matter of fact, but he will not take medication or see a psychiatrist. I believe the AOT pilot program could help him live a happy and productive life. Without it, the likely outcomes are an early death, jail, harm to my mother or someone else, or lifelong suffering. Please, I urge you to support this bill. My nephew's life depends on it. Thank you.
Thank you. All right, and you're next, sir.
Good afternoon. My name is Cornelius. I'm a senior care coordinator at Help in the Home. It's an agency located in Rockville, Maryland. We support individuals struggling with severe mental illness. I want to bring to light the dire need for state legislation, or State Bill 807. Some of our clients lack the capacity to recognize their illness and to process reality, which causes them to refuse or to avoid voluntary treatment. And as a result, they end up suffering the consequences of no treatment, including hospitalizations, homelessness, incarcerations, and other consequences resulting from aggressive and violent behaviors. One client with schizophrenia, who I'll call John, was involuntarily hospitalized 12 times in 4 years. After each hospitalization, he stopped outpatient treatment and the cycle repeated. He was arrested once and kicked out of 3 apartments for property damage and disturbances. The homeless shelter banned him because he threw a knife that fortunately embedded in the wall behind his human target. Only by chance has John not harmed or killed anyone yet. Others without AOT to stabilize them in the community suffer similar consequences. Please consider the current high cost of to our state without AOT as a result of repeated ambulance, ER, crisis services, hospitalizations, police, court, jail, and homeless services. Please protect us all by actively supporting statewide AOT legislation and implementation. Thank you.
Thank you. All right. We're going next to 2 persons who are favorable with amendments. Amanda Woodward and Charles Richardson. Or you have 2 minutes each.
I'll go ahead. My name is Charles Richardson, Dr. Richardson. I recently retired from the state of Maryland and Spring Grove Hospital. Over the 32 years of my work at Spring Grove, the frequency of criminal court-ordered admissions grew from a relative minority to the current state where fully 100% of patients admitted to Spring Grove and the other state facilities come directly from detention centers burdened with criminal charges. I saw far too many patients whose untreated illnesses generated behavior in the community that prompted arrests rather than treatment, which led to prolonged admissions where their biggest impediment to discharge was not their illness, but their legal entanglements. This is clear evidence of a systemic failure that cries out for solutions. I believe that assisted outpatient treatment would be one really quite modest intervention that might help to reverse this trend. An underappreciated fact about psychosis is a condition known as anosognosia. It's the inability to perceive the presence of an illness. This is not at all the same as psychological denial. Rather, it's a perceptual cognitive deficit that's a result of a neurobiological illness. It undermines a person's capacity to make informed decisions about their treatment and leads directly to treatment non-adherence, clinical deterioration, and psychosis. The vast majority of people with psychosis they truly suffer from their symptoms, and they suffer more if untreated symptoms lead to arrests, incarceration, and prolonged inpatient treatment. Assisted outpatient treatment is a proven method of intensifying treatment of severe mental illness for those who are unable to recognize their need for treatment. It would address the need for sustained treatment, which is so often necessary for a patient to achieve optimal response and to improve judgment, such that they are able to exercise good judgment and decision-making regarding their treatment. It would make families feel more secure in allowing their loved ones to reside at home. It would do so without requiring the patients to reside in a locked facility. It would reassure local police that troublesome behavior is being addressed in such a way as to ensure community safety. It would provide a mechanism for civil court-mandated treatment rather than the more punitive and expensive criminal court-ordered treatment. I'm respectfully asking you to support Senate Bill 807. Thank you.
Thank you. All right, and now Amanda Woodward.
Good afternoon to members of the Senate Finance Committee. My name is Amanda Woodward, and I'm a registered nurse with 24 years of experience in acute care psychiatry, emergency medicine, and the criminal justice system. Over the course of my career, I have witnessed lives wasted and families torn apart by serious mental illness. I've seen the same SMI individuals repeatedly cycling through the jail that I worked at, the ER, and the psychiatric unit. Had I worked with the police, I might have seen them dead or homeless. I am convinced that had my patients had a supportive AOT program, their outcomes would have been much better. As a psychiatric nurse, I witnessed some patients cycle through on a regular basis, having discontinued their medication, which is extremely common. They have a condition known as anosognosia, which means they don't understand or can't appreciate the fact that their brain is ill. And they don't take medication because nor would I if I did not think I was ill. In the emergency department, I saw psychiatric patients wait for days for an inpatient bed. And that was a particularly bad place for anyone with mental illness to stay for days. An ER is a very hectic situation, and the psychotic individuals do not do well there. And the staff is also they're not great, honestly, with the mentally ill. In the jail setting, I saw psychotic individuals repeatedly arrested instead of hospitalization. I realized when I worked at the jail that it was a matter of luck as to whether they were hospitalized or incarcerated. Implementation of AOT will stop the downstream problems we see today, making the effort worthwhile. In addition, studies have shown state expenditures on these current issues would dramatically decrease. These could, in turn, cover the cost for widespread implementation and upstream solutions.
Thank you very much. Okay, now we have 7 additional witnesses. I'm going to call the first 4 of them: Katie Rouse, Dan Martin, Adrian Brittenstein, and Mary Buckley. These are all unfavorable. You may decide in what order you'd like to go. The microphones are movable. State your name, and you have 2 minutes each.
Thank you so much, Chair Celli, Vice Chair Feldman, committee members, good evening. We really appreciate the opportunity to be heard on this bill. I'm Katie Rouse. I'm the Executive Director of Honor of Maryland. We're a peer-run education and advocacy organization, and for over 30 years, our network across the state has proven that peer support works, that choice is the foundation of recovery, and that everyone can make their own way forward in wellness. We strongly oppose the forced outpatient treatment program in this Senate Bill 807. We know that the intention of this bill is to connect people to services, but its methods are problems, not solutions. Instead of removing barriers to accessing care, it adds a complicated process that frankly is fraught with very serious logistical and ethical concerns. Instead of lifting up the community programs that are already working well to build trusting relationships with folks with significant behavioral health challenges like assertive community treatment, peer support, or respite houses, which my friend Mary will talk about in a moment, this program doubles down on force, which we know creates fear and trauma and distrust. In our written testimony, we share stories from 3 peers who went looking for support when they were in crisis from loved ones and providers, and instead they were restrained, drugged, humiliated, isolated. Their stories are not uncommon, and those scars last a lifetime, and sometimes they never fully heal. When we talk about a lack of insight when AOT, the insight that we see most lacking is that what looks like resistance or noncompliance or lack of ability is often after a bad experience when someone was in crisis and how they were treated. Or it comes from being cut out from decision-making about your own life, sometimes for years. Being ignored and disrespected, being disbelieved or stigmatized, being forced into treatment that you didn't choose, or maybe weren't even involved with the discussion about whether or not it was going to work for you. All of that isn't treatment, it's mistreatment. It makes mental health worse, not better. It damages your self-worth, and with it, your capacity for self-care, self-help, and self-growth. My time is up, so I'll conclude my remarks.
Thank you. You can just move the mic along. Yes.
Thank you, committee. I'm Mary Buckley. Thank you, committee members, for giving me the opportunity to speak with you today. I was very touched by Katie's speech. It speaks to my experience having had forced treatment by my family for many, many years of my life. And when I was 32 years old, my first hospitalization took place simply because behavior my family interpreted as odd due to extreme sleep deprivation. I was so traumatized.
Push your mic a little closer to your mouth.
Oh, I'm sorry. Okay. When I was 32 years old, my first hospitalization took place simply because of behavior my family interpreted as odd. I was so traumatized by that they took me to hospitalization that was very abusive. I was in 4 points. I was in seclusion, and my only thing I did wrong was feed my hungry daughter at 2 a.m. in the morning because they were being neglected. I was so traumatized by that hospitalization that I was in and out of psych wards for almost 25 years. I was always med compliant. I exhibited serious odd but harmless behaviors due to the trauma of the first hospitalization, which was dehumanizing to say the least. I recently had the maturity to go to a respite house before the hospital, before I felt I needed that for our hospitalization. I was able to heal there. It has a family atmosphere. It is the perfect balance between structure and freedom. You have your own room. And always have loving people, including staff, to talk to. We eat dinner as a family. I can't say enough good things about the place. I finally found peace and healing. My depression and anxiety are slowly improving, and I am on the right combination of meds. I urge you to listen to my story and vote against Senate Bill 807.
Thank you. All right. Who wants to go next?
I'll go. Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland, here in opposition to Senate Bill 807. And I wanted to start by saying I really do feel for the families that have already spoken. I'm a family member, too, of someone with a serious mental illness, so I really do know what they're going through. But I just have to say that not all family members support this approach. I'm going to talk really briefly about AOT generally, then just highlight some of the big concerns with this bill specifically. So many states allow for some form of mandatory community treatment. It comes in 3 kind of distinct categories: as a less restrictive alternative to inpatient commitment for somebody that's already met the inpatient standard, as a condition of release from inpatient commitment for someone that's already met the inpatient standard, and then there's this bill where a person who has never met and doesn't currently meet the inpatient commitment criteria is court-ordered into treatment anyway to prevent them from meeting that criteria in the future. And while you've heard from the proponents that Maryland is sorely out of touch because we don't have AOT, the truth is that less than half the states allow this incredibly coercive model. And of those that do, even fewer actually use it for a lot of different reasons. It results in queue jumping, where people who don't want treatment are forced ahead of those who do. There are serious racial disparities in states that have implemented it, with Black individuals disproportionately court-ordered into treatment. There are multiple systemic reviews showing AOT is not nearly as effective as its proponents claim. And I could go on, and all of this is covered in more detail in my written testimony, but since I only have a few seconds left, I'll talk specifically about some of the bill specifics. So this bill would allow a petition for AOT to be made by any individual with a legitimate interest in the person. And so how will that be determined? How can we make sure that that's not used in bad faith? The eligibility criteria is incredibly broad and subjective. It would allow a court to order into treatment someone who is living safely in the community, has never refused treatment, and has never been hospitalized or incarcerated. No objective criteria. If the person doesn't get a final say in regarding their treatment plan, even if they've executed a mental health advance directive, which we're always encouraging in this state, those wishes don't need to be honored if the psychiatrist considers them, quote, contrary to their best interests. And so, why would people fill out an advance directive if the psychiatrist can just overrule their wishes? And I could go on and on and on, but my time's up.
Give us a couple more concerns.
A couple more concerns. The bill would allow a psychiatrist to affirm an individual meets the criteria for AOT without ever having seen the person at all. And then just there's annual reporting requirements at the end, that reporting back to the legislature, but nothing, on who's in AOT and on how much they're adhering to AOT. And then I think the sponsor amendments say, reduction in hospitalizations and things like that. But nothing about whether the people on AOT symptoms are improving, nothing about what's their experience with the program, their satisfaction level, nothing like that. So again, there are a lot of really, really specific concerns about this bill in particular, and I'd urge an unfavorable report.
Okay. All right.
Good afternoon, members of the committee. I'm Adrienne Bridenstine with Behavioral Health System Baltimore. We're a nonprofit in Baltimore City that serves as a local behavioral health authority. Not normally would we weigh in on a Frederick County bill, but this bill, as Dan outlined, is in such conflict with the outpatient civil commitment pilot program that we are already implementing in Baltimore City, and we think it's a pilot program that if Frederick County wants to move forward with, they could build off of what we've been doing in Baltimore City, because we've learned a lot over the past several years of implementing this program. This pilot program was designed specifically to help people who have not been well served by the public behavioral health system. Those are people who typically end up in our jails and prisons because they have the severe mental illness. It takes a very person-centered approach, does not use the courts to order people to treatment. It's very person-centered. What makes this program particularly unique and effective is its use of peers that you heard Katie talk about earlier. The peers that are involved with the outpatient civil commitment pilot program will meet with people while they are in the hospital, before they're even discharged from the hospital, and work with them to develop what their treatment plan is. Rather than, and the peers will also continue to meet with people upon their discharge and make sure they're connected to the program. So that regular check-in happens with the peers as opposed to having that happen with a judge or a court. It's way more effective, and we know that. We've known from lessons learned of implementing this program for the past several years that the peers are what makes this program particularly effective, because they're the ones that are on the ground making sure that people get to those outpatient appointments. They're talking to them about treatment adherence, about the importance of taking medication, using their own lived experience to make that compelling argument to people. This pilot program in Baltimore City is intentionally small, but it has been growing over the years. 80% of the people who have been served have completed the program, which is a 6-month period of time, and they stay connected to care afterwards. We've gradually been expanding the eligibility over time with the support of this committee. Thank you, Senator Augustine, for your help over the years. And we're looking to do that again. We have been stalled, though. So not surprisingly by the Maryland Department of Health, not moving some regulatory changes forward that would gradually expand the eligibility for the program. So we urge an unfavorable report of this bill and would rather see us expand the existing outpatient civil commitment pilot program that already exists in our state.
Okay, thank you. All right, we have 3 additional people we haven't heard from, and so Karen Foxman, Keith Lodrich, and Carol McCabe. All right, the microphones are movable. State your name, and you have 2 minutes each.
Good evening, Madam Chairwoman and members of the Senate Finance Committee. My name is Karen Foxman, and I am a managing attorney at Disability Rights Maryland, the federally mandated program in the state that protects the rights of individuals with disabilities. And our goal is to ensure that individuals with disabilities live free from abuse and neglect and live productive lives in the community. My team advocates for individuals with mental illness who are receiving inpatient treatment in facilities and community mental health programs and who are at risk of abuse, neglect, and rights violations. I am asking the committee to issue an unfavorable report for this bill because it would deny individuals with psychiatric disabilities the opportunity to be active participants in their treatment and would violate their constitutional rights to live in the community free from coercive treatment. In 1999, the U.S. Supreme Court held in Olmstead v. LC that individuals with disabilities have a right to live in the most integrated setting in the community that is appropriate to their needs. This panel should note that Senate Bill 807 proposes to restrict the freedom of individuals with mental illness who are residing in the community. It creates an extremely low bar for requiring someone to participate in the program and creates a situation where someone could be involuntarily hospitalized if they don't comply with the program. The United States Supreme Court has held that states have no constitutional basis for limiting the liberty interests of persons involuntarily if they are dangerous to no one and can safely live in freedom. The same principles apply to the court's commitment of individuals with coercive mental health treatment. This bill will chip away those rights. Supreme Court has made very clear that individuals' rights to refuse medication is a protective liberty interest, and that if someone refuses to comply with this program, they could be involuntarily hospitalized based purely on a subjective standard of future risk of psychiatric deterioration. I would also like to point your attention to advance directives. May I continue?
Well, you can wrap up quickly.
Thank you. This bill basically says that if a psychiatrist feels that an individual's advance directive is not in their best interest, then they can override that. And this flies in the face of the purpose of advance directives and is a violation of an individual's right to bodily integrity and to choose their own treatment plan.
Thank you.
Thank you.
All right. Who's going next? Okay.
Good evening. My name's Carol McCabe. I am the chief of the Mental Health Division in the Public Defender's Office. We represent clients at involuntary inpatient commitment cases in more than 30 hospitals around the state. And in 2020, we represented clients in just over 9,600 involuntary inpatient commitment cases. The House version of this bill has been amended to include the Public Defender's Office as legal counsel for the individuals subject to involuntary outpatient commitment under this pilot project. And I understand from testimony that there's some intention to also amend the Senate bill to include the Public Defender's Office as the legal service providers under this program. Our written testimony was supplied to the ACLU. They reviewed it. They are going to sign on to our written testimony, and they support our opposition to this bill. The right to bodily integrity and the right to refuse medical treatment is among the most fundamental of our constitutional rights. The Supreme Court, and most recently the state of Maryland about 4 months ago, in an opinion called Mercer versus the Finance Center, hold that an individual has a constitutionally protected liberty interest in being free from forced psychiatric treatment. Forced outpatient psychiatric treatment, which is what this bill does, is a significant deprivation of liberty that implicates constitutional rights. This bill violates an individual participant's constitutional rights in a number of ways. This bill also invites malicious abuse of the involuntary outpatient commitment process. The vague standard and the lack of constitutional protections in this bill make it easier for the kinds of malicious abuse the attorneys in my division see in the inpatient cases, involuntary inpatient cases we represent around the state. And just quickly, we see these abuses particularly in cases where individuals are involved in divorce and custody disputes where there's spousal abuse occurring, And in cases where one family member may be trying to get money from another family member, they abuse this process, this commitment process. And SB 807 is just ripe for that type of abuse. Thank you.
Okay.
Good evening, Madam Chair. Members, it's late. I'll try to be brief. My name is Keith Lottridge. I'm the Deputy Public Defender for the state of Maryland. The reason I'm here is because of the amendment, which basically implicates my office. Essentially, in the House, and I believe here in the Senate, there's an effort to change our statute where we would be required to represent the people affected by this bill. I adopt everything Ms. McCabe just said about the legal problems with this bill, but let me tell you about my agency's problem with this bill. We are historically understaffed. Ms. McCabe is the chief of our mental health division. She has 8 attorneys, actually it could be 10 attorneys. They handled, as you heard, 9,600 civil commitments. They are also responsible for 33 hospitals. This bill gives us no funding, it gives us no attorneys. Let me put it this way. Will, can, should. It's not that when it comes to will, it's not that we will or won't. That's not the issue. If you pass a law, we'll do what we can. It's a matter of can we? We cannot. We do not have the staff. We do not have the resources to represent these people. The final thing is, should we? The answer is somebody should represent these people. This is a serious deprivation of liberty. A judge comes in and says, you will do this. Take medication, go to treatment. Somebody should be there saying, wait, they have a right to be heard. My office can't do it. We don't have the resources. Somebody should. This bill, as constructed, is problematic. I will tell you this, that if we were the ones to be representing people, every single case would be a constitutional case. Every single case. We'd bring in experts, we'd challenge it. This is essentially the Minority Report. A person's going to be forced into treatment because of what might happen. Thank you.
Okay, I think you've been very clear. If no other questions, then you are our final witness on our final bill for this afternoon, and thank you very much to everybody.